Paninu and okay. Because speaks good. Oh my God. Oh no. Because Lama.
A very good morning to one and all. After finishing our day one, we have gathered here for a day two of our PG training program. The first session for today is Mood Disorders, Effects of Comorbidity on Diagnosis and Management by Dr. M.S. Reddy. To chair this session, I would invite Dr. Ashok Reddy K and Dr. Anita onto the dais. Dr. Ashok Reddy is a professor and HOD psychiatry at SVS Medical College, Mehboob Nagar. He worked as assistant professor, associate professor, and professor of psychiatry, Usmania Medical College, Hyderabad. He is a founder director of Government Medical College, Mehboob Nagar. Dr. Anita Rai Rala is a professor of psychiatry, Institute of Mental Health, Hyderabad, has 14 years of teaching experience, recipient of Podubu Ramama Chinna Reddy Gold Medal Award for award paper in consultant category for the year 2018 and 2022. Her areas of interest are forensic psychiatry and neuropsychiatry. Welcome, ma'am. I would now request our chairpersons to invite a speaker and do the further proceedings.
I invite Dr. M.S. Reddy garu to come on to the dais, please.
Thank you. Thank you.
Very good morning to all the delegates, the organizers, and the faculty here. The second day of the program, we are starting with the very good program, but unfortunately the audience are very less, but we imagine that some of them are online, then we'll go ahead with this. So the first session is on mood disorders, effects of comorbidity on the diagnosis and the management. The commonest psychiatric problems what we deal in our practice is mood disorders only. Depression being the commonest, then comes the bipolar disorder. And today we have the well-known person, a very good speaker from Hyderabad, who is organizing so many programs on bipolar disorder, is authority in bipolar disorder in India, in fact. And we know that there are comorbidities like alcohol use. Substance use disorder is the most common comorbid condition when we consider the mood disorders. And we have several other mood disorders. Probably Dr. M.S. Reddy is going to detail all of them. Going into the finer details, he's going to educate us about all these things. I request Dr. Anita to introduce the speaker.
In fact, sir doesn't need any introduction, but still for the sake of formality, sir is a director of Asha Hospital, director Asha Bipolar Clinic, past president of Indian Association of Private Psychiatry, council member of Asian Network of Bipolar Disorders, council member of Asian Association of Neuropsychopharmacology, member of the editorial board of World Journal of Biological Psychiatry. Sir takes us into any topic with these, starting from spirituality or any biological basis of bipolar disorder. Sir delves into any topic with so much of ease. So we are very eager, sir, to hear to you. Over to the speaker.
Thanks. Good morning. Morning to you all. I thank the organizers for giving me this opportunity. Maybe I think I look this side and then talk more, maybe expecting that there are more virtual audience here rather than looking at this side. I understand that. We are all students, So 8 o'clock to start a program is not going to be that easy thing. So, but at least I see some people here with whom I can communicate. So definitely. Thank you very much, Dr. Gauri. Thank you very much, the EC of South Zone. Today the topic is going to be mood disorders and comorbidity. The whole of yesterday, most of you would have heard about comorbidity, this term maybe more than 1,000 times, and that there have been a lot of explanations in that. Today, I am going to talk very specifically. I think the organizers are very kind to giving me mood disorders and comorbidity rather than saying bipolar disorders and then comorbidity. There is a huge difference there. Broadly, you may say that, oh, it's the same thing, but there is definitely a difference which I am going to. Second thing is, I don't think I will be talking about very individually comorbid, this condition, that condition, how do you treat, because broadly there is not much of a difference which I will deal with. Comorbidity as a treatment is one. Second thing is diagnostic implications, sometimes whether there will be a problem, which I will be dealing a little bit at length, because that's one of the topics which is close to my heart and then which I am more and more worried about, especially in the diagnosis and management of bipolar disorders. Right, I'll start my talk today with this slide, which is in the Bipolar Disorders 2019, where this particular article clearly shows that are we doing a little bit overdoing with the concept of comorbidity. The concept of comorbidity has been expanded. So here if you look at any distinct entity which has either existed or going to be, it's like depression, existence OCD, or later he develops OCD. Depression, OCD, or later he has a panic disorder. It's something like that. Then only according to this 1970, so that is what this definition, according to that it goes, and it's fairly clear cut and then very conservative. But DSM system since 1980, any symptoms, suppose somebody has a major depressive disorder, the presence of one or two OC symptoms automatically is branded as a comorbidity. That is where it says that there is a pseudo problem of many comorbidities. I don't know, some of you must, every I think a decade or half a decade, NIH conducts a survey, National Comorbidity Survey. Long time back, I read one of the papers, Kessler's paper, 98% of patients with bipolar disorder have comorbidity. Oh my God, then where is this now, like a single entity? Diabetes can have a comorbidity of hypertension, but 98% of people having that, are we overdoing it? That is where it starts with. I conservatively put it as between 50 to 90%. I am going to talk about only psychological comorbidity, because physical comorbidity, there is a paper in the afternoon and they are going to talk about. And I am also not talking about psychological therapies, but mostly on the pharmacotherapy I am talking about. So if you look at it, the most common comorbidity is anxiety disorders. I think all of you know that. It's a generalized anxiety, panic disorder, and then associated social anxiety, and then OCD. This is one of the nightmares to have the comorbidity, especially in one component of the mood disorder. So what I thought today is that I will not go into all the details about all the comorbid conditions, but select a few where it can be very specific. One is OCD, impulse control disorders, which I am going to almost now, like in synonymous with personality disorders, I am going to talk about. These are the ones I am going to highlight. Then substance use disorders. Yesterday there was a good topic there. What is the title of the topic? The cause or effect of. So that itself shows that, because they know is that when we talk about comorbidity, you are talking about one entity plus comorbidity. But the moment they say that cause or effect, sometimes the substance use itself is an effect of secondary to the whatever the disorder. It can be schizophrenia, it can be mood disorder. So that concept which I am going to highlight today in later part of my talk, so it's going to be mostly on OCD and then personal disorders, which I am going to talk about. Mood disorders. Broadly, we all know that mood disorders two. One is depressive disorder, second thing is bipolar disorders. Right. The whole lot of difference comes in this. Suppose I listed the whole lot of comorbidity, anxiety disorders, OCD, impulse control, eating, and cognitive disorders, personality. If it is depressive disorders, let me just briefly run through. MDD with anxiety, MDD with panic disorder, MDD with social anxiety, MDD with OCD, MDD with substance abuse. What is the treatment? Not much. MDD with anxiety, you give SSRI and then done with. OCD, you done with. Substance abuse, okay, you give some anti-craving and then done with it. Impulse control, right, you add some like anti-convulsant, some of the people add, I don't add that, go ahead with that. There is no problem. It's like treating diabetes and hypertension. You treat diabetes, and you also treat hypertension. Only thing is make sure that there is not much of a drug interaction, which here we don't have a problem at all. Psychiatry, the beauty of it is that you give SSRI, the whole spectrum of disorders, it works well. So hardly anything when it comes to the depressive disorders, whatever may be the depression, RDD, psychotic, melancholia, with anxiety, without anxiety, anything, there is no problem. But the biggest problem comes when you talk about bipolar disorders. It's a block. Mania with OCD. Oh God, what do we do? The easiest answer is CBT. Whenever I ask, like not many people here, all of them would have said, we do CBT for OCD, and then like that. Then it goes, my talk goes into a different direction. Fortunately, not many are there in that. MDD with panic disorder, mania with panic disorder. Mania with all that you give SSRIs, which strictly they say that antidepressants as much as possible, as far as possible, as long as possible, avoid that. Now, how do we deal with? That is exactly the problem when it comes to bipolar disorder. And then when we talk about MDD, most of us deal with the present episode. The first episode of MDD, even second episode, you don't look at long-term prophylaxis. But when it is bipolar disorder, it's prophylaxis from day one. The dictum, we may question it, but as on today, for the postgraduate, the dictum is that when you go to the exam and ask, how do you manage the bipolar disorder? The first thing is prophylaxis long-term. So-called, I'm trying to avoid the term mood stabilization, but mood stabilization, that's it. You can't have any other answer. But you have so much of problems when you come to the comorbidity. That is where the problem is going to be. That is where I said that I'll try to focus mainly on OCD and then the personal disorders. Diagnostic challenges. We are all clinicians. The most important thing, but psychiatrists, we getting away. Whether you diagnose MDD or panic or OCD, treatment is the same. But diagnosis is an everyday moment of truth. We have a CT surgeon sitting in front of us here. The most important thing is diagnosis. Once you make a diagnosis, treatment protocols automatically follow. That's the everyday moment of truth. We have to make. Maybe 40 years back, 50 years back, we all said psychosis, neurosis, cello. No, it's not going to be. No longer it's going to be. Maybe the number of categories may come down, but it's going to be the most important thing. And this is one which maybe I'll talk about it in a bit more in detail. Diagnose indicates prognosis. Why is diagnosis important? I think all of you know that. Suppose it's OCD is the diagnosis. You're going to tell you, you'll become better, you'll become much better, you'll become far, far better. Will I become all right, doctor? You'll become much better. Lot of improvement can be there, you can function. Will I completely recover, doctor? Let us see, ma. We'll wait. We don't say that we are conveying. Suppose it's a clear recurrent depression, third episode. Will I become doctor? All right. Absolutely. Even before he says, I'll tell him, you're going to be all right. Give me 2 months' time. I may give you SSRI, I may give you CT, I may give latest RTMS. Patient is going to. So diagnose indicates prognosis, which is very, very important. For the patient, this is most important. They are not bothered about your diagnosis. They are bothered about where I am going to become. And then obviously therapeutics. Definitely what you are going to be based on that. Management challenges. Diagnostic challenges I'll complete later. Management challenges. Pharmacotherapy, as I told that I'm going to talk mostly about pharmacotherapy only. ECT. Again, now I'll come to that OCD. Suppose you have a patient where you have on one side major depressive disorder, melancholia or psychosis, comorbid OCD. You have OCD, both. Suppose your diagnosis MDD with comorbid OCD. ECT may not be of much. Suppose it's a primarily MDD, OCD is only a secondary, ECT helps. I'm sorry, I think the first one I didn't say that. OCD with MDD, ECT is not your primary line of treatment. So that is where even the subtle it may look, that may be the differences there, right? Now ECT is not indicated, but now suppose it's a OCD with depressive symptoms, I may straight away say that why don't you go for a deep TMS, which is fairly indicated. The same thing, ECT may not be indicated in OCD. Psychological therapies, we all know that CBT or now like counseling or now supportive therapies, reassurance, we all know about it. So the next one is, here what I thought is, when you have a patient with the depressive symptoms and also obsessive compulsive symptoms, the symptoms are both obsessive symptoms and also depression symptoms. How do we look at it? Number one, the way how we have to look at it concept wise. Diagnosis of MDD, diagnosis of OCD. Two different entities which satisfy DSM-5 criteria for two different diagnostic entities. So the treatment, you treat MDD, you treat OCD. Fortunately, or whatever it is, it's only SSRI, so we don't have no problem. The second is, primary diagnosis MDD, major depressive disorder only, depression, but OC symptoms as a significant component. Every patient with depression need not have OC symptoms. So here, how will be our treatment? Primarily MDD. You treat the depression, OC symptoms automatically have to subside because it's only a clinical variant. Then why I said this is that, suppose you may ask me what is the difference? You said MDD, OCD, MDD with OC symptoms. What is the difference? If you ask me, the first category, I will look at improvement of MDD, but OCD symptoms, I will leave it like that. He may not completely recover. Suppose this is the diagnosis for the patient, MDD with OC, I will do whatever I can. I'll increase it to 60 milligrams of escitalopram, I'll give him ECT, I'll add augmentation, I'll add supportive, maybe lithium, maybe thyroid. I want to see that MDD recovers, so OC symptoms recover. For an youngster, what's the difference? Both are the same symptoms. But my therapeutic approach, I'll go to any length because MDD is something which I can make the patient recover, which is not the case when OCD is. I'm not painting a very negativistic picture about OCD, but we know that it's a little bit difficult problem. This is something which we have to. Sometimes patient has a personality trait. We all know that. That's one of the important areas where we need to know about the premorbid personality. Premorbid personality traits which do not create any kind of a clinical problem, but when you have a diagnostic entity, the entire personality traits gets exacerbated. OCPD, he has been managing quite well with this. He develops depression, the presenting symptoms can be OC symptoms rather than MDD. Here again, once you are very clear about it, your primary target of treatment is going to be MDD, you can aim at recovery. That is what I am saying that. Condition 3, you can aim at recovery because it's MDD. 2, you can aim at recovery because it's MDD. The 1, you can component of MDD you can, but OCD, you have to live with a part of it a little bit. That's what the most important difference. This is another one. Primarily it's OCD. Almost all of us, now every patient with OCD will have some depressive component because they live with the most distressing condition in psychiatry, if you ask me, it's OCD. Schizophrenia, blissfully, fortunately, they don't have much insight into their problem. Schizophrenia is a problem for the caregivers and relatives. Psychosis is a problem for the caregivers. But OCD, every moment, he knows that he doesn't have to wash for 20 times. He doesn't have to check for 30 times. He knows it's ridiculous, it is silly, it's nonsense. Doesn't have to do. He can't help because it produces tremendous kind of uneasiness and anxiety. He is aware of it. He is full insight, but he can't help. Imagine the situation, and they are living with this for umpteen years, and with the family member saying that can't you control, can't you manage, can't you stop it, why are you doing it? You are doing it in my house only, you don't do it in when you go to plaza. This is a common question. So mostly they go into the secondary depression. So when somebody has depressive features, OCD features, if you can look at these 3-4 different concepts, you will have a clarity about the prognosis. You will know how aggressively you have to treat. You will know whether you can use ECT or you have to go for RTMS or less dose of antidepressants, or can you have to go up to higher dose of antidepressants. All you have to. Right, this is a nightmare. PD and OCD, all of you know that. All right. Secondary to depression, here also the problem. You just see that OC symptoms, secondary to MDD, job there is no problem at all. But suppose it's a bipolar condition. In the depressive episode, there are OC symptoms, it's a double whammy. OCD, the only treatment is SSRI, and they say no antidepressants. The quetiapine may not work for your, olanzapine may not work for OCD. How do you deal with it? Now you know, some of you who are here who have been listening to me, why I keep talking so much about the diagnostic issues. We are over-diagnosing bipolar disorder. The next 10 minutes of my talk is going to be on that. If it is a simple case of MDD, your treatment is so very definite. If you diagnose bipolar 2, the dictum, textbooks, papers, everybody says that don't give antidepressants or make it as a last, or give a minimal dose, or give for the short duration, or the minimal dose for minimum duration for. It's nice to talk about it, but when it comes to the clinic, what is the minimal dose? What is the minimal duration? We have a trouble on that. So that is a nightmare here. That is where if your diagnosis is this, that's where I said the diagnosis becomes most important when it comes to mood disorders. This is another beautiful thing. Sometimes we see that you have OCD symptoms, but during the manic phase, they disappear. It's beautiful to, someday I think we will learn what is the neurobiology behind that. How does it happen? It will be wonderful to know how does a manic switch completely disappears, obsessive compulsive symptoms. But as on today, it's good they don't have, otherwise it will become a big problem for me. The management is that. Yeah, this I don't think I can talk about. Patient is mania is also keeping washing the hands 20 times. I don't know what to deal with like. I don't think manic patient will be even cooperative for your CBT also. That's it's going to be a big problem. And most of the times it's the OCD which starts earlier. OCD starts around second decade, 13, 14 years. Mood disorders come a bit late. The one question which always keeps bothering me is that, do you call this OCD with bipolar, or because you go by the hierarchy and say that bipolar with OCD? This is always one problem which keeps, that's okay, that's only semantic, nothing more than that. And from here, yeah, this is one. That's why I showed very clearly. If it is MDD, this SSRI should have been in the top. CanMed says depression, SSRI comes way down here. This is what I have been talking about. You have to try all these things before you treat depression, whether you have OCD or not in bipolar disorder. Right, this is about the irritability. I think I'll just skip this. Yeah. Now the next 10 minutes I'll be talking about. Till now I talked about concentrated mainly on OCD and then mood disorders. What are the therapeutic implications? What are the prognostic implications? How confident we can be? How shaky we can be? How difficulty we can be in the management? Now in this part of it, let me go into the diagnostic problems. Here, let me clarify. The theme of the conference is comorbidity. That is, one diagnosis is established, second comes as this. It's very clear, I think, for the postgraduates. Schizophrenia is established, and then anxiety, OCD, substance abuse. Right? Diabetes is established and then hypertension, MI. So here mood disorder is established and then you talk about other. But I'm slightly altering here because psychiatry is not like diagnosis of diabetes. Diabetes 300 blood sugar is diabetes. Schizophrenia we diagnose, sometimes we are not very sure. Bipolar we diagnose, lot of times I am not sure about the diagnosis of bipolar. So even the primary diagnosis when it comes to question, that's why yesterday's topic, substance use disorders, is it the cause or effect? And today we have, I think today or yesterday, anxiety disorder, is it a spectrum or comorbidity? If it is strictly going by the definition, those two topics would not have been there at all. So that is why today, the next few minutes I will be talking about how a comorbid personality disorder or a symptom of irritability is creating confusion in the diagnosis, because of which the entire treatment changes. Simply if you look at it, I think all of us know bipolar disorder, the DSM-5 criteria, there are two. One is elation, second is irritability. This is a pediatric bipolar, it's a long, almost about 15 years back story, not like in the paper. USA, if you take elation as the symptom, the concordance, USA and like UK is 96% there, 86%. If a patient is presenting with symptom of elation, expansive mood, whether the patient is seen by a US psychiatrist or UK psychiatrist, the concordance is about 80%. But we have the second symptom, irritability. The patient presenting with irritability, if you present to somebody in US, it is 88%, it is 31%. What is the validity of this criteria, irritability? What is the reliability of this criteria? That I think we need to understand this. That is why I put this slide, and then that is where the irritability becomes one of the major issues. Now, I suddenly switching from mania to mood disorders to borderline. If you remember, I said that OCD, irritability, personality disorders. One of my favorite point is personality disorders in the differential diagnosis of bipolar disorders. For me, it's a perfect oxymoron. Bipolar disorders is a clear-cut episodic illness where recovery has to be. Personality disorders, you start somewhere and you end your life there. That is what the concept is. How can these two come into the differential diagnosis of it? But the thought is that we are having the problem in this. One of the, I just look at the borderline personality disorder. I'm mainly looking at affective instability. Is it a symptom of bipolar disorder? Like mood swings and all that. This is what borderline personality disorder, affective dysregulation, behavioral, and then what are the symptoms? Impulsive control disorder and then suicidal. Now, this is the core symptom. Here I am looking at the diagnostic problems you have when you talk about mood disorder and you have the symptom of affective instability. Dysphoric, irritable, rage, impulsive, suicidal, all these can be symptoms of mood disorder, bipolar disorder rather. He has depression, he has rage, he has irritability, and this can be the presentation of bipolar disorder, which is mainly a symptom of or like in the cluster of affective instability rather than any specific diagnosis. It's only a dimension. It can be in bipolar disorder, impulse control, personality, all this it can be seen. Now I am looking at a patient. Let's see, maybe one more slide on the borderline personality disorder. Some of you may be wondering why personality disorder is brought here. If you look at the borderline personality disorder, 1% of the community bipolar is also same. 75% have self-harm. And you look at this, major depression almost 50 to 60%. So it's almost similar to the kind of presentation of bipolar disorder where borderline personality is coming up at that age, dysphoric mood, irritable, swings, affective instability, we are talking about the whole lot of picture. This is the problem. Its euphoria is not seen. Next slide I will show that what is the difference, mood swings of any duration. And I was talking about the overdiagnosis of bipolar disorder, pardon me, Here in the comorbidity, I am questioning my own diagnosis of mood disorder, bipolar disorder here. To look at it, there is a famous statement. Clinicians receive a continuous stream claims of bipolar spectrum. Borderline personality disorders are being diagnosed as bipolar disorders. See, the two conditions coexist. On one side, maybe something similar to mood disorder, and you also have a borderline personality disorder where the symptoms are almost like swinging between both. How to differentiate? That's where the diagnostic problem is. So why do you have to differentiate? My entire therapeutics depend on what the diagnosis I make, primary diagnosis and the comorbidity. That becomes a very, very important. If you remember correct, the moment you say bipolar disorder, automatically mood stabilization, prophylaxis. How long prophylaxis? What's going to be your answer? Yeah, President of IPS Telangana said lifelong. And one of my standard things I keep, who's life doctor? The patient asked me. I don't know, who's life doctor? A young fellow at 19 years or 20 years comes with the diagnosis of mania and you tell him that prophylaxis, how long? If you say 2 years, examiner will ask you, why 2 years? Who told you 5 years? So the best answer is lifelong. Examiners don't open their mouth. That's it. That's the best answer. So that is what I am looking at. And imagine, next slide, I wrongly diagnose a youngster who comes to me with so-called affective instability. Diagnostic mistakes is a birthright of every physician. So you make a wrong diagnosis and suggest him go for mood stabilization. And imagine that fellow is one of the nice guys listening to the doctor. Very good complaints. What's going to happen to him? This is the danger. That's where the diagnostic problems, when we look at the comorbidity I'm talking about, last for a few hours. How many of us are seriously trying to make a difference? The moment you say that, I'll just run through one case story also, which I have copied from the textbook. Sometime back I presented also. Lasts for a few days. But for us it says that at least it has to be a duration of 1 week mania diagnosis. Euphoria is never seen. It's okay. DSM-5 says irritability is fine. No problem. You'll have to add one more. And this is environmentally driven. This is one of the major differentiating factors which we have to seriously look into. Alright, this is what I am talking about. Pharmacotherapy of mood stabilization in patients with borderline personality disorder. The difference between BD and BP, BD is bipolar disorder, BP is borderline personality disorder. Of course, the deadly thing is you have both BD and BPD. I get lost sometimes. A lot of times I do mistakes. I have done mistakes. Reversal of the diagnosis, and then I go back and then go back having a little bit of problem. That's why in comorbidity I am talking so much stress on this today. Right. Anyway, any questions here? Right, I'll put a, yeah, Manoj, go. Obviously.
I read her OC, she becomes manic, hypomanic, and she enjoys that. The family is troubled. Very difficult.
Yeah, absolutely. Mania is a problem for the relatives. Depression is a problem with the patient. None of your manics walk into the room and say, the doctor, I have mania, please treat me. No, sir. Then what the hell? I am happy, man. I am very happy. One of my frequently asked questions in bipolar disorder, a patient is happy. Why do you want to treat psychiatrist? That is what the journalist asked me. This is what your like a colleagues ask you. He's happy. He's doing good. He talks so nicely. He talks so relevant. Of course, he has got plans to become prime minister. What's wrong in that? What's wrong in that, man? He wants to become, like maybe. So they'll ask, what is this? So mania, you give a choice. Nobody wants to be treated for mania. That is why we become the biggest villains there. I am happy you put me in the hospital. What is this, doctor? So this is a everyday problem that is. No, I was talking about personality disorders. Mood disorder, bipolar disorder is a mood disorder. It has to have episodes, it has to have recovery, and then that episodes. Personality disorder, it's a continuous illness. If you call it as a personality disorder as an illness, everybody agrees. Is there going to be a remission? Is there going to be recovery from personality disorder? At least one of you, yesterday Nayak Street was asking how many of you are successful like that. I will ask, how many of you say that personal disorders people can recover? That's what I am taught. That's what the textbook said. తెలుగులో ఒక సామెత ఉంది, తెలుగు ఎంతమంది తెలుస్తుంది, పుట్టుకతో వచ్చింది పుడకలతో కానీ పోదు అని. And you are born with this and it ends with a graveyard and you are in a fire. That's what is personal disorder. But to my surprise, borderline personality disorders, I am quoting from Psychiatric Clinics of North America 2018. This is a learning for me. I was digging more and more into borderline personality disorders. What is this? Where am I going? Why is this happening? I'll tell you the implications of it. Most patients experience a remission. It's a 10 to 20 year follow-up study. It's not 1 or 2 years follow-up study. Lanarins, one of the famous studies. 50% achieved remission. JF is 70. Global assessment of function. A kind of burnout by middle age. Positive prognostic outlook in a patient with borderline personality disorder. Now, I'll give you a scenario. Patient came to me at 20. He is actually borderline personality disorder. I diagnosed him as bipolar disorder. Put him on mood stabilizer, valproate. Let's see that. For a period of years, 10 years, 15 years, patient is totally recovered. He doesn't have mood swings. He doesn't have affective instability. He is doing good. So what is my conclusion? My valproate is doing wonders, man, here. It's such an excellent mood stabilizer. It's such an excellent prophylactic drug. It has given the patient total relief from his underlying bipolar disorder. But you know what I am doing? I made a wrong diagnosis of bipolar disorder. I've given valproate to a patient with a borderline personality disorder who otherwise would have had a natural recovery remission according to this particular paper. I just want you to understand that concept of it, where we can go once in a while wrong. That is why the whole concept of last 10 minutes I was talking about borderline personality disorder and this. Of late we see lots of borderline personality disorders. Every second day you see a patient with so much of instability, with a neat cuts here, unstable relationships. Two characteristics: deliberate self-harm, unstable relationship. We see very commonly. Youngsters, bipolar spectrum, bipolar NOS, they are going it as bipolar disorders and then being diagnosed, and the whole process goes in a different line. Please be aware of it. I am not asking you to accept my argument or my whatever the kind of thing. Please look at it as a different possibility, different perspective. That's the only request to all the postgraduates here. This is what happened in borderline personality disorder. Now, the point here is that only one thing I want to talk about. This is from the STEP BD. The age of onset of bipolar disorder, you see this starting from the age of 2 years, man. Bipolar disorder diagnosis, suppose you take this as a cutoff point, age of 10 years. Before the age of 10 years, there is a significant group of 30% or 40% are children being diagnosed as bipolar disorder. You may ask me, so what? Disorder exists. What's the point in? My question is, does the disorder exist? Are we over-diagnosing so-called personality problems or childhood adjustment problems as bipolar disorder? Then important question comes, Dr. Reddy, you're talking about personality disorders and you're talking about children of this age, below the age of 18 years, can you diagnose personality disorder? That's one major point. But this book, Psychiatric Clinic, says that now the age limit is being reduced. You can diagnose sometimes personality disorders even below the age of 18. This is what in my clinic, what I show in ABC here. Here, you see that it starts at 12. Grossly, there are two things. Either I am under-diagnosing pediatric bipolar disorder, or STEP BD is over-diagnosing bipolar disorder. STEP BD is Gary Sachs, one of the major studies in bipolar disorders. But I leave it to you. This Next 5 minutes, I'm going to wind up. This is one case report. Like you can just run through the matter there. I've just copied and pasted from a textbook on pediatric bipolar disorders, childhood bipolar disorders. If this is what the textbooks are telling me, I'll leave it to your judgment and then like a conclusion later. Is a case report. I'll just highlight that you can run through this. 80-year-old girl, stepfather lives with her biological mother and stepfather. So there is a childhood trauma. Parents are already divorced, biological mother and right. This 80-year-old girl is the patient. Mother describes rages during which angry, breaks what she is doing. 80-year-old child broke all the keys. These episodes occur 3 times per week and can last a few minutes to hour. Grumpy moods, rages since the age of 2 years. What are the highlighted red color shows that? Number 1, rages last for few minutes to hour, and also the grumpy mood. Are we talking about affective instability there? Irritable, rages, and also grumpy mood downs. But the duration, you look at it, few minutes to 1 hour. DSM-5 does not. The DSM-5 insists on 1 week. Then I question, if the childhood bipolar disorder is different, let DSM come out with a different criteria for childhood bipolar disorder. It lasts for only few hours. Suppose I put it, suppose I am sitting in that side of the presenting, I would have said, oh, what's the problem, Ms. Reddy? This is ultra-DIAN, rapid cycling ultra-DIAN bipolar disorder. It closes it. Rapid cycler, 1 day, 2 days, much more than DIAN, ultra-DIAN. Out. I can't open my mouth. But now I can look at this. Few minutes to hours, any child, young child, parents are divorced, living with a biological mother and then a group of other, like a stepfather and then a group. This is what the child goes into. Periods of sad mood last for about 20 minutes. Oh God. Morning I came here at 7:30 thinking that all of you postgraduates are going to be here at 8. 8 o'clock, me and then some other organized. 8:05, 8:10. Don't you think I was feeling sad? What, Ms. Reddy, you have become like that. Nobody bothers about your talk is there or not. I become such a like an useless speaker. Don't you think I was feeling a little bit sad? Then I got a coffee. I stimulated myself. 20 minutes of feeling dull. Nobody is there in the hall. Nobody is there in the hall. Now, don't you think I feel slightly better? Okay, at least I can see some people here. Oh my God, 20 minutes of sadness and 20 minutes of this, you're going to diagnose me as a mood swings or affective instability. Oh God, it's a bit too much, man. Half a day average. Read the whole thing. No energy, moves and talks in slow motion. Now I am walking a little bit fast. Morning you should have seen me in that 20 minutes. I was not even moving. I was sitting there like that. Does not feel like eating. With all this information about depressed mood, sad mood is different. Depression, you are giving almost a diagnostic color you are giving. Manic episodes, where are the manic episodes, man? Where is the euphoria here? We can be fairly confident in diagnosis of bipolar disorder, not otherwise specified. This is from the textbook. I did not change a single word. I am very unhappy. If the textbooks teach me like this, no, it's not acceptable. Not acceptable. I don't want you not to accept it, but question it. That's it. Try to think about it differently. Children and adults frequently meet criteria and all. So here, according to this textbook, according to this child of 8 years is having a bipolar disorder otherwise specified. Welcome, Professor Rao. For the last 6 years, which you can call bipolar disorder otherwise not specified, ultra-DIAN cycles. And what is the treatment? You decide whatever you want to treat like. If the child comes to me, I don't treat. I'll send to Dr. Gauri Devi. child psychiatric problem, some adjustment problem, हाँ थोड़ा देख लो. Otherwise, I have to put the patient on, you name whatever mood stabilizer or, okay. I'm supposed to be doing that. I have no choice if I diagnose bipolar disorder. I'm not doing it academically right. Satish can question me, you diagnosed as bipolar disorder, you didn't put him on prophylaxis. He has got every right to question. So these are the diagnostic issues I'm talking about. So initially, now I think it may be just 2 minutes. One is OCD plus this, I took it as a prototype, where fortunately treatment is the same, but prognosis wise you can give a lot of reassurance to the patient. Problems in BD with OCD. When it comes to irritability, affective instability, diagnostic challenges also can come in mood disorders, even in depression, agitated depression, irritable depressions, where you can have this problem, but not like it's slightly relatively much less. Right, this is the last slide. Most of the times nowadays people are saying that childhood ADHD is an early indicator for later development of bipolar disorder. I don't know much about it. I have no, like not very different, but this paper, it goes with my line of thinking, so that's why I wanted to present it here. He said that it is not a significant prospective risk factor. I look at it as two different disorders. Childhood some problems, it's not, as on today we have no specific indicators. This is an important point, very, very important point. When you examine a patient, when you give a questionnaire to the patient about personality disorders, if the patient is in a depressed phase, patients met criteria for most personality disorders at a much higher rate when you do the testing in the depressed phase compared to euthymia. That means the personality disorder which comes out of your questioning is an artifact of exaggerated falsification of the depressive state rather than the actual personality disorder, which I think all of us know. We all know that retrospective falsification by this one depression, that is what is a very important point. So you better do the screening when the patient is euthymic, not in the depressed phase, where there can be chances for more diagnosis. So this is what broadly this is. Quickly run through mood disorders, no problem. It's a huge problem, any comorbidity. And then I did talk at length about where affective instability can create problems. As medical doctors, we are supposed to be telling them this is what the prognosis, this is what I can do, this is what I can do, that's what it is. And then different modalities of treatment where we can extend that. This is broadly how the comorbidity in mood disorders can play in day-to-day clinical life. Thank you very much. Thanks for a very patient listening. Thank you so much.
Thank you, sir, for the very clear presentation. We always look forward to your presentations whenever there is any seminar or any presentation by MS Reddy, sir. We don't miss at all because he gives very clear fashion without any confusion. He doesn't create confusions. There's a plus point about him. Very clear narrations are given, mainly focusing on the day-to-day problems what we face in diagnostics and therapeutic level, mainly on depressive disorder, OCD, then BPAD, and including the personality disorder, borderline personality disorder, what we face in day in and day out. So now it's open for questions.
Yeah.
Sir, it was an excellent presentation, sir, as usual. These days, I am seeing a new trend, sir, in the comorbidity of mania, sir, particularly. Seeing patients with a lot of behavioral addictions. Like porn addiction, sir, one thing. Particularly in adolescent manic patients, they are coming with increased sexual desire, addiction to porn, and excessive masturbation. This is one kind. And another kind is a lot of gaming, sir. Patients, family members are complaining till 2 o'clock in the night, 3 o'clock in the night, they're just playing PUBG or something in the mobiles. And one more presentation was like, one patient came with mania, sir. He said that he had made 500 TikTok videos. Actually, we thought it as a grandiosity, but when we really checked in the mobiles, he was having a lot of TikTok videos, and the videos are also, he was like increased psychomotor activity, excessive gestures, and grandiose talk. Everything was there, sir. So, and some family members also complain that he's always on the mobile phone, and except when it was not charging, his headphones are on his head and continuously listening to music. So, I'm seeing a lot of behavioral addictions these days. So, what is your say on that? And any research started on that? Can we think it as a comorbidity, this behavioral addiction thing?
Yeah, I
Yes.
think it's a very relevant question and day to day. Now, what we are seeing in the last maybe a few years, substance use disorders, now like I didn't go into the details, but only thing as I told, is it a cause or effect? So suppose I look at say all the things what you told, increased sexual activity, increased masturbatory activity, increased watching of porno, increased making of these short video clips and all. Suppose that's where your diagnosis is important. Suppose my diagnosis is bipolar disorder mania. The entire spectrum of all these, you call it overdoing or addictive tendency, behavior, you take it as a symptom of mania. You treat the mania aggressively. If it is symptom, everything will subside once a manic episode comes down, but it may not be all that simple. Part of now, how much of watching now let's see is going to be normal, how much of watching is like an abnormal, it's sometimes a difficult to differentiate, but mostly all those things. He may still make TikTok videos, but instead of 500, it will come down to 5, which we may have to sort of agree upon. Suppose it is not secondary to mania, it's a separate thing, oh, it's going to be a huge problem. So that is where the beauty of making a correct diagnosis. That's what I look at.
The prevalence seems to be very high, sir. We don't have actual data on that, but many patients out of 10, 8 are saying that they are addicted to some or the other things. Do we need to diagnose them separately as having a comorbidity, or it's just mania? Like we diagnose substance use
I would like
disorders.
to answer here. No, here I would like to answer. See, like what you said, the trend is now for the past 3 years, I would say. The reason is that COVID and they're not exposed to school, they are at home, there's absolutely no stimulation. And many children are, brought with this kind of a thing. They are teenagers, the hormonal influence is there, and there's nothing else. I mean, exposure only to the, internet and things like that. So all of them are exposed to that, and they don't know what to do. They have become little more creative. Few people have become more creative, and few people, the porn addiction and the thing. They are, I mean, it's not episode at all. It's a continuous phenomena for the past 2 years or 1 year. I would not make a diagnosis of bipolar disorder at all. I think I would say it's very unfair to make a diagnosis of bipolar disorder just because they are a little more creative. And I've seen children doing wonderful things, as you said, TikTok and all those things. And they said we would take it as a profession. It is not grandiosity. They have been doing it. So here I would say, like, if it's a continuous phenomena for a year or so, and they're, I mean, porn addiction, teenager, he looks at it and he masturbates and things like that. Why do you want to make a diagnosis of, no, it's not episodic. If it's a long-term thing, then definitely, I mean, I'll not make a diagnosis thing because the family circumstances. Here I would like to say about what MS said. Irritability. Somehow I never want to take irritability as the diagnostic criteria for either depression or bipolar disorder.
Please inform DSM-5 people.
The reason is that I say right from the age of 5 years, 6 years, children having irritability, moods, irritability, whether it is because of family situation or the marital disharmony or anything. So why are we taking irritability and make the diagnosis? I mean, the worst diagnosis of bipolar from the age, I mean, I can see from BD, say 2 years. Of course, I had seen a child who was 4 years old having a manic episode where father had bipolar disorder. The boy would get into the bus, he doesn't pay, etc. I don't need to pay. I mean, I'd seen in Nilofer. I mean, what I want to say is just don't take the criteria of irritability as the thing. I mean, because most of the children below the age of 12 years, irritability, mood, instability is a very, very common thing, and making a big diagnosis rather than getting into the family circumstances and the child's conflicts and his temperament, just don't make a diagnosis. That's really, I think, unfair on the part of
Ma'am,
psychiatrists.
I just add to this, ma'am, they have already got diagnosed as bipolar because of the other symptoms. I just explored this angle of internet addiction and I got these results. Already diagnosed bipolar cases only, madam. Syndromal diagnosis was made. This is only one of the presenting symptom. That's
Yeah, no, it could be, but what I've been for the PGs, I just want, I mean, they can't take your word and then say, like, make a diagnosis.
That very clearly she said,
Yeah.
underlying diagnosis, right, that's
Yeah.
fair.
If it's underlying diagnosis, yes. But many times we make a diagnosis, we are in a hurry. Another thing is about borderline personality disorder and the bipolar disorders. See, one is that this irritability and stability part of it. I think sometimes I feel we are over-diagnosing even borderline personality disorder, because this has become the trend, because the irritability, and especially I see the teenagers, most of them, they have this behavior and it's a learned behavior because of the family, and the way they are getting things on and off, and the parents, they don't discipline initially, suddenly they start disciplining at the age of teenage. No, sometimes I feel that because we have the diagnostic categories, we try to pigeonhole them. I mean, these are the two things I just want to tell.
Yeah.
With due respects to Dr. M.S. Reddy, and I think both of your comments are well taken. The only thing which off late from 2016 onwards, what Jin Mali, the current president of International Society of Bipolar Disorder, is propagating, that his own concept of bipolar mood disorder, and that's a good way to look at it. He talks about ACE model. The ACE model consists of three things: activity, cognition, and emotion, where he underplays the irritability as a factor. That's why I think we should agree on that. And not only that, see, right now our psychiatric diagnosis, especially if you go by symptoms, it's less specific. That's why I think what we keep arguing from time to time is, so many criteria need to be present. This criteria should be present. I think many times we heard Dr. MS talking about whether hypomania is for 4 days or 7 days. See, all these things go, but when it comes to comorbidity, the topic of today, I think comorbidity is the rule in child and adolescents especially. You see any child, we very rarely find without any comorbidity, whatever the comorbidity. And last, on your comment, you said 8 out of 10 have addiction. That seems to be a little high. It depends on what you are defining as addiction. See, today, a child of first year birthday is given a smartphone or an iPad, and they keep playing. Whether that is addiction or not, how much time spent, that would not be a criteria. In the near future, if you say 8 of 10 are using this, that's a norm. Only
Sir,
20%
it's like
who are not
family
using.
members are complaining and they are saying that
Agree.
it is like,
See, the family
troubling.
members are complaining because of multiple reasons, including parents not having time. And once they come to the clinic, they complain a lot of things. See, among the complaints, what is important and what is not is.
Sir, these are all patients at IMH, sir, who are excessively violent and already diagnosed bipolar and having too much of internet usage.
No, I think the point what she raised is a very valid point. The contemporary, see, I can only talk about, I don't want to go again on discussion. Established diagnosis of mania, there's no doubt, on that presenting symptom. I think that's it. And then postgraduates also. Whatever may be our loopholes or deficiencies in the diagnostic system, that does not give you a scope saying that it's okay with the diagnosis. No. You make a wrong diagnosis, but still you have to make a diagnosis. Without diagnosis, don't just jump into that. It can be adjustment disorder, can be. So, there can be problems, but you cannot say that it's okay with the diagnosis. Let's not go back to what we were 40 years back. You have to follow whatever DSM-5 or ICD, whatever. Yeah, please.
With due respect to all super specialists, what I observe is people who are working on bipolar, with due respect to you, sir, too, that we tend to stretch our diagnosis many a times, like things we look in that color. And that's where the kids with 2 years to 10 years, 12 years would have been diagnosed as mania. So that's where I think the problem lies.
Yeah, yeah.
Like I am a specialist in OCD, so I'll look everything as OCD with something, bipolar with something. So that is the main.
Exactly. That is why I was telling them, you have to make a diagnosis. What you said is right. The more number of surgeons, the more number of surgeries. That's all over. It's a very well known fact. It's not only in psychiatry. That's a problem.
Thank you, sir.
Ajay, do you have time?
Ajay, please.
Thank you for a wonderful presentation, sir. Sir, you have spoken at length about the various comorbidities, sir, but I think one thing that has not been covered was the eating disorders, sir. Eating disorders very frequently are presenting with mood disorders. Recently, we've seen a lot of young children present with a lot of anorexic symptoms and all that. I just wanted to know your take on that, sir. Yeah.
I did put that. Eating disorders, one word. I didn't want to go elaborate that because now it will become too much. Eating disorder can be again the same thing, cause or effect. The same thing as substance abuse. Is it secondary to underlying depression, or this anorexia is not like producing? That is where the differentiation comes. Primary eating disorders like anorexia, bulimia, see really so much. I don't know, unless like an latest trend. If at all there is, generally we look for underlying depression. I'm not talking about bipolar at all here. Underlying depressions, atypical manifestations, masked depressions. These are what we look at. Treat primarily with like antidepressants. One of the drugs, whichever, right? Plus, maybe supportive counseling may be very much required there. I didn't mention that, but it depends on. Suppose eating disorder is episodic. Doctor, my child had this anorexia problem for 6 months when she was 10 years. She was all right. Now she is 18 when she had. I go favor of depressive disorder, recurrent. Suppose it's a continuous, I'll go for the primary. It all depends on that.
Thank you, sir.
Yes, please.
Myself, this gentleman, whenever he goes into manic phase, he would like to lose weight. He would go for exercises, swimming, and all those things. And when he is in the depressed phase, he eats, overeats, and puts on weight. And I'm sure you know, but he committed suicide, and then there's no more. But we do come across people with mania. They do a lot of exercises, go for running and marathon and things like that, and it stops suddenly. And then they start overeating, and then they put on weight.
A brief discussion about the comments by Dr. Anita and Dr. Madam Gauri Devi. Like if somebody in psychiatry will go by symptom presence, distress to self or others, and dysfunction. If the child is brought with all these symptoms, including sleep disturbances and all those things, and child is not doing the proper work of education, which is their primary function, so it leads to dysfunction, and there's a distress to the family. That's why they brought the child. So if it is not in presence of bipolar disorder, it's independent of bipolar disorder, I think some diagnostic label has to be there for that, because unless we put it as a disorder, we cannot treat it. So what type of disorder can we think of in these situations? It's not secondary to bipolar, but in the last 2 years, students were habituated for using both because of social environmental situation. It led to increased use, dysfunction, distress to family members is there.
Yeah. So here, I mean, see, it's not that, I mean, you need to make a diagnosis, but if you are forced to make a diagnosis, would like to make adjustment disorders, because the adjustment disorders with reference to, their time and then interaction with the family members, because family members want them to do something and they're not able to, and then they get used to staying at home. Many children are refusing to go back to school, and then they are spending more time. The sleep disturbance, when I ask most of them, it's not the sleep disturbance. They are so involved in that they postpone the sleep. So they postpone the sleep, they continue watching it, and then they get up and they're so tired they don't want to go to school. So there is dysfunction, but what I mean to say is a lot of things in child psychiatry, you just don't want to make a label. That's what I just want to tell. This is more of adjustment disorder with a reference to the situation and the family situation and the society, situation in the society. Okay.
So we are making adjustment disorder label, and so we are treating, yes.
Yeah.
Exactly.
Thank you, madam. Yes. So with this, we'll end the presentation. We have a lot of take-home points learned from Dr. M.S. Reddy's presentation. Thank you so much, sir. And thanks organizing committee for giving me the opportunity to chair this session.
Thank you for such a wonderful talk, which reflect your vast experience in the field of bipolar disorder. I now request the chairpersons to give away mementos to Dr. M.S. Reddy, sir. I request M.S. Reddy, sir, to give mementos to the chairpersons. Let's move on to the next session. It is comorbidities in the course of schizophrenia. We have with us Dr. Shiva Prakash sir speaking on this topic. I invite chairpersons Minas sir and Dr. George Reddy onto the dais. Okay. Dr. Minas sir is a professor and head of the Department of Psychiatry, Deccan Medical College. He is the Vice President, Hyderabad Psychiatric Society. He is also Honorary General Secretary of Indian Association of Private Psychiatry. He is a recipient of a National President Award, IMA 2017-18 and IMA Telangana State Award 2020-21. Dr. George Reddy is a consultant psychiatrist in Healthy Brain Clinic and he's also president of IPS Telangana State Branch. Welcome, sir. I request the chairpersons to invite our speaker. Sir, please come on to the dais.
Good morning to all. Can I request the postgraduates to come forward? It will be a lot, motivating for the speaker. And really, I should appreciate you all. Though the group is small, but I see the zeal and interest in your, to learn. I appreciate that. I request you to come forward. Yeah. Thank you. Thank you.
I would request our for our today's talk on comorbidities in course of schizophrenia, I would like to introduce our speaker, Dr. Shiva Prakash Srinivasan sir. He is consultant child and adolescent and adult psychiatrist at Vikas Center for Hormones and Mental Health, Chennai. Welcome, sir. And he is also consultant psychiatrist at SCARF, which is a well-known organization for treatment of schizophrenia and chronic schizophrenia. I would hand over the mic to our co-chairperson, Dr. George Reddy, sir.
I think the topic chosen, I think Dr. Sap, I think would definitely do justice, and particularly postgraduates, I think schizophrenia is our bread and butter. And really, I wish, we better go like a surgeon who does good appendectomy surgeries. He will be a successful surgeon. And, complex surgeries will be later. But likewise, for us, when we start our career, particularly schizophrenia, I think we really need to be well versed because that's where our journey starts. The complex syndromes will be later on. As we add years to our practice, I think we will be going into new presentations. But schizophrenia is one where I feel we all should learn to the best. And today's topic, comorbidities, I think it's an ocean. so many, we come across so many comorbidities, and a wonderful topic chosen. I think over to the speaker without, in between between us. Thank you, sir.
Thank you so much. A very good morning, everyone. Audible? It's on. Yep. Thank you. Thank you. Excellent. I'd like to thank the organizers for having me over here today. This is a topic that's really important, as Sir had already mentioned, because it's pretty much what most of psychiatry is identified with, right? Most of psychiatry is identified with serious mental health conditions, which primarily constitutes schizophrenia. Now, there has been a time where schizophrenia has been thought of as single condition. It's like either schizophrenia or not schizophrenia, right? But then the growing amount of knowledge that we are having, we have come to realize that it's not a unitary concept. It's probably a multifaceted, multi-component concept, which we refer to as the schizophrenias in a way, right? So let's not focus on the entire diagnostic process, but also think about, during the course of today's talk, about the comorbidities. So the basic outline, hopefully by the end of the next 30 to 35 minutes, we'll be able to define comorbidities specifically in the context of schizophrenia, the lifetime pattern of comorbid conditions, and also talk about the unique management strategies. See, if we were all lucky, we would have a brain which would have a specific pathology, and we would take that brain out, we would treat it, and then we'll put it back into the individual, right? Unfortunately, that's not happening, which means we have to think about individuals as a whole. And that's where the condition of schizophrenia and actually all mental health conditions come in, because we do not understand the entirety of the risk factors which play a role in the development of such conditions. So another important thing is we go for the next best option, which is our diagnostic systems. We've had a lot of discussion. Dr. Reddy sir is not here, but he demonstrated beautifully how there are huge amounts of symptom overlaps, right? But we need that, right? Our diagnostic systems are twofold. One, they are atheoretical. We no longer say this is a schizophrenic reaction to X, or this is a depressive reaction or a manic reaction to Y, right? We say that there is no theory behind it. These are the symptoms. Here are the slew of symptoms. Here are what you met. And we see the potential pitfall of that, right? You can have manic symptoms for 20 minutes or 1 hour, and you can be labeled as bipolar NOS, right? Which is what he demonstrated. And the second thing is it's hierarchical. All of you have seen the ICD-10, and all of you know that there is F00, F10, F2, F3, F4. Things which happen higher up subsume everything underneath it, right? Which is not true, because if it subsumes everything underneath it, you just need to make one diagnosis and you're done, right? The person can suffer with anything else. For example, we had a talk about bipolar disorder and OCD, right? Bipolars are in the F30s, right? OCD comes in the F40s. If we subsume OCD under bipolar disorder, no need to treat the OCD, okay? No matter how distressing. Just treat the bipolar, be done with it. Schizophrenia is at 20, which means skip everything else. Only if they have dementia or substance use problems, address it, right? Which is such a disservice that we do to our patients. So let's start off with this. I would actually also want to thank SCARF, because all these are real individuals who we've seen at SCARF. We've had great discussions about them. We've had loads of inter-consultant discussions, PG and consultant discussions. So All these are real people and these are real problems that we face. So a 50-year-old male living with his sister since the death of his mother, past psychiatric history, has a 25-year history of diagnosis of schizophrenia on regular treatment. His symptoms included hearing the voice of gods through the animals in the neighborhood, animals following him around, recurrent thoughts that if there was a change in climate, his mother was unhappy and thus he had to pray repeatedly. Repeated concerns about being struck by lightning, compulsive checking of weather on phone, news, looking out of the window. Things were so bad that he refused to leave home and essentially has not gotten his COVID vaccination yet. He has other past medical history of diabetes and hypertension. Again, so what do you think are the problems that we need to focus on in Mr. A? Just broadly, throw out answers. I'm perfectly okay. There are no wrong answers. There are only answers which we never say, which lead to wrong interpretations, right? So what are our primary issues? Come on, I am on Viva. You guys are going to ask me questions. Yes. What are the issues you want to address in this individual? Let's talk. We are all going to be budding psychiatrists. So what are the psychiatric issues you want to address? Anything? Hearing of voices. So you want to address the auditory hallucination. Awesome. What else? Compulsive checking. Okay, compulsive checking.
As she's not going out, avoiding completely, so we'll check why is she doing like that.
Awesome.
So avoidant behavior.
Right.
And this animals.
What do you think about these recurrent thoughts that if there was a change in climate, his mother was unhappy, the dead
Magical
mother was
thinking type of
unhappy?
thing.
Do you want to call it OCD? Do you want to call it psychotic because there is of uncertain origin? What do you want to do with that? Right. What do you think about diabetes and hypertension and COVID vaccination? Is that an issue?
She's anyways not going out, sir. So why to bother about COVID vaccination?
Awesome. He's been consulting me on teleconsultation and it is frustrating for me because I want him to come to us. Right now that's okay. Eventually I'm going to close the teleconsultation at SCARF and say you come. Good point. But what do you think not going out has an effect on, say, diabetes and hypertension? Right? So again, in an ideal world, I want to take out the brain, I want to treat it, I want to put it back. Unfortunately, I'm not able to. So I'll have to work with what I've got. This is somebody that we've been treating for a long time. And as you notice, in spite of the treatment that he's been getting, and unfortunately, he's been on 25 years of treatment regular, the only medicine which seems to even hold him together is clozapine. And as we know, clozapine is extremely bad for his diabetes and hypertension. And as we know, clozapine can also have an effect on his obsessive thoughts. We are stuck in a situation where nothing else works. This is what is actually keeping him out in the community. So we have to work with what we've got. So really quickly, we'll cover a few things. I'm sure we've had this discussion before, but these are the co-occurrence of more than one disorder in the same individual. Works excellent in the medical model. I'm allowed to have tension type headaches and back pain and diabetes, right? Three separate things, entirely separate things. It is an epidemiological phenomenon. It is not we identify comorbidities through associations which happen in the community, right? Individuals with diabetes are more likely to develop cataracts. Individuals with diabetes are more likely to develop peripheral vascular disease. You treat the diabetes, but you also treat the peripheral vascular disease, right? It is an epidemiological phenomenon. And association is not causation. Keep this in mind, right? many a time there is a discussion between, let's assume, the risk factors that we do understand for psychiatry, right? Adverse childhood experiences. Adverse childhood experiences increases the risk of psychotic illnesses. I mean, to a certain extent, yes. So association is not causation. Increases the risk is not causative. And this may result in, especially in the case of psychiatry, may result from symptom overlap. Let's assume in schizophrenia, because this is the nature of my topic. In schizophrenia, let's assume an individual comes and says, I don't want to go out, right? Which is what we talked about. Is this social withdrawal, or is this actual positive psychotic symptoms like delusions of persecution? He's got problems with individuals outside. What we are observing is he's not going out. And if he doesn't open his mouth and tell us what the reason is, we could make either a diagnosis of schizophrenia or a diagnosis of severe depression with psychotic features, right? Detection artifacts. This is something that we've Dr. Reddy very beautifully demonstrated. When somebody is depressed, you give them their personality questionnaire, and more people will be able to identify borderline personality, right? And life course effects. What happens over the course of life? Okay, so really quickly, I want us to keep these models in mind and think of it as you start doing your work, right? These are models which have been developed for, again, the medical model of comorbidities, right? So the first one is, oops, this, there's a risk factor 1, disease 1, risk factor 2, disease 2, okay? So these are two completely independent things happening. A child had neonatal hypoxia, had developed cerebral palsy at birth. The child witnessed the death of both his parents in a car crash, has developed PTSD. So cerebral palsy and PTSD, two separate entities, two separate risk factors, right? Next is, the risk factors might be independent, but the diseases may overlap. Or may have an effect on each other. So this is an associative model. In the third scenario, the risk factors may be linked to each other. Let's assume an individual has got impulse control disorders, right? And let's assume that that's the risk factor. So the risk of developing both opioid dependence as well as alcohol dependence, very high, because there is impulsivity, right? Then there may be no association between the risk factors, but each one could potentially cause the other, right? The example that they had given, at least in the medical model, is diabetes could be associated both with cardiac disease as well as cataracts, right? The other thing that they've talked about is age could be related with cardiovascular disease and cataracts. Two independent, unrelated risk factors can cause both conditions, and they may have an effect on each other. And this is the most important one. There might be a separate risk factor, development of disease 1, and similarly a separate risk factor and development of disease 2, but they might actually be caused by disease 3. The easiest example, episodic aggressive behavior, right? You would assume just episodes. It could be an affective condition, right? Episodic aggressive behavior where the person goes and breaks things and gets up in the morning and says, oh my goodness, I'm so sorry, right? We might say impulse control disorder, right? Actually, both of them are related to the fact that he's been drinking alcohol, has got a binge pattern of alcohol use. So disease 1, either affective, or disease 2, impulse control, actually being caused by disease 3, substance use disorder, right? As we get to know more and more about the risk factors, as we understand this illness more, right, what you will notice is that we are able to put together the comorbidities, especially in the case of schizophrenia, into one of these baskets. And that helps us because then it will give you a hierarchy as to what you need to start addressing and where and when, right? So, so basically they can either occur by chance, they might be secondary to a core disorder, or there might be a shared liability. So Emil Kraepelin did an amazing job, right? He set the stage for us to understand that there are certain chronic, progressive illnesses and there are certain episodic illnesses. What did he call them? Thank you. So, right. So dementia precox and manic depressive illness, right? It doesn't work because as we've seen, there is a huge amount of symptom overlap. We will not be covering schizoaffective disorder here, right? If we had talked before DSM-4, we might have talked about schizoaffective disorder, right? We might have talked about how affective symptoms can happen with psychotic illness. They can occur independent of each other. They can happen together, all these things, right? We aren't talking about schizoaffective anymore. It's a separate diagnosis. So symptom overlaps we saw as in the case of Mr. A. There are biological findings. Hopefully by the end of today's talk, you might be able to label a few biological findings which are there. There are huge genetic risk factors. Schizophrenia is amongst the most heritable of mental health conditions, right? It is probably secondary only to autism spectrum. So, and there is a tendency for it to breed true significantly. So there is a huge genetic risk which people pass on, right? There are certain neuropsychological findings, and over a period of time, unfortunately or fortunately, through reverse psychopharmacology, we figured out that this medicine also works for this thing. So maybe both of them are linked, right? Do not use that logic. But there are psychotherapeutic developments which have shown that there are medications which work equally well for both conditions, right? So what are the neurobiological underpinnings? So let's see, reduced frontal cortex, reduced functional connectivity within the brain networks in schizophrenia may affect the abstract and reward reinforcement in the orbitofrontal cortex. People with depression have a problem with accepting positive comments, right? They do not experience the positivity which is being given to them. So there is reduced reward reinforcement. And schizophrenia is a neurodegenerative condition which causes problems in the functional connectivity in the brain, which is somewhat similar to what you would expect from somebody who has depression. How many of us know the negative symptoms of schizophrenia? What does the SANS say? Evolution, apathy, anhedonia, apathy. You tell me a joke, I'm going to stand like this. I'm not going to smile. Alogia, affective flattening, and inattention, right? So anhedonia is, what is anhedonia? Sorry? Inability to experience pleasure in things which were previously pleasurable. What does this sound like? Reward reinforcement. Oh, you did a good job. I don't care, right? Degenerative changes in schizophrenia in the cingulate and caudate nuclei, which may mimic OCD, right? Which is basically based on the corticostriatal thalamic circuitry. Psychopharmacology actually clozapine, the most atypical of the atypical antipsychotics, has an effect of affecting the 5-HT2A functions, right? Which is very significantly associated with the development of obsessive compulsive symptoms, right? So basically what we are trying to say is that the brain is predisposed to having multiple effects. Schizophrenia being a neurodevelopmental, neurotoxic condition has got a wide range of effects in different parts of the brain, and so expect emergence of different kinds of symptoms, right? Okay, genetically, this you can look up the references at the end of the slide. This is a very beautiful diagram which talks about what we know is through genetic studies is that we have a whole slew of SNPs, right? Single nucleotide polymorphisms, right? What we know is that again there are huge amounts of associations between individual SNPs and individual conditions. What they did was they put it all together and they realized that there are some which are unique to say schizophrenia, but they are also present in bipolar disorder, in psychosis, and bipolar disorder and psychosis. There are some SNPs which are unique to just psychosis, namely B. There are some which are unique only to bipolar disorder, EFH, right? But what we've realized is that there is a very small group of single nucleotide polymorphisms which are linked to all three of these, and typically these are related to the 5-HT2A receptor, the serotonergic receptor. There is some element of glutaminergic receptor development or glutaminergic production, right, which are associated with all three of these things, right? So there is some genetic basis for us to say that all these three are linked. Okay, let's look at Mr. B. He's a 17-year-old male from a lower socioeconomic status family, educated till the 9th grade. After that, he's just dropped out of school. He's been sitting at home. He presented with chief complaints of repetitive behaviors, reassurance seeking. Okay. What questions do you want to ask? Let's assume that this happened for about 2 years. What questions would you want to know? What aspects of history do you want to know? Some of you might have already seen the next thing which comes out, but just think about what questions do you want to ask. Okay, I'll give it to you. So since he's a child legally, right, we go ahead and ask him, ask about developmental history. So there is some history of developmental delays. The family is not able to communicate much because both the parents were working. They had to leave the child with the grandparent. There was some questionable delays. He's always been a stickler for the rules. No other features of autism spectrum reported, at least by the parents. Social history, he was slow in his studies, limited friendship, was bullied at school. So what are the things which come to your mind? What do you think we can diagnose him with? Based on a limited information. Okay, let's say provisional diagnosis. What provisional diagnosis do you want to give? Anyone? Okay, let's take a vote. How many of you say schizophrenia? Raise hands. You don't even have to speak. Raise hands. Okay, no schizophrenias. How many of you say schizotypal disorder? Okay. How many of you say depression? How many of you say OCD? How many of you say, I don't care, I'll send them to Dr. Gauri Devi? Right? Even for this, if you don't raise your hand, then there's no point in having this conversation, right? So let's provisional diagnosis of OCD. He continued to have problems with poor social connectedness, but had reduced reassurance seeking once we started treating him for a provisional diagnosis of OCD, wherein we started off with SSRIs, fluoxetine, something, right? 1 year hence, he started developing symptoms of hearing the next door neighbors talking about him. He started feeling like he was being followed. He had repetitive gesturing and increased social withdrawal. Now, what do you want to say? Schizophrenia, right? More likely than not schizophrenia. So what was the OCD? Was it a symptom of ASD? Was it a symptom of OCD? Was it a symptom of as a prodrome of schizophrenia? So when you think about comorbidities, especially in the case of schizophrenia, which is a lifetime disorder, you should think about what happens before, what comes during, what happens after also the diagnosis of schizophrenia, right? In retrospect, we might have thought that there were certain oddities, that social withdrawal, maybe not engaging with others, academic deterioration from a very young age, possible obsessive symptoms, right? Maybe we could have gone into the phenomenology of the obsessive symptoms and have thought like, okay, this is not very obsessive, but still something is not right, right? But especially in the case of schizophrenia, which is a lifetime diagnosis, always think about comorbidities which can happen before, during, and after the diagnosis of schizophrenia, whenever that happens, right? So there is actually evidence to say what comes before, right? This is a very busy slide. I'd like to show you this particular line, which increases the odds by 8, an increased odds of 8 or more, right? So we have major depression, substance use, bipolar disorder, mood disorder, anxiety, depression, suicidal ideation. So pretty much prior to a diagnosis of schizophrenia, you can have every single F1 to F00 to F99, every single diagnosis in the book, right? And that is important to keep in mind. And these are again associative studies. These are huge population based studies wherein they took individuals who were diagnosed with schizophrenia and they went back and saw what were the diagnoses in their charts before that, right? And that is important to keep in mind. So let's start off with childhood schizophrenia. The most important comorbidity that we need to keep in mind is substance use. Teenage is a period of experimentation. Young people do experiment with substances. It is normal. It is a part of the developmental process. But this is also the period which increases, wherein the risk of developing schizophrenia is the highest, right? So now we have a chicken or egg argument. What came first? Was it the substance use which led to schizophrenia? Vice versa. Either way, substance use worsens the course of psychotic illnesses, right? Pervasive developmental disorders. This is another major association which has been found. Unfortunately, one of the things that we need to keep in mind is a diagnosis of schizophrenia has to be made based on our diagnostic criteria, current diagnostic criteria, namely delusions, hallucinations, disorganized thought, disorganized behavior lasting for a duration of 1 month or more, or presence of negative symptoms, right? Pervasive developmental disorder may mimic, but wait, observe is something important. Childhood schizophrenia, right? We know that trauma, adverse childhood experiences increase the risk of psychotic conditions, but certain traumatic experience can also manifest itself like disorganized behavior, right? We need to keep that in mind, especially childhood sexual trauma, especially sudden life-threatening traumatic events could also manifest itself like psychotic symptoms because there are disorganized behaviors. Anxiety and OCD, again, these are associations which have been found. And one very important thing, especially in childhood schizophrenia, that we need to keep in mind is medical conditions. Children are extremely predisposed post-seizure confusion states, post-seizure psychotic conditions, any other medical conditions, developmental medical conditions which may affect the development of psychotic symptoms, right? So again, as we can see over here, the odds of having suicidal ideas before the diagnosis of schizophrenia is 51.2. So, I mean, such huge odds are worse than our chances of dying in the streets of Chennai or Hyderabad, right? So, we have bipolar disorder which has been diagnosed, and we go all the way down till personality disorders to which is 12, right? Remember schizophrenia comorbidities, lifetime course. What comes after? We notice that they develop altered brain damage. In 8, they have a hazard ratio of 87.3. Altered mental status, bipolar disorder, alcoholism, substance use disorders 45, So pretty much what I want you to take from this particular slide is, once you make a diagnosis of schizophrenia, you cannot rest easy. You have to be actively paying attention to what might potentially come. So as the primary source of contact for individuals with mental health conditions, you might be it in trying to make sure that none of these things develop. So I'll quickly go through these slides. We know that positive symptoms, depressive symptoms, cognitive, suicidal ideas, substance use, all these are linked amongst each other. Panic disorder is associated with all of these. PTSD is associated, right? So we need to keep in mind that, I'll skip this one, medical comorbidities need to be addressed. There are different pathways of developing medical comorbidities. First are health risk behaviors. Smoking, sedentary lifestyle. We talked about Mr. A refuses to go out, lead to worsening medical comorbidities. Biological, there is a link between inflammation and oxidative stress. There might be a genetic link between the development of both medical as well as schizophrenia. Social, disparities in the availability of healthcare. This is not something that we necessarily pay attention to in India, because everybody seems to have poor healthcare. But we need to keep this in mind, that people who have major psychotic illnesses are probably less help seeking than individuals who do not have this, right? And the attention to physical health is relatively less. So in the case of psychosis, again, another major huge database based study, we found that asthma is 3.2, the odds is 3.2, obesity 3.67, and all these are prior to the diagnosis of a psychotic condition, right? I mean, they had other things also, but keep in mind that there are comorbidities all the way through. So really quickly, Mrs. B, she came to the hospital, status post-suicide attempt by overdose on her father-in-law's medications, presented with 2 months of acute onset of symptoms of delusions of persecution, third-person auditory hallucination. No other mood symptoms elicitable, past medical, past psychiatric history, nil significant. A relatively common presentation. If I were to ask you about diagnosis, does anybody have a thought? 45-year-old female, psychotic symptoms, acute onset, possible depression with psychotic symptoms. We worked with psychosis NOS as a working diagnosis, because our other consideration was acute transient psychotic, acute schizophrenia-like psychotic disorder, right? She was started on risperidone and within 3 weeks showed significant reduction in psychotic symptoms. At 3 weeks, she had reduced auditory hallucination, the delusions of persecution had reduced, general slowness, reduced interest in doing things, reduced tiredness, no other EPS, denied any depressive cognition. What do you think? We might think that no, still the risperidone is the cause of this thing. She slowed, her cognition is slowed because of risperidone. So we reduce the dose, establish closer follow-up. At 6 weeks, still no EPS, no psychotic symptoms, but now we start seeing the emergence of low mood, anhedonia, poor motivation, guilt about psychotic symptoms, reduced energy, and death. Right? If OC symptoms emerge during the course of illness, optimize first your antipsychotic dosing, review the treatment history, and important thing over here is pharmacokinetic interactions. Most SSRIs, which are the gold standard of treatment, have some effect on the CYP450 system, which can cause an effect on your antipsychotics. Always consider CBT, and at no point, I'll come back to this thing. I haven't mentioned it over here. At all points of time, address the obsessive symptoms, right? Depression and schizophrenia, screen to differentiate between negative and depressive symptoms. This is important. We can't use the simple Hamilton depression rating scale or the MADRS. There is something known as the Calgary depression rating scale, which is specifically developed for the identification of symptoms of depression in individuals with psychotic illnesses. Reduce the dose of first generation antipsychotic, reduce physical symptoms by use of anticholinergic medicines. Adjunctive use of SSRIs is indicated, CBT is definitely indicated, and atypical antipsychotics. Remember, reverse psychopharmacology, quetiapine, aripiprazole. I mean, progressively we've got more and more indications of use of antipsychotics in the treatment of depression. So you might want to switch to atypical antipsychotics. Substance use, a huge problem. We saw a hazard ratio of 50 and above. Evaluate substance use at baseline and as indicated. I'm not probably going to ask a 45-year-old lady who had the first episode about her alcohol use or cannabis use, but I will definitely follow up with a 21-year-old college-going student as to, have you tried alcohol? Have you used cannabis? I mean, at baseline, I would ask even the lady. There's zero doubt about it, but subsequent follow-ups, maybe I won't. But a 21-year-old college going or a young individual, I have to evaluate it. Use motivational interviewing strategies to address any ongoing concerns. Keep this in mind, individuals with schizophrenia are not incapable of having logical processing thought, and motivational interviewing is focused on trying to engage the individual to develop their own reasons for quitting substances, right? You cannot say, oh, he's psychotic, can't think like this, we can't do MI. No. Motivational interviewing can work with anyone. It is important that you are able to engage the individual in an appropriate discussion. Of course, I'm not talking about a florid psychotic state where you're not even able to have a conversation, but over a period of time, individuals with schizophrenia can engage in motivational interviewing. Prefer abstinence over harm reduction strategies. This is something that's important. Be mindful of the effect of medications on mental health. So medications such as disulfiram, they have been associated with development of manic symptoms. They have been associated with development of psychotic symptoms. Medications such as naltrexone can be associated with depression-like features. There is a lack of reward or appreciation of rewards and so on, right? So this is primarily what medical conditions, right? We completely forgot. Be aware of the risk. Ensure screening of weight, blood pressure, essentially the BMI at each visit. Ensure screening periodically. Automate as much as possible. This is an important thing that we tend to forget. People will go get treatment, they'll come back after 6 months. Write in the prescription that the last blood work which was done was on this day. Next blood work is due 6 months from now or 1 year from now, depending on however it is indicated, right? Choose metabolically neutral antipsychotics. Again, as our repertoire of antipsychotics increases, we have more and more choices. And discuss lifestyle changes at each visit. This is important. Remember, the brain doesn't exist independent of the body, which means you have to discuss about lifestyle changes, whether it be dietary changes, physical activity, and so on. So that is something that's important, and hopefully we will take back these few things. Number one, comorbidities increase the risk of hospitalization, whether medical or psychiatric, right? There is increased mortality. 60% of the increased death in schizophrenia can be attributed to medical comorbidities, right? There is an increase in a risk of death by suicide in individuals with schizophrenia. There is a lower quality of life. Remember, obsessive symptoms are probably more distressing than the actual manic or psychotic symptoms. Lower quality of life. And finally, comorbidities influence your choice of medications. With this, I hope you go and practice your schizophrenia a little bit better. Thank you.
Thank you, Dr. Shiva. It was wonderful, and you took us through ocean of schizophrenia and comorbidities, and there were many things even for us to learn from your talk. Thanks a lot. I would like to open for questions from the audience. I think Hamza has some questions. Hamza?
I had a question.
Yes, sir.
So with the advent of drugs with very specific profiles, right? Now we have cariprazine, aripiprazole, and all that. So what is your experience with them in terms of comorbidities that come up later? Do you see, like with the older generation, they have multiple receptor profiles? So if you give a single drug, even they may have better control over possible other depressive features or OC features which come in later in the illness, compared to now we have very specific drugs with very specific receptor profiles. So do you see more comorbidities arising now compared to before with the older generation drugs?
That's a good question. In my personal experience and working at SCARF and individuals with schizophrenia, we don't notice as much the development of comorbidities in individuals who have been on medications for a period of time. But over a period of time, what we've kind of realized is probably this is our detection bias. We've been more conscious. We have regular checkups. We have this automated way of saying like 6 months now, once in 6 months, we'll get this thing tested. Half the individuals are involved in some research project or the other, and they'll come back and tell us these symptoms are increased. What are you going to do about it, right? So whether we have a huge detection bias, especially in individuals who are coming in new and who are invariably prescribed more newer novel antipsychotics. So I'm not entirely sure that we have identified this as the causative factor, but we have been able to identify more individuals through actual conscious detection rather than anything else. So,
Dr. G. Prasad Rao, sir.
Thank you. Thank you for a nice way you presented. There are 2 or 3 observations from your presentation, of course, for the larger audience. Not that I'm teaching you or
I'm willing to learn, sir.
The first thing is that even pre-atypical antipsychotic era, there used to be higher medical morbidity in chronic mental illness patients, especially schizophrenia. Lot of higher percentage of unexplained deaths was also noticed. So that would partially answer your question. Second, 2 studies you have quoted about I have seen the statistics. You see, they have a large number of psychotic patients, but have only a smaller number of normal controls, very single numbers.
Right.
So that can explain the abnormally high odd ratio, like 87 and all. That's my just observation for the youngsters.
Yes.
Because see, if you see the large, you have 8,000 or 6,000 and 1,000 patients here on this side, and comparatively you are having only 10. So in the 10, even if 0 develop,
Right.
and here a larger percentage, so the odd ratios change. A third larger thing is, the fact remains that metabolic syndrome is a fact of iatrogenicity. Maybe previously we used to say schizophrenia are negative, they don't work, all these things, but I think we know to a large extent the newer atypicals, some of them at least, have contributed to the metabolic. I think, and we are still looking ways and means, and you have put that slide very nicely. I think I would also add on to Keshavan's study, in which he has taken the 3 groups of things, and cognitive testing, neuroimaging testing, and genetic testing. There was no, I mean, he couldn't differentiate between the 3. So right now our understanding, though, for phenotypically we need to differentiate schizophrenia versus bipolar versus other things. Possibly there are multi-etiological, and once it is multi-etiological, I think our own approach for causation of metabolic biological, medical comorbidity or psychiatric comorbidity, it's still multifactorial.
Thank you, sir. Yes.
Sir, I'm Dr. Hamza from IMH Hyderabad. Sir, you talked about the management of other disorders developing after schizophrenia, right? But as in your first case, you said that some disorders can occur before schizophrenia as well. So how to manage that? Like in the first case, you said that we had make a provisional diagnosis of OCD. We started on SSRI, and then he developed schizophrenia. So should we consider that as a prodrome, or should we take it as an independent disorder again? And should we stop fluoxetine now because and should we only treat on schizophrenia, or should we wait and watch?
Excellent. See, a prodrome, unfortunately, as of now, is a retrospective diagnosis. Once you've made a diagnosis of schizophrenia, then retrospectively you identify all these things which could potentially have been indicators that this person would develop psychotic symptoms. So, for this particular individual at least, right, we cannot retrospectively go back and stop fluoxetine and start risperidone or olanzapine. So we will take it as it comes. But one thing that we were very conscious of was once the diagnosis of psychotic symptoms were established, we wanted to make sure that we were addressing both his obsessive reassurance seeking, because that was more distressing, as well as addressing the psychotic symptoms, because as was discussed, that is more distressing to the entire family and the society as a whole. So, and which is why when we talked about the last one, choosing our antipsychotic, making sure that we thought about what are the drug-drug interactions. So eventually we moved from fluoxetine to say sertraline or escitalopram, one of those things, I don't remember which. But we had to think about the pharmacokinetic interactions once the treatment for schizophrenia had started. And so to answer your question, prodrome is a retrospective diagnosis once we are able to establish a clear psychotic episode suggestive of schizophrenia, right? And so we accept it, and it is something of a learning for us, so that the next time somebody with a similar history of less friends, slow in studies, dropped out of school, comes with obsessive symptoms of reassurance seeking, we might want to probe a little bit more into the origins of the obsessive symptoms. And that's where phenomenological assessment is important for us, right? It's a learning experience. That's all.
I would like to add in this. Many a times, teenagers with some symptoms may come to you, and as Hamza, you were saying, whether to treat or not, or when we look back, it has been found in some studies that if you treat those symptoms, then there are less number of chances, around 300 times lesser number of 300% lesser number of chances of the person developing schizophrenia. So we need to treat those symptoms.
Thank you, sir.
Just to add on, before the student could ask the question, I was just about to comment about the slide you talked about it. Like before the onset of schizophrenia, you come across varied number of symptoms you said are almost like a diagnosis, depression or social withdrawal or substance use or behavioral addictions, kind of a thing you see. Here, I mean, as he rightly pointed out, I mean, we say brief transient psychotic conditions or, I mean, prodrome, we think about it. There are certain things which I found, which is more important, is ask for the history of family history of schizophrenia or obsessive compulsive disorders, and the very vast difference between the premorbid personality and the behavioral change. That clearly indicates that maybe the child is going in for. See, for example, a child who was bright and doing very thing, I mean, so fairly well-adjusted personality or temperamentally, the child starts, not showing interest in studies and then preoccupied with, gaming or something, and irritable suddenly, and then, not interested in, playing with friends or something like that. You can think in terms of depression, but you need to be a little wary about, especially as you know, as a child psychiatrist, that is the area where you can make a diagnosis of depression, or maybe it's bipolar, or it could be schizophrenia. So these are the three things which can evolve at teenage. And there I would say the clue is that you need to look into the family history. I have found number of times they say like we never called it a madness, but the grandfather had something, we used to tolerate him, that kind of thing we find. So sometimes, to your question, you can also look into the family history and the odd behavior that just at the transitional age of adolescence coming up, you need to think in terms of schizophrenia. Just add to, like from what you said.
What Madam said, we have to go back to McGorry studies, where they have followed the high-risk children, and now we have data up till 20 years. McGorry's group from Australia and the Origin, and both the groups that you can say Australio-American studies. The insights are very clear. Not all will convert to schizophrenia. Now you have a kind of a gamut from you can say anxiety disorders to personality changes to psychosis to bipolar to mood disorder. So what is definitely sure is, especially for child and adolescent, don't jump into a diagnosis of schizophrenia right away, even if you have a delusion, because micropsychosis are also known in prodrome. So when you ask for a specific things, see what he quoted and what we see in the clinical practice is not different. What we see at a cross section, if the patient is sitting across you, you find a psychotic symptoms. You might find a OCD, you might find a depression. So just stay with the patient. The art of psychiatry's beauty is watching them, watching the phenomenology, doing a detail, and then following. And the long-term course actually might change. And as you say, the intervening variable like substance use, which is now getting, cannabis is now getting much more virulent across the South Indian culture too, and other drugs is causing a, we can say, artifact of whether it is causing a disease, egg and chick basic problem.
It's also okay to be unsure of what is actually happening. It's okay to be unsure of what is happening. I discuss this with both the individual and the family, and we don't necessarily have to medically treat because they've come to us.
Exactly.
Unless there are very well-formed symptoms. It could be anxiety. We might still treat an anxiety disorder and revise the diagnosis 2 years down the road. But I mean, at least as a postgraduate, it's okay not to know what it is, accept it, follow up the course, and then take a call as time goes by. So just
perfect. So take a deep breath, then the patient comes in. And keep watching. Yes, absolutely.
Thank you, Dr. Shiva Prakash. I think it's a wonderful session, and let's close the session. Is that okay? If there are no more questions, thank you. Over to the organizers.
Thank you, sir, for a wonderful talk. I request the chairpersons to give a memento to the speaker. I request the speaker to give mementos to our chairpersons. Thank you, sir. Before the next session, I have few announcements. All the delegates, we request you to vacate your rooms by 12 o'clock. You can keep your luggage in the lobby. And second thing is the participant certificates are in the Sun Pharma stall. You can collect it from there. And the valedictory function will be at 3 o'clock in the same hall. We now have our next session. So we have seen about psychiatric comorbidities. Now let's go towards medical comorbidities. So the topic for the next session would be treatment and prognostic implications of medical comorbidities in psychiatry. So for this, we have our speaker, Dr. Rajat Mohanty. I request Dr. Prasad Rao sir and Dr. Vijay Sheshadri sir to chair the session. Dr. G. Prasad Rao has done his DPM from NIMHANS and MD Psychiatry from PGI Chandigarh. He is the director of Asha Hospital, Division of Schizophrenia, and the director of Psychopharmacology. He is president-elect of AFPA. He is ex-president of IPS WPA Planning Commission member and fellow of WPA. Dr. Vijay Sheshadri has done his MBBS from KIMS Bangalore, MD Psychiatry from Manipal University. Study, one of the largest comprehensive studies on epilepsy in a rural community in India. I request the speaker onto the dais.
We'll start the program. My colleague and dear friend Vijay would introduce Rajat. Meanwhile, I thought it is prudent to start the flow of this session. First of all, we should congratulate the organizers for selecting the theme of comorbidity. And I would ask one question to all of you. How many of you know that Indian Psychiatric Society has guidelines set for comorbidities? Raise your hands, please. Only one, and that too from a faculty. Do you know Indian Psychiatric Society is the only society in this world which has guidelines for psychiatric disorders and comorbidity, and that was released this year. I would request all the postgraduates to really go online. It is freely available in the Indian Psychiatric Society website. Download, because whatever our speakers have worked very hard, the summary would be there. So this talk is going to be very interesting because here, till this point of time since yesterday, multiple talks have focused on varieties of disorders, and very rightly so. But right now, the ball is being set. What is the treatment implication and prognostic implication? Very important, because for us as a psychiatrist, maybe we will be focusing on psychiatric disorders, but for the patient, you are a holistic physician. You are an MBBS first and then a psychiatrist. How many of you are really auscultating your patients? Raise your hands, please. Please raise your hands. Nobody? How many of you are checking the blood pressure? One. Thank you. How many of you are doing fundus examination? Whatever I'm talking is a basic clinical medicine, and forget. I know today you can send for an MRI and get what is there in the brain, but that's not what we are looking. You are essentially a physician. I would beg to respect the patient by doing a physical examination. I have seen patients, my postgraduates actually do all these things. At least we are part of the training. Please, each one of you do that. So with much ado, focusing on the implications of medical and psychiatric comorbidity in the terms of prognosis and management.
Good morning. It's my pleasure to invite the speaker for today, Dr. Rajat Mohanty. He has a MD in internal medicine from the UK. He has fellowships in critical care and diabetes from Apollo Hospital in UK again. He's a consultant in internal medicine, critical care and pulmonology at Basavatarakam Indo-American Hospital and Omni Hospitals at Kukatpally. May I now request Dr. Mohanty to kindly deliver his talk.
Good morning, everyone. So I'm an intensivist at ASA Hospital. So today we'll be talking about some of the medical conditions what we are treating along other than psychiatric issues. So many of the patients who are in ASA psychiatric hospital in wards, so they have other than psychiatric issues, they have other medical conditions. So many of the time they become sick and we ship them to our ICU. So we are handling a ICU in ASA hospital since last 2 years, and basically I'm going to tell you about the medical conditions and to also not to miss any of the medical conditions which patient is having along with the psychiatric issues. So first thing is when we have to shift the patient to ICU. So the thing is if there is a threatened airway, if there is a respiratory rate of the patient is more than 30 or less than 8 breaths per minute, if the pulse rate is less than 40 or more than 120, if the systolic blood pressure is less than 90, if the oxygen saturation which is coming down, or even after putting a oxygen patient saturation is not maintaining, if there is a sudden fall of consciousness, that too GCS coming down less than more than 2 points, if there is a repeated or prolonged seizures, patient will be having seizure like activity, but it improves by itself. But if the things is continuing, we have to shift. And if there is a arterial carbon dioxide tension increasing when we do a ABG, or any of the patients who are having a cardiac arrest or respiratory arrest. So in every hospital there is a scoring system when to shift the patient to ICU. So that scoring system is called MU score. So modified early warning score. So there are various parameters, as you can see, like physiological parameters in which you have scoring points 0, 1 and 2 and 3. There is systolic blood pressure, heart rate, respiratory rate, temperature and APOV score. So generally when patient is in ward, we have to see these scores. When this score is more than 5, this is a patient who should be shifted to ICU for monitoring. So we'll be talking on these various topics. So generally in our hospital, when a patient suffering with many of the medical conditions and they become sick, and we shift the patient to ICU. So what are the things we have to see? What are the things we should not miss when we are doing regular psychiatric practice? So many of the patients who we shift to ICU for evaluation, like patient come to our ward to ICU or from emergency to ICU. Patient comes with the altered sensorium, seizures, anemia, severe anemia. We need monitoring and treatment. Patient having fever which is not coming down, and patient having shortness of breath which suddenly developed. Acute conditions like patients who go for PCT do not recover. Sometimes they need to shift to ICU. Patient having severe dyselectrolemia, pneumonia, UTI. So all these things we will be discussing today. Coming to the evaluation part, first thing is many a time we see patient comes with acute altered mental status. Generally we term vaguely that patient is altered sensorium. So altered sensorium, acute mental altered mental status is a vague term. So but the patient will be having seizure, speech difficulty, generalized weakness. There must be having some anger management issues. Patient may be having one side of weakness or psychosis. So this is acute altered mental status is not a disease per se, but it is a condition. So before labeling the patient, we should know what are the different terminology we should use for a patient who have to tell a consciousness level. So first thing is conscious. A patient is called conscious when there is a altered attentive, conscious, alert, attentive, and patient is cooperative. When you call patient drowsy, patient is sleepy but can be aroused easily with the external stimuli. Patient is stuporous. When it will call, so appear to be asleep but can be aroused with painful stimuli. Patient is in coma. So patient deeply unconscious, even though you keep on giving deep, painful stimuli, patient is not responding. So whenever we are labeling a patient's consciousness level, we have to label it properly so that the next people will know what was the initial presentation to emergency or in ward, so that the treatment will be given properly. So the common terms for altered sensorium. There are multiple terms we use. patient is called confused when there is a mental and behavioral state of reduced comprehension and coherence and capacity to reason. Patient will call as delirium when there is a acute confusional state defined as relatively acute decline in consciousness that fluctuates over hours. So the hallmark will patient will having attention deficit, he'll having hyperactive or hypoactive. Next thing is the dementia. So impaired cognitive function in a setting of a normal consciousness level. A patient is in amnesia where there is a loss of past memories and to ability to form a new one despite of alert, or a patient is in normal attentiveness. Patient is in psychosis who has lost contact with a reality. So next thing we have to see patient's GCS score. All of you must be knowing GCS score. So the GCS score is calculated based on the eye opening, verbal response and the motor response of the patient. So when you go and ask a person, stand beside the person and see what patient is responding. If he spontaneously open his eye, listening to some sound, he is having 4 score. If he responds to your speech, he score of 3 in eye opening. And if he give pain, he opens, it is score of 2. And if there is no response, it's score of 1. Coming to the verbal response, there is it is out of 5. When you go and ask person, for example, you are asking which year it is. If he responds immediately, that is this year, like which year it is. If he gives the correct year, that means he just score of oriented, it is 5. If he gives year, but some other year he says, that means he is confused and having not able to say the things correctly. If he says something different, inappropriate words, he answered to some other irrelevant things. That means he is inappropriate words, it is score of 3. If it is patient screams, goes and makes some sounds, doesn't respond, that means it is score of 2. And when doesn't respond at all, it is score of 1. Next thing is the motor response. It is also score of 1 to 6. So patient obeys whenever you ask something to do, he obeys, is score of 6. And if we localize the place, so it is score of 5. When you give some pain and withdraws, is score of 4. And if there is an abnormal fraction when you're giving some pain to the patient, is score of 3. And if the extends a response, it is score of 2. If there is no response, is score 1. Next is this altered sensorium or coma. So it is divided mostly when you get a patient of this altered sensorium, we have to examine the patient and we have to find out what is the reason patient is having this. So we have to localize the sign. So localizing sign will help us to know where is the lesion is. Because in our brain there is a tentorium, above the tentorium brain is there, below the tentorium other organs are there. So above tentorium like cardiovascular, cerebrovascular diseases like tumor or abscess, they will be having supratentorial issues. Like in patient having ischemia, patient will be having infarct. So these are the conditions which are supratentorial. Infratentorial, next is if the patient, there is no localizing sign. So it is divided into 2 times. You have to check for the neck stiffness. If there is no neck stiffness, then 2 things. If there is a structural damage like hypoxia, patient is having cardiac arrest, or is encephalitis. If there is a functional neuronal depression, then there may be a hepatic condition, maybe a uremic condition, maybe patient have a seizure and there is a post-ictal stage, or patient is having severe electrolyte imbalances or might have consumed some drug. Then next is if there is a neck stiffness. So you will think about subarachnoid hemorrhage or a meningitis. So any patient comes to altered sensorium, we have to examine and localize the place. Then only it will be easy for us to know what is the medical condition, or is it a separate medical entity or along with the psychiatric things. So other differential diagnosis which come for the acute mental status, patient might have taken alcohol. So we just remember with the mnemonic like AEIOU tips. So thing is there will be alcohol intake, epilepsy, electrolyte, encephalopathy. Patient might have taken some insulin, overdose. Patient having opiates. There might be uremia. Patient might have some trauma or high temperature which is causing this. Patient might have some severe infection, taken some poison or in psychosis, or patient is in shock, patient has stroke, subarachnoid hemorrhage or any special occluding lesions. Next, for these conditions, we have different diagnostic tests. So to differentiate among them, if there is a metabolic or endocrine condition, we have a following tests like rapid glucose test. Patient should take a serum osmolarity. It will help us to know is patient is in decay or in honk. Check for the electrolyte level. Check for the ABG. Check for blood urea nitrogen, creatinine level. Check the thyroid function. So it will help us to know about the metabolic or endocrine condition. If patient is having toxic or a medication related issues, check the level of medications what patient is taking. Do a drug screen. So we have to do a urine drug screen or a blood drug screen. Check the alcohol level. Check the osmolarity of the patient to know the toxic level of alcohol. If it is an infection, we'll see the blood count. We do the urine culture, blood culture. We do a chest X-ray. We do a lumbar puncture to rule out any neuro issues. And remember one thing, that before going for any lumbar puncture, we should do a CT scan to know the pressure inside the brain. So it will help us to avoid the herniation. Next thing is, in any trauma, patient will be having some chest, do a CT scan or a cervical CT, get a X-ray if there is a trauma related to particular part. Then if it is a neurological issue, go for a head CT, if MRI or EEG. If it is a hemodynamical issue, think about cardiac, get a ECG, get a cardiac enzymes done, get a echo done. And sometimes the vessels which is supplying to the brain, get a carotid and vertebral artery ultrasound also. Next thing is evaluation of seizure. So patient with a seizure comes to emergency or in wards, we have to think about, is it an epilepsy seizure or is it not like epilepsy? So if it is a first time, think about low risk and try to find out the history and review it, and then based on that plan the treatment. If it is a high risk one, think about epilepsy, plan the medication. If it is a second time, we have to be very cautious and you have to start the treatment. Next thing is diagnosis. If it is not like epilepsy, there are many medical condition can have. So if it is a medical cause like not seizure like, can be syncope, can be migraine, can be a sleep disorder, or can be a movement disorder. If it's some of the medical condition which can provoke this seizure like episodes, like patient having very high temperature, patient suffering with multiple altered sensorium, patient is having some vascular issues or trauma, patient is having some toxic or metabolic issues. So treat the underlying cause, automatically the things will come down. Or next thing is psychological cause. Next thing is, many times patient comes to us with severe anemia. So anemia, we have to know, basically for PGs and all, patient, if you see a CBP, you find a anemia, you have to be very cautious about what to do next. What are the blood tests or investigation to be sent? Why it is necessary? Because you are the primary person who is handling the patient. By the time you give a cross consultation, doctor will come. At least if you know what are the basic things, you will get this blood test or investigation done. So based on that, the doctor who will come for the consultation later on, he will help you out for further things. If patient is having severe anemia, what are the basic tests we need to send? Generally a CBP with a peripheral smear, it will help us to know. In that MCV, MCH will be there, it will help us to know it is microcytic, hyperchromic or normocytic, or it is a macrocytic. With MCV, we can know which type of anemia patient is suffering with. Then get a retic count done. Retic count will help us to distinguish between a normocytic or it is an extravascular hemolysis issue. So based on that, we can plan further. Next is fever for evaluation. So patient come with fever, generally we give normal paracetamol or give some antibiotic prophylactically, but fever is not coming down. We have to find out what type of fever patient is having. So take the vitals, check for sensorium, try to rule out fever of different type. Fever can be a normal due to bacterial infection, maybe viral infection, maybe because of some other issues which patient is suffering with, can be a urinary tract infection, can be a pneumonia, take a travel history. Nowadays fever with a travel history we are having most commonly with COVID and any other bacterial infection, or the dengue is a common thing and typhoid. So we have to find out. So based on that we do the investigation and try to find the reason for this fever. Next is for the evaluation of shortness of breath. So shortness of breath, patient comes to hospital, that doesn't mean patient has a lung issue. That can be many other multiple things which can cause shortness of breath. If we have to find out what system patient is, what system patient belong to. So which system is affected. If it is a respiratory related, patient can be having asthma, have a COPD or a pneumonia or pulmonary thromboembolism. Patient can have lung tumor, can have a pneumothorax. If it is a RTA or sometimes a spontaneous pneumothorax, patient comes with shortness of breath. There may be aspiration. Many of our patient in psychiatric hospital, they are taking drug, they are drowsy, they take food and they lie down flat. Sometimes they aspirate. So we have to make sure that how can we prevent aspiration, and if we know that aspiration chances are there, we'll prevent those things. Next thing is cardiovascular. In cardiovascular, there is CHF, acute coronary syndrome, valvular heart disease, pulmonary hypertension, arrhythmias, if you think about neuro, there can be a rib fracture, patient having severe pain, having shortness of breath. Patient has massive obesity, the abdominal organ will be pushing up, having shortness of breath. Patient having deformed spine, hyposcoliosis, will having a shortness of breath. Some CNS disorder, some phrenic nerve is injury causing a diaphragm paralysis, having shortness of breath. Systemic condition like anemia, then acute renal failure, metabolic conditions, thyrotoxicosis, cirrhosis, some of the psychogenic conditions like hyperventilation syndrome. Most of the time in our ASA ER, we get patient come with young girls come with hyperventilation syndrome. So they are not shortness of breath. We have to find out the reason. Then psychogenic dyspnea, upper airway obstruction, foreign body aspiration, angioedema, and if there is a swelling epiglottis. Next, let us come to the acute condition for which patient need monitoring, which sometimes they need ICU shift. Most of the time we find in our hospital, the patient go for ECT, they give medication, patient recover, but sometimes they don't recover. They need monitoring, because if those patients, if you shift to ward, it will be difficult for us, because some of the things may miss, we may find patient in a late deteriorated state. So before ECT, we should know what are the side effects. That should be informed to the patient. So immediately after ECT, we should tell patient that you may have nausea, you may have headache, you may have muscle aches. So patient also can get the acute confusion on the day of ECT. So most of it resolves by itself. Next is some of the medication patient may be taking earlier. So we have to tell them this medication should be stopped before going for ECT. So like psychotropic medications, benzodiazepines, sedatives, hypnotics, barbiturates, SSRIs, lithiums, antipsychotics, TCAs, and anticonvulsants. Basically in ECT, we are just artificially creating seizure-like activity for the treatment. So next thing is why we use some of the medications for ECT. So most of the time we use muscle relaxants. So most commonly used muscle relaxant is succinylcholine. So it will help us. Why we use this one? Because it is having a good rapid onset of action and very ultra short acting. Other medications which can be used for ECT are propofol, thiopentol, methotrexate, etomidate, ketamine, alfentanil, and ramifentanil. But if you ask for a gold standard, it is methotrexate all the time, because of its on a rapid onset and recovery with having minimal effect on seizure. So what to monitor? What to monitor after ECT? So always check for the cognitive assessment at least 24 hours after ECT treatment. Presence of severity of deterioration or anterograde amnesia, retrograde amnesia. Post ECT, we should see the airway. If before shifting the patient to wards or to the respective home, check for the airway. If you should make sure that airway is completely airway reflexes come back. Patient breathing normally. There is no bronchospasm. There is no pooling of secretions. Otherwise, patient may aspirate. There is no hyperventilation. Go check for the CVS, connect the monitor, see there is no tachycardia. Sometimes this patient, when we give these drugs for ECT, they go in SVT. So make sure you have enough drugs ready to prevent SVT. Check for the CNS, they should not be getting continuous seizures. Sometimes they may get continuous seizures post ECT. So we have to shift the patient to ICU for monitoring till stabilization. And what are the drugs to be kept ready whenever you plan for ECT, like Zylocard, ondansetron to reduce the gag reflex, glycopyrrole to reduce the secretions, amiodarone if the patient gets SVT, tachycardia and all, we need a beta blocker, and keep an intubation trolley ready and a suction can, so that if any aspiration is coming or anything is coming to the mouth, you can suction it. So most common side effects, we should tell the patient, and we should always see for a nausea, headache, muscle pain, confusion, slight memory loss, and which may last for a few minutes to hours, and it improves. Next topic is dyselectrolemia. So many a time we give medication to the patient and we see the blood reports, and we have to see what are the reason for this dyselectrolemia. So first one is hyponatremia. So when you see a patient having low sodium, that doesn't mean that patient is having low sodium. Always you should see both the things along with the sodium, the water in the plasma. So hyponatremia does not necessarily imply there is low sodium. It is we have to assess the fluid status of the patient, then only we can say if it is hyponatremia or not. So what signs and symptoms you get when patients comes with hyponatremia? They will be having anorexia, nausea, there will be a malaise initially, followed by there will be headache, irritability, confusion. Patient may have a low GCS, seizure-like episodes may come. So always make sure that cardiac failure and edema, that will also indicates the cause. Some of the time they not be hyponatremia, but we get a wrong report. How do you know? Blood sample taken from a drip arm. So whenever patient is having drip in left arm, do not take sample from that. If you take that sample from the drip arm, there may be hyponatremia because of the dilution. So always take from the normal hand where which the drip is not going. Sometimes because of high serum lipid and protein content, the increased volume lead to decrease in sodium concentration. Sometimes hyperglycemic patient will cause this one. Then the iatrogenic hyponatremia. So many times we will be giving patient 5% dextrose in our wards. We think patient is not taking food, let us give 5% dextrose. So what happens is with the only 5% dextrose, if we give without giving a normal saline, this glucose will quickly used by the body and the water will remain. So water will cause reduction in sodium in our body. So and any other patient who are taking thiazide diuretics or women who are premenopausal, who are undergoing psychological stress. So these people having more chances of getting hyponatremia. So next, the management. So whenever we get a patient with hyponatremia, don't think that we should, sodium is low, let us give sodium. It's not like that. We have to treat the underlying cause. What is the reason why there is a hyponatremia? Never treat with sodium concentration. Check for the symptoms, check by the chronicity of the hyponatremia, check the hydration status of the patient, then replace with sodium and water at the same rate what they have lost. Check if there is patient is asymptomatic with a chronic hyponatremia. Check for the fluid status. If patient is having hypervolemic, we may get hyponatremia. Some patients are having acute or symptomatic hyponatremia. So these patients check for if they are dehydrated, gives normal saline, but not correct the changes rapidly, because if you correct the patient with hyponatremia with sodium, patient may develop central pontine myelinolysis. So we have to correct it at a particular rate. If it is a chronic, we should correct in a day 15 millimoles. If it is a acute hyponatremia, we should correct at a rate of 1 millimole per liter per hour. Next is in emergency. Patient may have seizures or coma, so give hypertonic saline. Beware of whenever giving, beware of this heart failure and central pontine myelinolysis. Next is hypernatremia. Hypernatremia means sodium which is more than 145. So check for the symptoms. Patient will be having lethargy, thirst, weakness, irritability, confusion, coma or fit-like activity. So in this there will be an increasing sodium. If you see a CBP report or a RFT report, will be having increased PCV, albumin and increasing urea. So what are the causes? Due to the loss of excess sodium loss, fluid loss without water replacement, like patient having vomiting, diarrhea or burn case, patient having diabetic insipidus, post some head injury or CNS surgery, especially to the pituitary, patient having osmotic diuresis due to diabetic coma, patient is having endocrine issues, or in iatrogenically if we are giving incorrect fluid replacement. So that's why whenever we are giving fluid replacement, be cautious about the fluid replacement for the patient. Next is management. So management for hyponatremia, generally we should not add extra sodium, so we give 5% dextrose. Always monitor the input output, so not overload the patient. Use 0.9% IV if hypovolemic, and this will help for the shift of the sodium. Next is hyperkalemia. When we call a patient hyperkalemia, when it is, what is the normal level of potassium? It is 3.5 to 4.5. When plasma level go more than 6.5, that is a medical emergency. We have to alert our team. So I have to need urgent assessment for the patient and check for, because high potassium can excite the heart. Patient may go in ventricular fibrillation or cardiac arrest. So whenever you find a patient having high potassium, you should be very alert. First assess the patient, check if the patient is well or not. I would always think about artifactual results. There may be a wrong result, so we have to know. So what are the symptoms patient who comes with hyperkalemia? They can have a fast irregular heart rate, they'll be having chest pain, they can complain weakness, there will be a palpitation or lightheadedness. So if you come to see a ECG, you can see this is the normal ECG, the above one. In ECG you can find some changes, like there will be a flat P waves and there will be a prolonged PR interval, the QRS complex is prolonged, and there will be a tall T waves. So always know what are the basic changes we see in hyperkalemia. Next is, many a times we get wrong result. We don't start treating the patient whenever you see high potassium. See for the, if there is a hemolysis, check for the, generally they collect the potassium sample for electrolyte in EDTA bottle. If the EDTA is more in quantity, they may have wrong result. If patient is having high platelet count, they also show hyperkalemia. If blood sample is collected, sent to lab, kept for a long time, and we get a result very late, so then there is a chance of hyperkalemia. So we have to know about these things. Do not go immediately and start treating patient with hyperkalemia. Always check for the artificial results. And what are the causes for hyperkalemia? Patient having low urine output, having a renal issues, patient on drugs like dexamethasone or ACE inhibitor, excess of potassium therapy given to the patient, patient having endocrine issue like Addison's disease, patients having potassium sparing diuretics for the treatment, patient having massive blood transfusion, patient having rhabdomyolysis, or patients with burn come to our hospital or having metabolic acidosis will have hyperkalemia. So hyperkalemia is an emergency condition. We have to treat it immediately, because if potassium goes more than 5 or 6, there is a hyperexcitability of the myocardium which will go in cardiac arrest. So that's why we have to be very cautious when you see a patient with hyperkalemia. So do not wait for the lab result, get a ABG, confirm it is a hyperkalemia. If there is a ECG changes, start with the treatment. So what we give for cardiac stability, we generally use calcium gluconide or calcium chloride. So it will help to reduce the excitability. Then if it is more than 4.5 to 5.5, we can give dextrose insulin. So it will help us to come down in potassium level. Other thing which can be used is salbutamol. So it will help to shift the potassium from intercellular. Next is, if potassium is not coming down with the above line of treatment, potassium is keep on increasing. That means patient is in refractory hyperkalemia. So we have to call a nephrologist, plan for a renal replacement therapy. Next is hypokalemia. So when normal level is 3.5 to 4.5, when the potassium is less than 3.5, we think hypokalemia. So hypokalemia also require urgent treatment, because of patients, cardiac patients who are on digoxin, we have to act fast. Otherwise, patient may go in digoxin toxicity. What signs and symptom patient comes with? Patient comes with muscle weakness. There will be a hypotonemia. When you examine the tone of the patient, there will be hyporeflexia. There will be a cramp complaint. There will be a tetany. Patient may complain of palpitation. They sometimes say they have lightheadedness and constipation. So ECG, we generally find some changes, like there will be a slightly peaked P waves, there will be ST depression, and there will be prominent U waves. So whenever you find these small changes in ECG, alert us so that the potassium correction can be given. And another thing you should remember all the time, that whenever you are doing a potassium correction, many times you give correction, potassium doesn't improve. You give another correction, it doesn't improve. Then you should think, whenever there is a magnesium, also check for the magnesium level. Because when the magnesium level is low, even though you keep on correcting the potassium will not correct. So always correct magnesium level along with the potassium. Coming to the causes, it happens due to diuretic use, due to continuous vomiting and diarrhea. So any patient having vomiting and diarrhea, do send the electrolyte to know about the hypokalemia. Renal tubular failures, in endocrine conditions like Cushing's, alkalosis, patient having this Conn syndrome. Next is, you might have heard about hypokalemic periodic paralysis. Patient comes with weak limbs, unable to get up from bed, weakness lasting for more than 72 hours. That may be because of the potassium shifting from extracellular to intercellular things. What are the treatment for hypokalemia? So it is a basic, everybody, all of us know that for hypokalemia, we give potassium correction. So first try with, if it is a mild hypokalemia, go with potassium supplement. If it is a severe one, we give potassium chloride supplement. And one thing we should remember, whenever you're giving potassium to the patient, never give through peripheral lines, because potassium is very irritating drug which will damage the vessels. So always try for a central line, or if you are giving very less correction, you can give peripherally, but otherwise if you need a very high correction, always need central line. Do not give, because otherwise patient will have a ischemic limb later on. Next is hypercalcemia. Hypercalcemia we see very rarely in our clinical practice. Patients we generally see in a book, it is written that bones, stones, gones with psychic moans. So generally this type of patients comes with abdominal pain, vomiting, constipation, having polyuria, polydipsia, anorexia, depression, weakness, confusion, along with renal stones, renal failure and cardiac arrest. So if you see a ECG, there will be a QT prolongation. So any electrolyte imbalance, if you find a patient, always go for a ECG. So most common causes for hyperkalemia are malignancy or primary hyperparathyroidism. So other conditions are sarcoidosis, vitamin D intoxication. Patients sometimes nowadays many people think that I have vitamin D deficiency, let me keep on taking vitamin D, there is no harm. We should remember the supplements like vitamin A, D, E and K should not be taken blindly. Vitamin B, you can take it because it will come out through urine because it is water soluble. These are not water soluble. So before prescribing somebody vitamin D blindly, try to find out if he is taking this medication earlier or not. Because many patients come to us with hypervitaminosis D. So next is always if you get a hypercalcemia patient, think about malignancy versus primary hyperparathyroidism, because these things will help us to early diagnose the patient from malignancy. And how to know what are the pointers to tell patient is having malignancy. If you see the blood reports, they will be having a decrease in albumin, decrease in chloride, there will be alkalosis in your ABG, there is a decreased potassium, there will be increased phosphate level, increased alkaline phosphatase, increased parathyroid hormone. So these things, if you see, that this will help us to distinguish between malignancy and hyperparathyroidism. Next is treatment. It is calcitonin, calcium mimetics, then bisphosphonate, denosumab, steroids like prednisolone, IV fluids and diuretics. Next is hypocalcemia. So hypocalcemia generally maybe it is an artifact of hypoalbuminemia. So if the albumin is low, we get patients with hypocalcemia. So patient may come with tell us complaints like mild symptoms and severe symptoms. In mild symptoms, they say they have cramps, they have perioral numbness, they have paresthesia feeling. So if there is a severe, you might have seen patients, young kids or 20 to 30 year people having hypocalcemia, they carry with carpal tunnel spasm. They have laryngeal spasm, they have seizure-like activity. Sometimes you might have seen the hands will be like this. We call it as chopstick signs will be there. And if there is a cataract, most commonly for these patients. If we do a ECG for these patients, they will be having long QT. And coming to causes, always check for the phosphorus level along with the calcium. If there is a causes with increase in phosphorus, there will be a chronic kidney disease, there will be hypoparathyroidism, acute rhabdomyolysis or hypomagnesemia. Check if it is normal or decreased phosphate. With hypocalcemia, think about vitamin D deficiency, osteomalacia, acute pancreatitis, overhydration of the patient. And treatment is calcium, and if it's chronic kidney disease, think about giving alpha calciferol. If it is severe symptoms, we have to give calcium gluconate. Next thing is pneumonia. Pneumonia is basically is acute lower respiratory tract infection associated with fever and other signs and symptoms of chest with abnormalities in chest X-ray. So what are the causes? They can be community acquired infections. They can be typical organisms like Streptococcus, Haemophilus influenzae or Moraxella. Atypical organisms like Mycoplasma, Legionella, Chlamydia, maybe due to the gram-negative infections like Coxella burnetii or a viral infections. Sometimes patients are shifted from other hospitals. They have some pneumonia, so they are hospital-acquired pneumonia because of the cross-infection from other patients. So those infections, we have to make sure that when patient is coming to other hospital having some respiratory syndrome or fever, try to send a culture, sputum culture or a throat culture to see for if there is a Pseudomonas. So these are the common organisms we get from hospital-acquired infections like Pseudomonas, Klebsiella or Clostridia. Sometimes patients get aspiration leading to pneumonia. So who get aspiration? Patients who are stroke, patients having myasthenia gravis, having bulbar palsies, having decreased consciousness because of the post-ictal post seizures or intoxicated due to drugs, having esophageal issues, unable to swallow, having achalasia or reflux diseases are most commonly get aspiration. Then coming to immunocompromised patients, if you get any patient who is immunocompromised, see for this organism and like pneumonia, H. influenza, Staph aureus. And like virals, CMV and HSV are most common, and mycobacteria. Coming to clinical features for pneumonia, patient will having fever, rigor will be there, malaise will be there, anorexia, dyspnea. Sometimes they have sputum along with hemoptysis and pleuritic pain. What are the signs we elicit in patients? Patient have temperature, having cyanosis because of hypoxia, have confusion, there will be an increasing respiratory rate, heart rate, there will be hypotension if there is a severe pneumonia. Then do the tests. What are the tests should send for the patient? Any patients coming thinking of pneumonia, send the blood test, get a chest x-ray, get a ABG. In blood test, send normal blood picture, urea, electrolyte, LFT, and CRP. Send the sputum test, send the urine test for Legionella and pneumococcal and urine antigens. Check for the atypical organisms. Check for the respiratory, call for respiratory physician for getting a bronchoscopy if the pneumonia is bad. Check for the curve scoring for the admission of the patient. In curve scoring, we see generally the confusion, urea, respiratory rate, and BP. So based on that, we decide the admission of the patient or not. If the curve scoring of 1 or 2, don't admit. If it is a 3 and above, we admit. So treatment, basically the antibiotic you give prophylactically. Then we think about the culture. Based on the culture or the condition or the exposure, we give the antibiotic. Give oxygen as required. Give IV fluids. Do not make patient dehydrated, because patient with pneumonia will having high respiratory rate. They keep on losing fluid through their respiration. So we have to make sure the fluid should be given properly. Give proper analgesia if there is a pleurisy, chest pain, like pleuritic pain. Consider shifting patient to ICU if there is a shock, if the carbon dioxide is raising, patient is continued to stay in hypoxia. Next is asthma. This is another common disease. So it is due to the chronic inflammatory disorders, due to the airway hyperresponsiveness, due to leading to the variable airflow obstruction. Clinical features, patient comes and tells us with a triad like wheezing, you can hear the sound, or patient says, I have this wheezing sound, they have a cough or dyspnea. There is hyperresponsiveness along with this dyspnea, he has chest tightness and sputum production. Check for the sputums. Check for the always ask the patient, ask for the exacerbation. How frequently the patient is getting these asthma symptoms in a week, in a month, or in a, based on that we can tell how severe the asthma is. If you find the asthma is coming every month or every week, then you have to send to a pulmonologist for a review. Do not think that it is normal, because if you miss it, patient may think it is a normal for him, but it is not normal. So always try to know what are the reasons why the patient this asthma get stimulated, because of the smoke and perfumes, because of the allergens, because of some drugs patient is taking like ASAs, NSAIDs, infections like bronchitis, sinusitis, and sometimes because of the emotional stress, cold air, exercise lead to asthma. So physical examination tells patient having wheezing and prolonged expiratory phase. Check for the exacerbation, see for the respiratory rate, heart rate, see for the accessory muscles of respiration, see for the diaphoresis, how much patient is sweating. Then diagnostic test. So what are the diagnostics we should do generally for asthma patient? If they have done, check it for pulmonary peak expiratory flow rate, check, ask for a spirometry, and if patient is getting asthma regularly, think about sending an allergy test, check for the IgE level, check for the eosinophil levels, do a skin testing or rash testing. So drugs, generally we use beta adenoreceptors like salbutamol, salmeterol. We give corticosteroids. We give anticholinergics, leukotriene receptors like montelukast, gefilukast, and IgE monoclonal antibody like omalizumab. Next common disease we find in our place is UTI. So patient comes with urinary tract infections. That can be a bacteria, so which will be bacteria in urine. Patient may be having symptoms or without symptoms. So all bacteria is not a disease, it is due to the infection. So UTI can be two to three types, like lower UTI, upper UTI. Lower UTI, any infections from bladder down. Any upper UTI, bladder till kidney. So lower UTI, we get bladder infections, prostatitis. Upper UTI, think about pyelonephritis, and abacteria, cystitis, urethral symptoms. Then classification, two types, complicated, uncomplicated. Uncomplicated generally due to the normal renal tract structure or function. Complicated due to the structural functional abnormality along with obstruction, or patient is on catheter, patient have some stone, patient have a neurogenic bladder or had some transplant. So what are the risk factor? Increase in bacterial inoculation during sexual activity, during urinary incontinence, fecal incontinence, and constipation. Decreasing binding urogenic bacteria because the people using spermicide, which causes decreasing estrogen in patient in menopause, they're more prone for UTI. Increasing urine flow due to the dehydration, obstructed urinary tract. Next, what are the symptoms patient comes? They have multiple symptoms based on the place the infection is. If it is in the bladder, we call it cystitis. Patient will have increased frequency of urination, increased urgency. There will be a suprapubic pain, polyuria will be there, sometimes with hematuria. If it is related to kidney, patient may have fever, rigor, there will be a vomiting, there will be a loin pain, tenderness, there will be costovertebral pain, cystitis symptoms or septic shock. If it is due to prostate, mostly in males, they'll be having pain in the perineum, rectum, scrotum, penis, bladder, lower back. So these people will be having along this, they're having fever, malaise, nausea and urinary symptoms. So what signs we should see in these patients? They'll be having fever, abdominal pain, loin tenderness. If there is a kidney issues, check for the bladder. Sometimes due to the obstruction, the bladder distension will be there. So check for the bladder. Check and think about prostate enlargement. And people who are having more vaginal discharges, think about PID, this pelvic inflammatory disorders. So what are the tests? If patient is a non-pregnant, check for the cystitis, check for the vaginal discharge, do a dipstick test, send for a urine culture, send the blood test like complete blood picture, urine and electrolytes, CRP, blood cultures, and get a imaging done for like cystoscopy we do generally. You get a urine dynamic, so if to know the incontinence for the patient, get a CT done if you are not able to find anything, and check for the organism. Most common organism are gram-negative bacteria from bowel and from vaginal flora, and E. coli is the main organism we see most of the time patients 75 to 90% in community, but also in hospital. Then next is dysarrhythmia. So many a time you might have seen patients on psychiatric medications you get an ECG when you find chest pain. We find different type of things. Here I'm not going to teach you the entire ECG, entire things. I just want to tell you about different rhythm what patients are having. So based on that, you can think what is the disease and you can know when to alert the next level, like call it for psychiatric, for the cardiology consultation. So when you are checking the ECG, check for the rate, check for the regular, check the pulse, and also check the rhythm, it is regular or not. Check for the P waves, PQRS. I will tell you in the end about basic ECG reading. So based on this, we will think about when to call for the next level doctors. So here they're just showing you some of the pictures of patients with normal sinus rhythm. The second one is sinus tachycardia. See the RR intervals. Third one is the sinus bradycardia, sinus arrhythmias. So if you find something which is other than normal, and at least you should know what is the rhythm. Next disease which we think about most commonly, we all know by now, we all are expert in COVID. So the basic symptom patient comes with SARI symptoms, respiratory symptoms with fever, and patient will have, we do the physical examination, talk to the exposure, take the travel history, do the rapid CART test or COVID RT-PCR for the confirmation, get the normal basic blood tests like CBP, CRP. Along with that, we do D-dimer, ferritin, LDH, IL-6 and LFT. Some are the markers for inflammation. Some of the tests are to help us to know other things which is associated with COVID. Get a chest X-ray done. If you want to know the correct damage, we get a HRCT chest. If you want to know if there is patient developing hypoxia or not, get a ABG done. And management is symptomatic, along with antivirals, supportive management, plus or minus oxygen requirement. Next condition is acute kidney injury. So many times we vaguely tell patient is AKI. We see a creatinine level and say this patient is having AKI. It's not like that. Always we have to see, when you see a blood reports for a creatinine of any patient, always ask them when they have done a creatinine test earlier. See for the baseline creatinine. And patient can be termed as an AKI when there is an increase in creatinine by more than 0.3 milligram per deciliter within 48 hours. Or increase in serum creatinine 1.5 times the baseline, what his patient was having earlier. And present patient having some blood test done earlier. And next thing to call to a acute kidney injury, check for the urine output. If a person, we generally call if urine output is 0.5 ml per kg per 6 hours. So 0.5 means if a 60 kg person passing urine less than 30 ml per hour, then you can think about to be a AKI. Next, for what is the diagnosis? how do you treat for AKI? Always send the blood test, get a blood urea nitrogen, creatinine, urine analysis, get the imaging, check for the hemodynamic and patient, check for the urine input output, then burn. So patient with AKI always check for the nephrotoxic drugs if they're taking. Make sure if they're taking any nephrotoxic drug, they discontinue those medications. These patients should be encouraged for an enteral route of nutrition. Check for the energy, total intake patient, protein intake should be calculated. If patient is critically ill, make sure you give insulin, because if patient AKI patients having high blood sugar, the infection will get worse. So make sure the blood sugar should be checked and maintained between 110 to 150 by giving insulin or other medications. Check for hyponatremia and make sure patient should not be giving more fluid, more than 1 liter per day. There should not be any volume overload. There should be a salt restriction for the patient. And check for the potassium. These patients tends to have hyperkalemia. Potassium diet restriction should be done. Patient should be off ACE inhibitor, ARB. The antihypertensive medications should not be given potassium sparing diuretics. Check for the ABG, see for metabolic acidosis. If the pH is less than 7.1, think of giving bicarbonate. Check for calcium. This patient tends to have hypokalemia. Try to administer bicarbonate. If you have a hyperphosphatemia, make sure patient should restrict the potassium phosphorus rich diet, add some potassium phosphorus binder. Patients also have hypermagnesemia, avoid magnesium, and check for the medications. Any of the medications patient is having high magnesium, check for the urea level and make the required changes in the drugs. And if even after doing everything, creatinine is keep on increasing, output is not coming, acidosis is worsening, think of dialysis. Next thing is poisoning. So poisoning, there are many types. So one of them is unintestinal or accidental poisoning. So generally we see for young kids. So they take it accidentally in school, in workplace. Sometimes some people take due to drinking toxic fluids. So poisoning by drugs results due to, because sometimes patients are given some drugs, they miscalculate it and take overdose because of confusion. So that, and then some poisonings are deliberate or self-poisoning. So they do it knowingly. Next is non-accidental poisoning. So mostly this kids get affected with that. Some are homicidal poisoning, chemical plant incidents, and because of the drug. So what happens based on different drugs patient takes, we get different type of poisoning. So if you find patient comes to your place having respiratory depression, what drugs you should come to your mind? So generally for respiratory depression, we think opioids or benzodiazepine toxicity. If the patient is hypoglycemic agents. Think about the patient come with constricted pupil. Think about opioids or insecticide like opioid poisoning. If patient has dilated pupil, think about amphetamine, cocaine or tricyclics. If patient come with hyperglycemia, MAOs. Think if patient is having hypoglycemia, think about insulin overdose. Patient on any of the oral hypoglycemic, not taken medications, or over alcohol intake, or on salicylate. If patient need renal replacement, think about salicylate poisoning, paracetamol poisoning, or ethyl glycol. If patient is having metabolic acidosis in ABG, think about alcohol, ethyl glycol, methanol poisoning, paracetamol poisoning, or carbon monoxide poisoning. If you find increase in osmolarity, think about alcohol or ethyl glycol. So in emergency, what are the way we treat the poisoning patient? We check for the ABC, airway, breathing, circulation, check for the airway is clear or not, consider giving ventilation to the patient if required. If there is a hypotension, treat for the shock, check if patient is unconscious. So after assessing the patient, check the history from the family, friends or person who has brought the patient to hospital, do the examination, check for the blood sugar, check for the urea electrolyte, complete blood picture, LFT, INR, ABG, ECG and paracetamol level. If you think there is a paracetamol or a salicylate overdose, check for the urine and serum toxicology if you don't know what the patient might have taken. And then we have to monitor for the temperature, pulse and respiratory rate, blood pressure and oxygen and urine output of the patient. And make sure do the ECG. Sometimes patient with some drugs have some dysarrhythmia. Then plan the treatment according to the type of poison, supportive management, and sometimes if it is not acidic things, we put a rice tube, we do a gastric lavage, and we use sometimes activated charcoal so that it will absorb the thing is inside the stomach. Next condition, most commonly we find hypoglycemia.
Excuse me, sir, we are running out of time, so maybe the last 5 minutes.
Yes, sir. So hypoglycemia. So generally patient comes with symptoms with headache. Generally we see the thing is he's tired. What symptoms patient will tell? He will tell with headache. He will be having irritable. He will be sweating. He will be having tachycardia, having irritability, restlessness, and dizziness. So what are the symptoms? Generally we'll have the headache, visual changes, and if patient is diabetic, check for the diabetic drugs. Patient has beta blocker, and evaluate the patient. And if the patient is hypoglycemia, we have to give 25% dextrose. Next common condition, we know acute gastroenteritis. We have to think about the disease, what type of organism patient got affected. It is bacteria or virus, or due to some food poisoning. Sometimes some of the drugs causes poisoning, causes gastroenteritis, like antibiotics, patient or laxatives, PPI, NSAIDs, or decoxin or alcohol. So based on the things, we send the blood test and the stool test, and we treat it. So these are the investigations, and management will be fluid management and antidiarrheal medications. So many of the time minor trauma patients also we keep in our ICU for monitoring. So that if there is an injury, patient may damage the injury more. So we keep it. So now I'll be talking about some of the drugs which causes ECG changes. So these are the drugs which causes bradycardia. So we have to remember about the bradycardia, drug causing bradycardia, tachycardia. Coming to dyselectrolemia. So there are some of the drugs which causes hyponatremia. So we have to make sure this drugs patient is on. So and you have to avoid these drugs. Then some of the drugs causes drowsiness, antihistamines, muscle relaxants, beta blockers, and benzodiazepines. So then I was thinking of talking about hypertension. Basically, all of us will be knowing about hypertension. So basically, we should know what are the different stages, when to treat the patient, and how to diagnose. So hypertension, this is the classification. So primary, secondary, and this one. And along with, whenever you see hypertension, always think about the other causes like exocrine causes, renal causes, mechanical and endocrine causes. So always remember about these two topics whenever you see a hypertension patient, because patients who are hypertension, there will not be an issue. But patients who are having this hypertension crisis need emergency management. And there is two terminology: hypertension urgency and emergency. In urgency, there will be increasing SBP of more than 160 to 180 and diastolic more than 100 to 120. So those patients doesn't have target organ. Along with this, without organ damage, we call urgency. And hypertension emergency, increasing BP along with target organ damage. So these two things should be immediately treated and with medications. So normal workup, taking the history, physical examination, sending the blood test, and monitoring. Diabetics, we know. So basically, we should know when types of diabetes, two types in the type 1, type 2, due to the defect in the carbohydrate metabolism and the insulin secretions and insulin actions both. So in type 1, there are both two types, LADA and MODY, and type 2 due to the obese, non-obese patients, gestational diabetes and pre-diabetic. So clinical features, we know polyuria, polydipsia. Generally call patient a diabetic when check the blood sugar, fasting postprandial and HbA1c. So many patients who are on diabetic treatment for a long time, not on medications, taking on medications, we don't know what is the diabetic status. Think about sending HbA1c to tell the medication is properly working or not. Decay is another complications of diabetes. Many times we get in a hospital patient taking medications and taking not taking food but taking insulin. So they lead to go to decay. So there are different signs and symptoms and check and decay management is very important because patient may deteriorate. So basically, when you find a patient think about decay, get a urine ketone done, get a CBP, get a ABG, check for the acidosis, and check for the blood sugar, and need a insulin management and fluid management. So ALD, most of us, so just I want to tell last 3 slides about ECG, basics of ECG, all of us should know. So this is a normal ECG. So where there will be PQRST, and when we should call for a doctor for help. So first one is the P1P. So it is arterial contraction, QRS is ventricular contraction, and after S to T is ventricular relaxation. When you find there is any abnormality in P wave or this PR interval or QT interval, we should think of asking for help. So based on this ECG, so when you get an ECG and you find there is a changes in lateral leads, generally we see the ST segment or the T waves. When there is changes, then the abnormal. So if there is a lateral MI, when there is a lead 1 and AVL is involved, when it's 2, 3 and AVF is involved, it is an inferior wall MI. When there is a V1, V2 involved, it is septal MI. And when is the V5, V6 involved. So in this, just check for the 2 things. One is T waves, is it normal or is inverted. Check for the ST segment and how is it elevated. If it is elevated more than 2 boxes, think about MI. X-ray, basic interpretation of X-ray I want to tell you. This is normal X-ray and these are the different places we have to see. This is the clavicle, and many times we think there will be a white color patch seen both sides of the heart. And we think it's some pneumonia, but don't think it is pneumonia. It is the pulmonary vessels going through, or there are some lymph nodes. Okay, and this is the hilum you can see. So where there are most of the vessels divides. So, and you have to see for pneumonia. If you call somebody having pneumonia, see for the lobes. This is the upper lobe, this is the middle lobe, lower lobe, and see for the angles. If the angle is normal or it is blunted. If it is blunted, think about effusions. So this is the 3 different lobes. You can see the upper lobe, middle, right side we have 3 lobes, upper lobe, middle lobe and lower lobe, and left side 2 lobes. Next thing is, last thing, ABG. Many times we get ABG. We have to know the basic interpretation of ABG. Check for these things. Thing is, if with the check for the pH. If the pH is low, think about acidosis. If pH is high, think of alkalosis. If PC with low, if just for example, I'll give you. So sorry, I just brought some examples for you to show if it is acidosis. So basically, to call respiratory metabolic acidosis, the pH should be low. pH should be low. And PCO2 is normal, PO2 oxygen will be normal, bicarbonate will be low. So it is a metabolic acidosis. If metabolic alkalosis, the bicarbonate will be high, pH will be high. Coming to respiratory acidosis, the PCO2 will be high with pH will be low. Coming to respiratory alkalosis, the PCO2 will be low with pH more. So along with ABG, we have to see 3 to 4 points to know what is the fluid status of the patient. Always see for the lactate, because lactate will tell us to know about patient is dehydrated or hyperperfused. Check for the pH and always see for the acid status of the patient. Then so some of the psychotropic drugs I just brought for your knowledge. The drugs causing the SSRI causing hyponatremia, SIDS, some TCS will cause ECG changes like QT prolongations, acute confusional states, seizures and drowsiness. Some of the patients who are giving bupropion, see for the seizure tendency. If you are giving patients with trazodone, check for the priapism. If you are giving sertraline, check for the gastric distress and worsening. If your patient is antipsychotic, always check for the QTC prolongation. If it's atypical psychotics, check for the drowsiness, check for the cholesterol and triglyceride levels. If patient on clonazepam, see for the agranulocytosis, myocarditis. Patient, if there are mood stabilizers, check for drowsiness. If a patient is on any of the lithium, see for diabetes insipidus, do not miss it. And always there is an interaction with hypo and hypothyroidism and patients on alcohol. Thank you.
Rajat, that is one of the comprehensive medical comorbidities in psychiatric disorders presentation. I think you are covered from A to Z. for those of you sitting here who are going to be the future psychiatrists, there are two kinds of psychiatrists. Some of you are working in corporate hospitals, some of you are working in the medical colleges, some of you are private psychiatrists, and a few of the lucky ones are in Asha Hospital where we have an ICU. In fact, not self-praising, but Asha Hospital is probably the only hospital which has a medical ICU setup. But having said this, what he presented in the story to begin with is a real practical experience of what happens in a psychiatric. The first 6 or 7 examples, post-ECT complications and when to shift, all those things. It's overall, though it looks very, very large in content, I think it is a basic medicine which we need to know when to refer, whom to refer, and how much to refer. How much to refer means, you can manage on your own. Hypertension, he has told us, diabetes, he has told us. So with this brief remarks, I think I would request my dear friend Vijay to continue.
We'll take a couple of very quick questions. Postgraduates, anybody?
It's medicine. It's not psychiatry.
Okay, so I think it was really a very, very good and comprehensive presentation. I was just kind of, one thing is in our postgraduate training for psychiatrists, one of the challenges is you either have exclusive mental health establishments, unfortunately, where exposure to medical models, liaising with other specialties is very limited. And psychiatric trainees often get like a 1-month training posting, which I feel is very, very grossly inadequate. The challenge in managing medical morbidities is also to be able to establish a good consultation liaison practice with many other medical specialties. So a strong recommendation for many upcoming PGs is to try and also gain some experience working in CLP units for at least a couple of months, so that also a lot of training for our medical colleagues who do not see much of psychiatry, and because every behavioral presentation is not necessarily a psychiatric illness. So I think liaising with other specialties is probably quite important. One of the things that you mentioned about altered sensorium, delirium, I mean, if you work in a consultation unit, it has different meanings for different people. It could mean anything from comatose, it could mean primary psychiatric illness. So many of these jargons are unfortunately not used very consistently. Obstructive sleep apnea is one of the big challenges that I tend to see in a general hospital setting. 50s, 60s year old people, multiple medical comorbidities, many of our patients on sedatives. So any comments on OSA and...
So people who are OSA, generally they have this one because of their obesity. Okay, so we have to monitor their respiratory patterns. We just do a sleep study for them, and we ask them to put a CPAP or BiPAP during sleep. But what happens is, because of that OSA, they have drowsiness throughout the day, and they go to a doctor. They don't say that they have this issue. Because of OSA, they have the sleepiness, tiredness throughout the day. But once you put this NIV or BiPAP in the night while sleeping, the sleep will be good. So the next day will be completely good. So we have to find out the reason of this and treat it.
I think it's grossly underdiagnosed amongst our thing, but I think a fairly large number of people. So I think if there are no further questions, we'll conclude.
The reason why both of us were chosen as chairpersons is he has large experience in working with the corporate ICUs. In fact, me and Vijay would share quite a lot experience of NMS, missed NMS diagnosed in ICUs, and of course management. Each one of you tomorrow, once you go out, remember you are going to liaison with somebody, and that is the message. And I think we should thank the organizers for selecting this topic as the end. See, the previous topics are all related to psychiatry, but this is very broadly, each one of you should know. Though Rajat, we should congratulate Rajat for being so, I would say, complete and comprehensive, with a touch or a taste of how to manage in a psychiatric nursing hospital, an ICU. With that experience he has come. We congratulate you. Thank you, Thank you very much.
Thank you so much, sir, for such a wonderful presentation. I would now request our chairpersons to present memento to our speaker. I would now request our speaker to present mementos to our chairpersons. Thank you so much, sir. So moving ahead with our program, we are having case discussions now. I would request our moderators for this session, Dr. Anurag Srivastava, Dr. Nageshwar Rao, Dr. Y.S. Srinivas Rao sir, to come on to the dais. Dr. Anurag Srivastava is a professor, HOD of Medicity Institute of Medical Sciences, Hyderabad. He's a psychiatrist and psychoanalytic psychotherapist. He's a General Secretary, Hyderabad Psychiatric Society, 2003 to 2005. Vice President, HPS, 2007. Organizing Secretary of AP Psychon, 2009. Organizing Chairperson, IPS South Zone PGCMA, 2017. Organizing Chairperson of TS PGCMA, 2019. Dr. Nageshwar Rao Nallapareni is a consultant neuropsychiatrist at Recharge Clinic in Tirupati. He is also professor and head of the department psychiatry in Sri Venkateshwara Medical College, Tirupati. Dr. Y.S. Srinivas Rao is a professor of psychiatry, Kakatiya Medical College, Warangal. We have three case discussions being presented by three different presenters. Dr. Uma Maheshwari, second year PG student from IMH. Dr. Satish, pursuing his secondary DNB from Asha Hospital, and Dr. Niharika, pursuing her secondary DNB from Asha Hospital.
Hello. Respected moderators, all the guests, and my dear friends, a very good afternoon. I'm Dr. Uma from IMH. Can I start? So my diagnostic formulation goes like this. A premorbidly well-adjusted 44 years male, Mr. X, studied up to 10th standard, works as a machine operator in a chocolate factory, married, father of one child, hailing from Champapet, urban background, Hindu by religion and belonging to the lower socioeconomic status, with significant history of alcohol dependence in father, no significant past or personal history, was brought by his mother, whose information was reliable and adequate. He presented with a 24 years history of continuous illness with an insidious onset and fluctuating course, with history of alcohol consumption since 24 years, increased since the last 20 days, as his wife had left him due to a quarrel at home, hearing of non-existent voices since 15 days, abusing, assaulting family members, breaking household articles, and fearfulness that someone is coming to kill him since 13 days. Patient has not been going to work since the last 20 days. He's having decreased sleep and appetite and is not taking care of his personal hygiene. His last consumption of alcohol was 540 ml of whiskey one day before admission at IMH. He was treated for similar complaints 1 year back in IMH and has shown complete improvement within 1 month. He remained abstinent for 15 days then and had started consuming alcohol again. No significant findings were found in the general physical examination and systemic examination. Corroborative MSc findings revealed a restless and ill-kept person who had an increased psychomotor activity, who had difficulty in maintaining eye-to-eye contact, and rapport was established with difficulty. The tone and tempo of his speech was normal, volume was increased, reaction time was decreased, and prosody was maintained. He had delusions of persecution on his brother-in-law on his brothers-in-law that they were planning to kill him, which was secondary to the auditory hallucinations. The delusions were fixed and mood congruent. On asking his mood, he said "Bugul bugulga undi," and his affect was fearful, normal in intensity, full range of affective response was present, mobile, congruent, and appropriate, but not labile. He had third person auditory hallucinations, voices of his two brothers-in-law, present almost throughout the day, not present during sleep. And he said that he could hear them discussing to kill him, and the hallucinations were mood congruent. He was oriented to time, place, and person. Attention was arousable, but concentration was not sustained as he was restless and fearful. So, further cognitive function examinations could not be performed. His judgment was impaired and insight was 1/6. Motivation was at pre-contemplation and locus of control was external. With this, I'd like to make a provisional diagnosis of mental and behavioral disorders due to alcohol dependence syndrome, currently psychotic disorder, schizophrenia-like. Points in favor of my diagnosis are that the patient had a strong desire to consume alcohol. He had tried abstaining from alcohol thrice before, but he had developed fearfulness, decreased sleep, and tremors, so he had started consuming again. He had increased from his initial consumption of 90 ml once a week 24 years back to 180 ml daily 18 years back to 540 ml daily currently. He had multiple conflicts with his wife regarding his alcohol consumption and one similar episode of psychosis 1 year back, but patient still could not stop consuming. His onset of symptoms were 20 days back when he was consuming alcohol, and his psychotic symptoms were in a clear consciousness and were fixed, not transient. So this is in favor of induced psychosis. I would like to admit the patient in view of multiple past failed attempts at detoxification, and because
Hang on a minute. First of all, I can't follow you at this rate. So I'm going to ask you a few more questions. I don't know, rest of my colleagues are able to follow. I can't follow. I'm considerably slowed down. I was a slow person to begin with, so I can't follow at this rate. So you have presented only a formulation. I was
Yes, sir.
told that you will present a formulation only. So a few points I want to understand, because without that I cannot make sense of this, right? So you said that there is an insidious onset,
Yeah.
and there is a variable course of illness. I need you to tell me a little bit about that. What do you mean by that?
So patient started consuming alcohol 24 years back when he was working in his brother's alcohol factory. His brother owned an alcohol shop and a soda shop. So patient started consuming alcohol because he had made new acquaintances with business people they had insisted him on drinking, and he was also curious. So he had started consumption back then. He had started with occasional consumption of 90 ml of whiskey, and then he had increased the consumption to the present levels.
What is occasional?
He was consuming once a week or once fortnightly back then 90 ml of whiskey because he was having physical strains at work, and he felt that the consumption of whiskey was relieving him and he could fall asleep. But then he increased the consumption to 90 ml of whiskey every day, and then to 180 ml of whiskey, which he was continuously drinking twice, once a year back and once currently when his wife and he had quarrels and she left home. He increased the consumption to around 360 to 540 ml of whiskey, which was there since the last 20 days.
No,
that's why I said
every day?
Every day.
So he
since
went
the
from
last 20
90
days.
ml once a week. Sorry, say that again.
No, 90 ml once a week to 180 ml once a week was what he was consuming throughout. And in between, when the stressors were more, he was consuming around 360 ml per day since the last 20 days.
So in the last 20 days, he has been drinking daily, and that is 360 ml.
360 to
for the
540
last-
ml.
Yeah, before that, for the last, say, 20 years or so, he was only drinking once a week.
180 ml every day.
180 ml every day.
Every day.
When did that everyday thing start?
20 years back. For the initial 4 years, he was drinking only 180 ml once a week or once a fortnight. And then he started drinking 180 ml every day. Patient attributes it to saying that since marriage, patient and his wife were trying to bear a child, but they were not able to bear a child. And then he had multiple failed ventures at occupation. So he's attributing to these two factors that he started drinking 180 ml every day.
Very well. A little bit about the voices and the fearfulness.
Yes, sir. So, in patient's terms, patient says that he can hear his Bamardlu's voices which are discussing among themselves to planning to kill the patient. So he was very frightened. What he did was, actually, when his wife left him, he had started the increased consumption, and when she came back that day, she found that he
We'll
was very
stay with the
fearful.
voices, beta. Anything else you want to add about the voices?
Yeah. So at night, when the patient and his wife were sleeping, the wife found out that some police officers brought the patient back. He had wandered away. He was knocking at everyone's doors and asking if his brothers-in-law were present in their house, asking if they were hiding in those other houses. So he was acting out on his hallucinations.
These voices are since 20 days, you said?
15 days, yeah.
15 days, right?
So throughout your presentation, the couldn't establish. So was it aggravating or was it relieving? During intoxication, what was happening to the psychosis?
Psychosis. He started hearing of voices since 15 days, which was present throughout the day. And then he developed his suspiciousness, which was around 13, 14. After he started hearing voices, he developed suspiciousness and fearfulness, and he started being abusive with his wife because he was having suspiciousness on his brothers-in-law.
So then the other thing is, in your diagnostic formulation, you brought about in the word clear sensorium.
Yeah.
In the MSc, you said that you could establish cognition. See, not
Attention was arousable, but I could not, like, his concentration could not be maintained because he was restless.
having said that, being not able to concentrate, you established so much psychopathology. So how is it possible?
Because he was saying that he could hear voices and he was suspicious. He was saying someone is going to come and kill me. He was preoccupied with that, so I could not perform other.
In the formulation, you said that there is clear sensorium.
Yeah.
So that cognition should have been better.
Yeah, it's a very good summary. In fact, the ability of an individual is known by the ability to summarize. So it's excellent that IMH students are doing very well. It should be because of the very good training from the teachers. One thing you should have added is a little about the physical examination and other things. And it's nice that you have spoken about the locus of control and motivation and all these things. If you have added that physical examination, what would have happened is we would have seen the medical comorbidities also in this, and some impact on finances and the other legal aspects.
Yeah, he had.
And in the history also, you should add one word about suicide always. We should, whether that is present or not, is very important in a psychiatric history. Otherwise, it's really good. You have done very well.
Examination. How did you report mood?
And I asked him how he and his effect.
What should I make out from that, Peter? That is, first of all, this is a mental status examination. The purpose of mental status examination is that your report should be understandable by everybody. So this doesn't, what should I make of this?
Patient is saying that he's feeling fearful.
So now mood is fearful?
No,
Want to define mood? It's all right, take your time. You want a chair?
No, I'm
You want some water?
No, I'm fine.
Vodka? No? Okay.
I'm fine.
So relax. Define mood.
Is this it's the subjective.
It's all right. Don't worry. I know you know what mood is. You're just anxious. No? That's all right. But the thing is that if you say that the patient said that he's feeling fearful. That is not helping me to understand what mood is in this. Nah? So mood has to be on the euthymia to dysphoria, depression, anhedonia, elevated, expansive, euphoric, exaltation, unio mystica. That scale has to be visible in MSc.
Okay.
That has to be visible. What did you say about the voices? You said that this is third person hallucination.
Yes, sir.
Third person hallucination, it's a Schneiderian
First
symptom?
rank symptom. Yes, sir.
All right. How do you explain that in person with whom you are saying this is alcohol-induced psychosis basically, right? That's what you said, right?
Yes, sir.
How do you explain third person hallucination?
So actually, what the patient described was that he could.
I'm not doubting that it is third person hallucination. It is third person hallucination. Why is an alcohol-induced psychosis having third person hallucination?
So,
is there any difference between second person, third person hallucination? What is the difference?
Etiology.
Okay, etiology. What is the difference in etiology?
That second person auditory hallucinations can be seen in other etiological factors
Excellent.
like depressive
Why is
psychosis.
that? Very good. Wonderful. Why is that?
Because it's secondary to what he thinks, like
No, third person hallucinations are quintessential.
for schizophrenia.
Thought. Okay. Very well. What about you said there is delusion of persecution, which is secondary to
Auditory
auditory hallucination, right?
Yeah.
So first of the thing is that when you're describing the auditory hallucination, you want to give a little more detail. Has he heard it once, twice?
Yes,
How
sir.
long is it?
present
Where is the
almost-
voice coming from? Is it clear?
Objectives.
Whether how far away is it? Can he stop the voice? Can he start the voice? Does he talk back to the voice? Does he obey the voice? Does he like the voice? Does he dislike the voice? You want to give some more details?
Yes, sir. So he can hear two familiar voices of his brothers-in-law discussing among themselves and plotting against the patient to kill him, present almost throughout the day from the external objective space and not present during the sleep. And the hallucinations were mood congruent.
How are they plotting to kill him?
He said that whatever amount of money it takes, we are going to kill him. That's all. He did not give a description into it about how they were plotting to kill him.
Any motive?
Yes, sir. So since marriage, he has been demanding money from his wife, and that was one of the reasons for their constant conflicts. So there has been conflicts between his brothers-in-law and him since the beginning, and now 20 days back when his wife had gone home, that was also because there was a fight between his brothers-in-laws and him. So there has been constant fights between them.
So there's a motive in the voice, or there's a motive in his story?
In his perception of in his thought that he thinks that the brothers-in-law might kill him.
So the auditory hallucination is secondary to the thought, or the delusion is secondary to the hallucination?
The delusion is secondary to the auditory hallucination.
How do you know that?
Because he said that he could hear the voices first, and then that lasted for 2 days, and then he developed the suspiciousness.
Okay, I think Dr. Nageshwar Rao has pointed out that the crucial thing here is the sensorium clear?
Yes, sir.
Okay. How will you distinguish? So what is the other possibility that the person is in?
Withdrawal.
Delirium?
Withdrawal, delirium.
Withdrawal, delirium. Voices started. So he was intoxicated. Intoxication delirium or withdrawal delirium?
No, sir. Voices were present. Patient drinks only in the evenings. Patient consumes alcohol only in the evening, and voices were present throughout the day, even when he was not consuming alcohol.
So in alcohol intoxication delirium, the person has to drink throughout the day in order to hear voices?
That's not what I meant.
All right. So you have said that he has been drinking every day since the last 20 days. There is an abrupt increase in the amount of alcohol he is drinking. He is in intoxication, and I say that this is because of alcohol intoxication that he is having these voices. You are saying that no, this is a psychosis. This is the crucial question here. This is a crucial question here, right?
Because
How do you support that these voices are because of psychosis and not because of alcohol intoxication delirium?
yes, sir. One is that the other features of alcohol intoxication were not found.
No, stay with the voices.
Okay. The voices were present even after the patient had stopped consuming alcohol, and they were present throughout the period of admission that the patient was there. They were present for almost 1 week even after the patient had stopped consuming alcohol, which would not have happened if it was intoxication voices. And also that the patient had a clear conscience when there was voices, so there was no delirium.
Is there any situation in which there is a clear consciousness and still patient is hallucinating in alcohol?
Alcoholic hallucinosis.
So is this alcoholic hallucinosis?
Yes, sir. It can be considered as
Hallucinosis, is it psychosis? Are they the same thing? Hallucination, hallucinosis, are they the same thing? In your opinion?
No, sir.
This alcohol intoxication, delirium, if I say, the only thing is that right now, so you have examined him after he was admitted,
Yeah.
after he has had some stabilization,
Yeah.
and so his sensorium has cleared.
Yeah.
Can you go back and say that the sensorium was clear then?
No.
So there's a differential diagnosis needed in this?
Yes.
No? Why do you think this fellow has developed psychosis now?
He had one episode of psychosis previously also, sir, when he was admitted 1 year back and he was treated, but he was not abstinent. He started consuming again and he increased now.
I think the point is clear that
Yes, sir.
So what sir is trying to tell you is so that you should understand. So in any presentation, any examination, there will be different sort of examiners will be facing. So one will be critical, one will be supporting you, one will be precise. So you should be able to accustom to whatever examination pattern you are into it, but you should maintain your
Yes, sir.
confidence that continuously. So how do you manage this patient?
Yes. So I'd like to admit the patient because he had previous failed attempts of detoxification because he has psychosis, and also because he's a potential harm to his family members because of his abusing, assaulting nature. After I admit, I would like to do various diagnostic tests. I would like to get a complete blood test.
So Mental Health Care Act talk about anything about this admission? Because you said he is not having an insight.
Yes, sir.
And he is not willing for admission. He doesn't have insight.
Yes, sir. So on an emergency basis, we can admit him for a period of 12 hours because he's being a harm to others. But he does not have a nominative representative because that's not been done. So
Not wanting to give up alcohol is one of the reasons you said you want to admit him.
yes.
Can you do that?
No. I mean, yeah. I'd like to get a complete blood picture or a renal function test with serum electrolytes, liver function tests, RBS, and PT and INR. I'd also like to apply some scales on him, like alcohol use disorder identification test. His scoring in audit was 27, and SIVA, that is, his score was 12. So initially, I would like to detox the patient. As he's consuming around 21 units of around 14 to 21 units, which is 360 to 540 ml of whiskey. So he's consuming around 21 units of alcohol. So according to Maudsley, he needs 84 milligrams of chlorodiazepoxide. So I'd like to start with 25 milligrams of chlorodiazepoxide 4 times a day and taper it over a period of 7 days. I'd also like to add thiamine. Because his consumption is more than 15 units, he needs IM thiamine, that is parental thiamine also, 200 to 300 milligrams for 3 to 5 days, and then oral thiamine for a period of 3 months, that is 100 milligrams per day. I'd also like to make sure that he maintains hydration. So constantly check for his BP and keep him hydrated and monitor for his psychotic symptoms.
How did you calculate the dose of chlorodiazepam oxide?
So according to Maudsley, 20 milligrams, if the patient is consuming 20 units of alcohol, then he requires 20 milligrams of chlorodiazepam oxide 3 times a day. 4 times a day, sorry. He requires 20 milligrams of chlorodiazepam oxide 4 times a day. So, and also according to the SIVA scores, if it's a moderately, if the patient is in moderate withdrawal, which is a score of 9 to 15, he can be started with 80 milligrams per day of chlorodiazepam oxide. Long-term management of the patient, I would like to do some brief intervention initially following the FRAMES model, which is give him feedback about his alcohol use, and then see if he's willing to take responsibility for his action, advise him about the harms that, about his scores and the harms that alcohol is causing to him, and then give him a menu of options about the different things that he can do, be empathetic with him, not be judgmental, and teach him self-efficacy, which is going to help him in long run. And then I'd like to assess for motivation again, because this was in the initial days, and after he's gone through all of this, I'd want to assess his motivation again and do some motivation enhancement therapy. I'd also, for abstinence, I'd like to add naltrexone for the patient.
Low socioeconomic status.
Yes.
IMH is giving naltrexone free?
Yes, sir.
That is why, yeah. In the real world, what will you do?
Yeah, I can.
Naltrexone, do you know how much it costs?
Yes, sir.
How much does it
10
cost?
tablets are 250. Yeah.
10 tablets, 250 rupees, beta?
Yeah.
No. No. At least I
I may
don't
be
think
wrong.
so. I may be wrong also on that, but I don't think so. So, apart from IMH, what will you do? Naltrexone, he will not be able to afford.
Yes, sir.
Think of something else.
Since his renal function and liver function both were normal, we can go with acamprosate. And he's not, even on the day of discharge, he was not very motivated to quit. So I'd like to avoid disulfiram. Also because he has psychotic symptoms and disulfiram has a potential to cause psychosis, I'd prefer to avoid disulfiram.
Antipsychotic in your acute detoxification phase. You
Yes,
want
sir.
to revise that a bit?
Actually, sir,
You want to give antipsychotic or not?
according to the guidelines that I went through,
Forget
they
the
were not
guidelines.
talking
What
about
do you want to do?
antipsychotics, but we generally give antipsychotics in IMH.
Why guidelines say don't give antipsychotics in alcohol-induced psychotic disorder? Which
Yes, sir.
guideline is that, beta?
Sir, Maudsley and IPS both do not mention antipsychotics.
No. IPS I know.
No, sir.
So in alcohol-induced psychotic disorder, no antipsychotic?
Yes, sir.
I will call you out on that.
Yes, sir.
Where does it say that? I'm sorry, I don't agree with that. Maudsley, I don't know. So it may be wrong on that. If there's an alcohol-induced psychotic disorder, no antipsychotic. I will forget IPS guideline then they are wrong. They are wrong, right? What would you do?
I would like to start with the 2 milligrams of risperidone initially, sir. Because according to the studies that I went through, risperidone has been shown to have good efficacy in alcohol-induced psychosis.
Any
and the other,
antipsychotic will have. Okay,
yeah.
risperidone.
And the other antipsychotics like haloperidol and olanzapine have a seizure-lowering threshold, so I would like to avoid. Which is what,
Haloperidol you want to avoid because of its seizure-lowering threshold.
in the initial few days, Maudsley says not to give haloperidol, sir. So I thought.
But haloperidol we avoid not because of its seizure-inducing potential. Haloperidol has a low seizure-inducing potential unless haloperidol has also changed since my time. You know, haloperidol does not have a big seizure-inducing potential. If a Maudsley is saying that, then Maudsley is wrong. Yeah, I don't know if they are saying that they shouldn't do that. You should avoid it because you might be wanting to avoid EPS, something like that, so you don't want to do it in that is all right. How long do you want to continue the antipsychotic?
Till for not more than 6 months, sir, only till the symptoms are persisting. And after the symptoms are recovered, then I wouldn't want to continue antipsychotics.
Pre-motivational, we'll go with that. He's in the pre-motivational stage. In 1 or 2 minutes, what are you going to say to this guy?
Sir, first thing is to be empathetic with him and not be judgmental. And then,
Set frames, frames.
yeah.
Now you say what you will say to this guy. He says that I have no problem. I only got they dragged me here, madam. There's no problem. I've been drinking for 20 years. I'm fine.
I'd like to point out the various conflicts that he has in his house and how alcohol has been affecting him, the social implications that it is causing. Also, he has been changing various jobs and he couldn't go to work for these 20 days also, and about how his economic status also will be affected by his consumption of alcohol, and also later about the psychotic symptoms that it's causing, so that it can further lead to other complications, medical complications.
What effect do you anticipate this information will have on the patient?
Sir?
What do you think all of this is going to have an effect on the patient? What do you anticipate? The patient may say, madam, thank you for telling me all this. I'm going to give up alcohol. One thing is this. Other things you will say, okay, madam, can I go now?
Yeah.
No. So what is going to happen, do you think?
I can hope that
Hope is a wonderful thing, beta. We are surviving on hope only. You are right about that. Very well. Thank you.
Thank you, sir.
So you generally we hope that he will come back. So what is the status of first rank symptoms in ICD-11 or DSM-5?
First rank symptoms are not considered in DSM-5 or ICD-11, sir.
Okay. So anyhow, that was a good presentation.
Thank you, sir.
Thank you.
Thanks.
It's an excellent presentation. Once again, I congratulate IMH people because they're training postgraduates very well. They're doing this very nicely.
Thanks.
Okay.
Good afternoon, everyone. I'm Dr. Satish, DNB resident from Asha Hospital. I'll be presenting a short case followed by a diagnostic formulation. So the client is a 12-year-old girl currently doing her 6th grade from a Telugu bar English speaking Hindu background.
One second. You have 15 minutes time only for presentation.
Okay.
You should be presenting diagnostic formulation and brief MSc. That's all. Salient findings in MSc, diagnosis and differential diagnosis.
Okay. So the diagnosis doing her 6th grade, Telugu or English speaking, living with her parents and a younger sister. Progressive in nature, characterized by persecutory belief that evil spirit is inside the body and trying to harm her, hearing of a non-existent voices of devil, and she has become socially withdrawn, muttering to self, decreased self-care, altered biofunctions and impaired occupational functioning. She has a family history of probable OCD bar OCPD in maternal uncle, medical history of cat bite at 1 year of age, dog bite few weeks ago, and tonsillitis for the last few days. Her temperament is slow to warm up. Birth and developmental history is significant for unsupervision during the till 6 months of gestation, and received category B drug, which is metformin, during this period. And during natal, it was a lower section cesarean section delivery. and low birth weight of 2.3 kgs, and postnatally she developed neonatal jaundice and received phototherapy. And physical state examination were revealed underweight, which is BMI of 18, and bilaterally enlarged tonsils. Rest were within normal limits. Her mental state examination, general appearance was thin built and fairly kempt. Separation from the mother was with cautious. Manner of relation to the examiner was she was cooperative, but at times she was preoccupied and muttering. When asked about what it was, she was guarded about the same. Motor activity, facial expressions were decreased. No non-adaptive movements were seen. Attention and concentration. Attention was aroused but not sustained, and she was oriented to time, place, and person. Memory, immediate were intact. Recent memory and remote memory was also intact. Reading and writing, she could write a simple sentence without no reversals or inversions. Speech and language, normal rate, tone, reaction time, good comprehension, fluent, audible, intensity, in a relaxed manner with no deviations noted. Her thought process, form of thought was normal, stream of thought was linear and goal directive. Content of thought, patient says evil spirit is inside her body trying to harm her, which was false, fixed, not keeping in his socio-cultural and educational background, persist in spite of evidence to the contrary. With this I infer she has delusion of persecution. And very magical thinking, she feels that by drinking water she can get the evil spirit out of her body. And possession of thought was normal. Perception, she's hearing of two non-existent voices of both two evil spirit and God in clear consciousness from outer subjective space. With this I infer she has auditory hallucinations. Affect, she has anxious affect, restricted, stable, reactive, appropriate to the content of the interview and congruent to the thought. When I asked about 3 wishes, she said she has to get rid of the evil spirit away from her body, and God should be with her, and she should have very good intelligence. Overall, her intelligence, she was able to comprehend, do simple arithmetic calculations. With this, I infer clinically her intelligence. Judgment impaired. Social was also impaired. Test judgment was normal. She had grade 1 insight. I would, in diagnostic formulation, I would like to conceptualize the etiology of this case from a chronology. Predisposing factor is family history of probable psychiatric illness in the family, and neonatal birth precipitating factor, query stressor related to change in environment, that is school. Perpetuating factor being her temperament of the child, that is she is slow to warm up. With this, I would like to provide a differential provisional diagnosis of psychosis not otherwise specified, medical diagnosis of tonsillitis and recent dog bite and past history of cat bite. Different schizophrenia, and the points for the diagnosis is she has well systematized delusions and hallucinations and decline in socio-occupational functioning. Points against are she's a female gender, acute onset, and more of positive symptoms and negative symptoms. Usually in early onset schizophrenia, it is more of insidious onset of negative symptoms. Management.
In the intelligence, why did you not talk about abstraction?
I did, so I forgot to mention about it. Similarities, differences, and the proverb test.
How is your abstraction? Is it normal or
It's
abnormal?
like concrete level, sir.
Concrete level. So did she develop that hypothetical deductive thinking? What
I
is
didn't
hypothetical
specifically
deductive
test
thinking?
for that, sir.
What is that hypothetical deductive thinking?
As per Piaget's developmental stages, after 12 years, I think, patient develops a hypothetical detective thinking. This is with the hypothesis, they should able to abstract and come to a detect and come to a conclusion.
So unless that is there, you can't tell about abstraction. So,
Okay,
so
sir.
how is her abstraction now at the 12 years of age?
Maybe maybe the stage before of hypothetical detective thinking, that stage she would have that pre-operational she would have achieved, sir.
No, is she able to abstract or not?
No, sir, concrete levels.
No, at what age this thinking is developed?
After 14, the early
14?
teenage.
Till 14 it won't develop? Okay, fine.
Not sure about the age.
You said that change of school is a precipitating factor. I don't think every child whose school is changed is going to go into psychotic illness.
Actually, that's a stressor that I have to clarify, sir. Basically, this patient got admitted. I interviewed her only twice at the time of admission. Just I built her some rapport and then clarified some history. So being a child, I have to strengthen my rapport and clarify for some more things. It's just a query I put as that because there's a temporal correlation of onset of these symptoms and change of school. Maybe
Yes.
that could have been a precipitating is just a like I'm conceptualizing, but I'm not very sure about that.
What is your diagnosis? You said first diagnosis?
Psychosis NOS.
Psychosis NOS. Why NOS?
Because two things I've not clarified fully. Next thing is in child, the clinical picture varies drastically. So I don't want to label her as schizophrenia right away when I see her. So just 1 month of symptoms. So during serial MSCs and clarifying further psychopathology, I can come to a conclusion. But for now, I can keep a provisional diagnosis of psychosis. This is what I thought. Not otherwise specified.
Yeah. Why? Thank you. Why do you say it is not otherwise specified? On what grounds? The grounds cannot be that in the future the course may change.
Mhm.
That cannot be ground for not otherwise specified. Or you cannot say that in this I don't want to label her. This is also a label. NOS is also a label. This is not ground for not otherwise specified. On what? When do you say it is not otherwise specified?
Not fitting on the criteria for schizophrenia.
Is it
or
not fitting? In your MSc, is it not fitting?
I have a favorable points for schizophrenia, sir. Early onset.
You tell why it is not fitting. That is more appropriate here. Because you have pointed out auditory hallucinations, you have pointed out delusion, you have pointed out some disorganization of behavior also. And yet it is not fitting. What more do you want?
Against points are age factor. It's very rare, 1 in 1 lakh.
Age factor
prevalence.
for diagnosis, is it an exclusion? Does it say in any system that you cannot diagnose schizophrenia in a person who is 12 years of age?
So all the socio-demographic factors and the clinical
Beta, for the diagnosis, socio-demographic factors cannot be exclusions.
And one more thing, acute onset, sir, and more of positive symptoms.
All of these are excluding a diagnosis of psychosis.
Against points are not excluding.
So why is it against? NOS, that diagnosis is, when is it made? You said you wanted to make a provisional diagnosis, is it?
Yes.
Provisional or tentative?
Provisional diagnosis.
What is the difference between provisional and tentative?
Provisional diagnosis is from the information till now we have got, what is the conclusion we can come,
Right.
and we need some extra information to come to a diagnosis.
What is tentative?
Tentative, not sure, sir.
So I think whatever the points you are trying to impress upon to say that this doesn't come under schizophrenia or psychosis. So you want to not to label it. So that should not be the situation. So how was the rapport?
It's very superficial, sir.
So rapport you couldn't establish.
It's little difficult. One being a child, and she was mostly preoccupied during the sessions. She was muttering, and when asked about what she was muttering, she was guarded. So it's very superficial rapport.
So you said hallucinations were outer subjective space, and whereas something was there inside. Was the voice coming from inside?
No, sir. From her, through her ears, she was
You
able
said
to.
dual voices. One is from God, one is from
Evil
devil
spirit.
inside.
Yes, sir. God's voice and
Both.
different God's voice and all. That's delusion, sir. That evil spirit is inside her. But voices.
The evil spirit is inside.
That is talking.
Sir is asking that evil spirit, when it is speaking, is it speaking from inside? That is what sir
She
is asking.
explains that speaking from inside, but she is able to hear through her ears.
If the spirit is speaking from inside, or in external space.
If it is speaking inside, she says she through her ears.
Is it internal space or external space?
That is internal space.
Sure. Beta, the person is hearing a voice coming from her chest.
Then internal space.
This place, your faith is in this. It is still external space. Why? Internal space is only within
Brain, mind.
That is what sir is trying to.
Oh.
Word carries meaning. So you said outer space. So that word should be clarified. There could be some hallucinations. What type of hallucinations you expect? Did you inquire about those things?
The evil spirit was inside her mind and hearing voices. Other than that, she was not controlling her feelings, emotions, or movements. No, nothing was.
Was she able to feel any sensations from
No,
inside?
sir.
No sensations.
No sensation.
You said that 1 month history is there, correct?
Yes.
Initially, it started with saying that there is evil spirit inside her. Then she started hearing voices. You said after some time, after a few days, she started muttering to herself.
Yes, sir.
This is acute onset?
The first symptom started 1 month before.
Is the onset acute? First, the patient has started hearing voices. First the patient has said I hear voices. Some days later, she has started muttering. These are all evolving symptoms.
Yes, sir.
Why is it acute?
How do you define onset?
Either abrupt.
Define onset. See, from the starting of the symptom to the development of the syndrome, the duration is called onset. It's not just the start of symptom. Say today I started hearing voices. It does not mean it is acute onset. Till the development of syndrome, say suppose schizophrenia patient is there, for the entire syndrome of schizophrenia to develop, the duration that is called onset.
Okay.
Not one symptom. Okay. It's the same thing with hepatitis also. Today he starts with malaise and he gets all the symptoms of hepatitis after say 15 days, 20 days. So that entire duration is what is called onset.
Okay.
Start of symptom to the development of entire syndrome. Okay.
Okay.
When was the dog bite?
June first weeks. Like
Is it today?
3 weeks before.
3 weeks before. This whole symptomatology started when?
May 3rd week.
So dog bite happened
After that.
After that?
After that.
You give any importance to that dog bite?
There is no temporal correlation, sir.
There was a cat bite sometime back. That was long time back. Huh?
At 1 year of age.
1 year of age. Dog bite happened few weeks, you said actually. So I felt it is before.
No.
You didn't say few weeks. I heard that wrong.
I said few weeks. That is June first week, sir. Symptoms 1 month before.
Because this implies that the dog bite happened before. Okay. So some evil spirit had entered, but after that now she is muttering to herself. There's voices also. She seems to be agitated and disturbed, and there's a dog bite.
That muttering in the last few days, and agitation, restlessness, all those things, last few days.
So does that trigger something in your mind?
Can be some organicity, but no other
Some
symptoms
organicity,
of,
like there's a dog bite and this, what
no other
organicity?
symptoms of rabies, or fear of light or water.
Light,
all those things was on
okay.
this.
So that will develop progressively, or in one day everything will develop?
Progressively.
Is there a possibility here?
Might be.
All right. In the MSc, you have first described about the general appearance. After you said that cooperative, you said that she's cooperative, you said.
Yes, sir.
Cooperative and rapport could not be established. Basically, you are saying that there's something wrong with my technique then. Then after that, you described psychomotor activity. You did not mention eye contact. Then you described orientation, memory. After that, you went to thought form and content. Then you went to mood. Then you went to perception. Then you went to affect. Then judgment and insight. So I am already confused, beta. You are trying to confuse me further. What is going on? Why are we jumping like this?
Actually, it is CMC's child performer, so I followed that performer. So it was given in this order.
Affect is after perception. Mood is. So thought, mood, perception, affect.
I didn't mention about mood, so it was thought, perception, and affect.
You didn't mention mood at all?
No, sir.
Is that a good thing or a bad thing?
I was explaining under mood and affect. I explained only about affects.
So after perception, you went to mood. Which system you are following?
CMC's performance.
I will look it up. Spell that for me. C.
Christian Medical College, their performer, sir.
Christian Medical College is saying affect after. Management.
Management, non-pharmac management. I would like to admit the patient under supported admission in view of severity of symptoms, vitals monitoring, blood investigation. I would like to do a complete blood picture, liver function test, creatinine, lipid profile, thyroid function, and random sugar. And I would like to get a physician opinion regarding the dog bite and for tonsillitis, and rate her on various rating scales like BPRS.
Why do you want a lipid profile in a 12-year-old girl?
I'm planning to start an antipsychotic, sir. So I want to have a baseline lipid profile. With the bystander, allow them to ventilate and acknowledge their distress, psychoeducate them regarding the cause, nature, and prognosis of the illness, Pharmacologically, I would like to start on an antipsychotic drug. I would like to prefer to start on olanzapine. I would like to start very low and go slow. I'd like to start 2.5 mg HSOD, slowly titrate once in 2 days depending upon the side effect and tolerability. I would start on a low dose benzodiazepine for agitation, restlessness and sleep. I would like to add a tablet lorazepam 0.5 in the morning, 1 mg in the night. And continuation phase, non-pharmac, I would like to strengthen the rapport, serial mental state examinations and clarify the psychopathology further. Watch for any drug-related side effects like EPS. With the family, elicit their model of illness and psychoeducate regarding...
You are anticipating EPS with olanzapine?
Possible, sir.
Why is that?
Though it's atypical, olanzapine, risperidone all can produce extrapyramidal
Olanzapine and risperidone have same receptor binding profile?
No, sir, different.
You want to revise that a little bit? How does olanzapine binding to dopamine receptor family differ? Now you are going against EPS.
But
if the olanzapine has a greater affinity for D1, D4, D5, and then D2, how on earth is it going to cause EPS?
It's like some D2 activity is also there.
How much D2 activity is required to produce EPS?
60% of D2 receptor occupancy should be there to produce EPS.
Not for EPS. That is for efficacy, right? For EPS?
80%.
80%. You expect 80% receptor occupancy with olanzapine on D2 receptor?
No, sir.
And 5-HT2 binding, 2A binding is strong, you said? Will that help EPS or cause EPS?
Help with EPS.
So, why are you, so you are saying something which you have memorized from a book? All right. But we are not even listening to ourselves what we are saying in that.
Okay.
Very well.
Which antipsychotic is usually preferred in children, if at all you are starting an antipsychotic for this child?
Preferably second generation antipsychotics.
No, among second generation also, which antipsychotic as per FDA guidelines are?
Olanzapine, aripiprazole, and risperidone also we can use.
Which has more evidence?
Not sure.
And why benzodiazepine 1.5 milligrams? Because the child is
Morning is mild restlessness. Is
no,
there.
already olanzapine causes morning. So the child will continuously sleep for 24 hours and then have a problem, right?
Yes, sir.
So why benzodiazepines again? And in this still because the child did not develop abstraction and other things, we do not know whether it is a possession state and she is feeling she is God and devil, and then because of her fantasy thinking she is thinking that it is hallucinations. So we should be careful, and we cannot directly come to a conclusion that it is a psychotic illness unless we establish these delusions and hallucinations very clearly, because it's a very young child.
Yes.
And the use of benzodiazepines also again in the daytime and other things are usually not preferred when it's not required. Okay.
Okay.
She's already diabetic.
Right now, I don't have any
Gestation.
blood parameters, sir. Gestational. Actually, mother had PCOD, sir. So she was taking metformin,
The mother was
500 BD. Yes, sir.
She's not diabetic.
She's not diabetic. She had PCOD.
So any special rule in Mental Health Care Act regarding admitting a child?
Actually, under Section 87, we have to admit minor patients.
What does it? What does it say?
Says we have to admit, and a child should be examined by 2 psychiatrists, also 1 medical practitioner within the day of admission or 7 days after the admission. And if we have a nominative representative, we can become a nominative representative.
It has a nominated.
No, sir. No, sir. Or else from the parents.
No, in this kit, sir is asking.
Parents. Parents.
So even after admission, you should intimate the same, the review board. So did you examine the patient alone or with the parent?
With the mother.
So did you take consent from both mother and child?
Yes, sir.
Child gave consent?
Yes, sir.
Is it valid?
Both mother and child gave
If the child gives a consent, is it valid?
for physical examination.
Any examination?
No, no, sir. Thank you, sir.
Having said that raised case, but still could have been worked up. Probably you didn't have time.
Yes.
Okay, it's good presentation.
Reading the diagnosis part.
Thank you, sir.
Good afternoon, all. I'm Dr. Niharika, DNB resident from Asha Hospital. Start this. Mr. K, a 48-year-old married Hindu male, studied up to intermediate, runs a grocery store owned by the family, currently not working for the last 20 days, belonging to middle socioeconomic strata family of semi-urban background. Is a diagnosed case of hypertension on regular treatment for the last 4 years. Pre-morbid personality is suggestive of cluster C traits. Came to the hospital with wife, informants being self and wife, whose information is adequate and reliable. Presented with an illness of total duration of 35 days of acute onset and continuous course, preceded by a stressful situation at home, presented with chief complaints of hearing of non-existent voices, causing him to appear lost and preoccupied, and remaining unmindful of his surroundings, recurrent intrusive thoughts against God, and recurrent intrusive thoughts of sexual nature, reduced focus and concentration on work, and disturbed sleep. The patient is currently taking treatment for the last 12 days. He is on tablet risperidone 3 mg per day and tablet fluoxetine 20 mg per day. His physical examination is grossly within normal limits. On mental status examination, he's a middle-aged man, was appropriately dressed, moderately groomed and well-kempt. He was appearing appropriate to age, came voluntarily for interview. Appearance was anxious. There was no abnormal posturing or movements. Attitude was cooperative. Eye contact maintained. Rapport was established with ease. His psychomotor activity was mildly increased and he was fidgeting. Speech, there was increased tone, normal reaction time and normal productivity, and it was relevant. His mood, he said he was worried and anxious. His affect was anxious, appropriate, communicable and reactive. Thought, form was normal, stream was linear and goal directed. his content had increased worries regarding the stressful situation back home and regarding his health. Possession had obsessive thoughts, which were blasphemous thoughts and of sexual theme. He said that he got repeated thoughts about negative things about God. He didn't wish to think so, but he was unable to stop them. And he was even getting an urge to use abusive language against the gods. There were also some thoughts which were recurrent which were of sexual nature regarding the gods and as well as other women. He was confused and perplexed. He didn't know why it was happening, and he felt guilty regarding it, and kept assuring that he didn't have any such intentions. Perception, he had second person auditory hallucinations. He said that he could hear voices of 4 people, out of which he could recognize the voices of 3 of them, claiming to be people from his family and friends. They were talking to him directly, asking him to follow their instructions, like going somewhere, sitting at a place, coming to a place, going out of the house. They also asked him once if he would harm himself. They would promise him that the gods would bless him and they would stop talking to him if he agreed to the voices. He said that initially he believed them to be true, but now he feels silly as to how he could believe them. But he claims to be still hearing them, especially when he's alone and idle, and he tries to distract himself by going out of the house when he hears these voices. His test judgment and social judgment were intact. Personal judgment was impaired, and he had an insight of grade 3. I would like to make a provisional diagnosis of psychosis not otherwise specified with obsessive compulsive disorder, predominantly obsessional thoughts, along with a medical diagnosis of hypertension. I would like to make a differential diagnosis of acute and transient psychotic disorder, schizophrenia-like, with associated with a stressor, along with obsessive compulsive disorder, predominantly obsessional thoughts, along with hypertension.
You said stress was precipitating. How do you decide about it?
Prior to the onset of these symptoms, for around a duration of 1 week to 10 days, he was very preoccupied and very worried regarding a property that he was in a dilemma whether to sell it or not, and constantly he would be worried about the same, and his sleep disturbances also started from then itself. Even in the middle of the night, he would get up worried and anxious whether he's making a right decision or not. That period was extremely stressful, even at home, was what he claims. And even the family members report that.
So were there any compulsions?
No, sir. No compulsive behaviors were seen.
He wasn't trying to stop those obsessions.
He would get very distressed and he would feel guilty, but he was not trying to stop them. He didn't actually know what to do with it.
He was yielding completely.
Sorry,
He didn't try to stop.
He didn't try to stop them. Only thing is he would, even the voices as well as the obsessive thoughts, he would just try to distract himself from them. But no compulsions were developed as such.
So you said the anxiety features were predominant on observation.
Yes,
Did you
sir.
examine for any symptoms of hypertension? What was the blood pressure?
Blood pressure
pulse
was normal, sir. It was 126/80. He's already a diagnosed case of hypertension on regular treatment for the last 4 years. Pre-morbidly, I've found him to be having some anxious personality
Pulse
traits.
rate is normal? Pulse rate.
Pulse rate was 88, sir.
So command hallucinations were there.
Yes, sir.
He was yielding or?
He was yielding to them in the beginning. For the last 12 days, he's been on treatment, and now he claims, now it feels like he has insight into the hallucinations, that they are not true and that he shouldn't believe them. But initially, now he acknowledges that initially he was believing them.
Okay.
And
So
now
you
he
said
feels silly that.
acute psychosis,
Yes, sir.
that the duration fit into the for this?
Duration, yes, sir. The onset was within 2 weeks, and there is.
What is the duration now?
Now it's 35 days, sir.
Can we have it? Even after
So recovery can take up to 6 to 8 weeks.
so you want to still hold that it is acute psychosis.
Sorry, sir.
After 1 month, we should make a diagnosis.
Can be seen as we can see that there's some insight that has developed into the hallucinations, and probably take it as a response that is.
You are still saying it's NOS.
Yes, sir, because I would still like to see how the course of the illness is, whether it is any other symptoms are going to develop, or this. I have seen the patient on an outpatient basis, so this was just the first interaction I have had with him.
See, anywhere on the trying to diagnose a case, we don't try to look into the how prognosis will be, how we want to predict things. Based on that, I want to make a diagnosis.
Yes, sir.
The diagnosis is what we make on examining the patient and taking history proper.
Yes, sir. Sir, since he has only second person auditory hallucinations, it is not really fitting into the criteria of schizophrenia as well.
So, okay.
So hence I was thinking psychosis, NOS.
Can it be a depression with psychosis? Severe depression?
It is possible, sir, but he has not
predominantly
really
there was a
met.
stress. There was a stress.
There was a stress.
Worry is there. Then
Yes, sir. But there were no other depressive symptoms or symptoms that were falling into the criteria of a depressive episode as such, sir.
what did you look for? What were not there?
Sir, any pervasive dullness of mood. There was loss of concentration in his work. That was one thing.
So that worry was not there.
Worries were there, sir.
Then?
As such, he was even his behavior at home.
What are the three major criteria?
Persistent and pervasive low mood, reduced interest and concentration, and the reduced psychomotor activity, gross retardation of psychomotor.
Sure.
They see me, are you feeling tired or you feeling fresh? Are you feeling?
Talk about energy or?
Energy levels. Yes.
Not concentration, it about interest.
Yes, interest in
Okay.
previously pleasurable activities.
Nothing was there here?
Nothing that was dominating the picture, sir. So all secondary to these symptoms.
So in fact, what is dominating the picture is very important here.
Yes,
so
sir.
about the voices.
Yes, sir.
Look, what are they like? How often does he hear them? How long do they last? How does he react to them? How much is it dominating his mind and the clinical picture? That is crucial here.
Yes, sir.
You
In
want to tell
terms
a
of
little bit?
frequency, it was quite frequent. He would say almost. He said that he wouldn't be able to calculate the number of times they would be present throughout the day, even at night. even at night they would be so disturbing that he would not have adequate sleep. The family members would see that he's been pacing around inside the house trying to distract himself. There was no replying back to the voices. And the characteristics of the voices, he could identify that one of them was his brother-in-law, one of them was his friend, and another one was a distant relative. So he could recognize those voices.
So the voices have started suddenly.
Yes, sir.
Okay. First of all, thank you for slowing down the speed so that I can at least understand what is going on in this. You said that the information is adequate and reliable,
Yes, sir.
right? So adequate and reliable are on the same level?
On the same?
Level. For example, reliability is judged by
By factors
adequacy,
such as
adequacy and consistency.
consistency.
So adequacy and consistency are on the same level. Reliability is on a higher level. So adequate and reliable is not the appropriate way to report that. Also, thank you for mentioning about grooming and dressing, because in the 3 presentations, this is the first time that has happened. Now the mood, what did you say the mood was?
Anxious and worried.
All right. Now the thing here is that if you are going to, so there was a discussion about major depressive disorder with psychotic features, right? Severe
yes.
with psychotic features. Unless you are going to take a stand on dysphoria, depression, anhedonia, elevation and all, if you don't take a stand on that, diagnosing mood disorders becomes difficult. Because in the diagnostic criteria for depression, as sir, mood, a depressed mood is one of the important criteria. For mania, it is inevitable. You have to say that the mood has been elevated or irritable.
Yes, sir.
If you do not comment on the mood like this, you are going to make it very difficult for yourself to diagnose any mood disorder. So we should not, like take the easy way out and say that he's worried. Okay, he's worried, but that doesn't help you in your diagnostic formulation. Now, that you have to take care of. You said that he has cluster C personality traits. Which particular ones?
Sir, anxious personality traits as well as some anancastic personality traits was what I found.
So that becomes interesting because anancastic is there and now
Yes, sir.
obsessive thoughts are there. So
Yes, sir.
what is going on
So,
there?
prior to the onset of these symptoms, he would be very particular and preoccupied about cleanliness as such, but that wouldn't be distressing to him. He would be having some.
Anancastic people are worried about cleanliness. Personality, you're talking about personality
Yes, sir.
traits, right?
Yes, sir. So not just cleanliness, even all other things. He wanted things to be done in a particular way, in a particular fashion, and he wouldn't be very flexible about it.
So OCPD
Yes.
versus OCD, they don't have that much in common as you're thinking. Symptom wise, presentation wise, no? They are different. It's how a person thinks, about. So now you see what is happening here is that you are going with sort of 2 diagnoses. You said there's a psychosis NOS along with that OCD. Are we looking at 2 different diagnoses, or you are looking at one diagnosis in a particular stage where you are having a mixed picture? Are you going to give this guy 2 diagnoses is what I'm asking.
Sir, at this moment, with the information we have and the course that we know up till now, this seems to be appropriate at this point, sir.
I will give you a further direction in this. So you said that this person has got obsessive thoughts, right? How do you distinguish between obsessive thoughts and overvalued ideas? Obsessive thoughts and overvalued ideas, how do you distinguish? Because overvalued ideas can be on the psychosis spectrum.
Oh, yes.
So, and obsessive thoughts are on OCD spectrum. How do you distinguish between obsessive thoughts and overvalued ideas?
So here, these thoughts that he is having, he doesn't intend to think so. They are
When you're asked the difference, then you should say that this is present in this, but not in that. So, intent to think is not present in obsessive thoughts. Is it present in overvalued ideas? Intent. No, it is not. Let me answer that for you. So, that is not a distinguishing feature. That is not a distinguishing feature. If I say, how do you distinguish between this watch and this pen? You cannot say that they are made of steel. That is similar to both of them, right? Yeah.
So the level of distress that is caused.
Where is it? How will you distinguish between obsessive thought and overvalued idea as far as distress is concerned?
In the obsessive thought, since the person doesn't want.
The distress is more?
More. Sir.
So where do you decide
Again,
what is more or
depending-
not more? Who decides? You decide, I decide, Gauri Devi madam decides. Who decides?
So I can't put it on a scale as such, but maybe it will depend on the content of the overvalued idea
But can you distinguish based on distress?
No, sir, not exactly.
Anything else?
It's repetitive in nature, the nature of.
Which one is not
intrusion.
repetitive? Overvalued ideas are not repetitive? Very well, I'll answer that question for you, okay? Otherwise, it looks like you're just being as smart, I don't want to use that word. You are being an overactive fellow in this. The distinction is like this. In obsessive thoughts, the person is worried about the intrusive nature of the thought. That why is the thought coming to me? Why is the thought coming to me? And I don't like this thought, in the initial stages at least. In overvalued ideas, the person never questions the thought. He never thinks that why am I thinking that those people are talking about me? I don't want to think that those people are talking about me. He is worried about the content. Are those people talking about me or not? I think they are talking about me. They are not talking about me. So you see, the intrusive nature of the thought is prominent in obsessive compulsive disorder, while the content is prominent in overvalued ideas. Very well. You further said that he has now gained an insight into his hallucination thanks to the 3 milligrams of risperidone, I presume. Right? All right. So currently he has an insight into his hallucination?
Completely, I wouldn't say partially.
Partial insight is there. Very wonderful. Excellent. So in your mental status examination, you want to call it a hallucination still, if there is partial insight? There was this fellow, Jasper's fellow, long time back. He complicated a lot of things for us. Nah? So now if you think of that, do you still want to call it a hallucination? What is not as clear as a hallucination? Next step will be? Step down?
Pseudo
Pseudo-hallucination. Very excellent. Wonderful. Is this a pseudo-hallucination? Now, currently.
Can call it, sir.
You want to go with pseudo-hallucination? Don't let me intimidate you, beta. I am not here to intimidate you. I am asking if you can distinguish between these two criteria. Don't think that, oh, sir is saying that, oh my God, now I have to go with it. No, not at all. It's about phenomenology here. In psychiatry, we have only phenomenology. We don't have, we talk about all the nice things and everything, but nobody can diagnose based on a PET scan, right? So we have to depend on phenomenology still. Maybe in a few years, you people will see something nice and we can get rid of all this nonsense. But right now we are stuck with it. So how do you distinguish between a pseudo hallucination and hallucination?
So one thing, the insight that we spoke about.
What about the insight we have?
It's present in pseudo hallucination.
Then what is the difference between pseudo hallucination and imagery? Both insight are present there also. No?
Imagery is under a voluntary.
Insight, regarding insight.
Yes, sir. Regarding
There's a
insight.
nuance about the insight in pseudo hallucination. An insight may be lost during the hallucination, but is generally regained when the voice stops. So this fellow is where?
Exactly, I'm not sure, sir.
Very well, doesn't it?
Yes.
Management.
So he's already on tablet risperidone and tablet fluoxetine.
That
But
may or may not be right. You go ahead with what you would want to do.
I would want to continue those.
It's not on any tablet. We'll begin from there.
So firstly, I would want to treat him as an outpatient itself. I would start on an antipsychotic.
So you think primarily this is a psychosis?
Yes. Tablet risperidone I would like to start with 2 mg, and I will gradually optimize it depending on the symptoms. And for the OCD, I would like to start tablet fluoxetine.
Why fluoxetine?
Sir, it's one of the first line drugs approved for OCD.
The typical answer to that in all examinations, you can say it is an FDA approved drug. They are our lords and masters. So if you say it's an FDA approved drug for OCD, nobody can argue with that. So just say that. It's an FDA approved treatment for obsessive compulsive disorder. Very well. Any other advantage of fluoxetine? It's cheap.
Cheap.
It has got a long range. You can keep on going up and telling yourself that I will go to a higher dose, it will work. I will go to a higher dose, it will work. Makes us feel better for 2 months. Until it doesn't work, then we are not feeling that good. So we can titrate it up. Right? Anything disadvantageous about fluoxetine as a drug in this patient for the obsessive symptoms?
The anxiety.
You were, when you were in class 2 beta, which section were you in? You don't remember? Was it B? Were you in class 2B? Was it roll number 6? No. Class 3 was it A? Cytochrome P450 system. Something fluoxetine does there. Don't be anxious. It's alright. Relax. Nothing is going to happen here. Nothing is going to happen here. Fluoxetine messes with the 2B6 and 3A4.
Yes, sir.
What will it do to the levels of risperidone?
Increase.
It will increase. Wonderful. How much will it increase? Approximately.
How much? I'm not sure.
1.5.
1.5.
Generally, it increases by that much. So if you are giving 3 milligrams of risperidone, 20 milligrams fluoxetine, it's like giving 4.5 milligrams of risperidone. Why do you want to choose a drug which has got
interactions?
So risperidone is metabolized by 2D6 or 3A4?
2D6.
2D6? Now you want to use another drug which has got more 3A4 problems?
No.
Fluvoxamine?
No.
No, you don't want to use. Very well. What, if not fluoxetine, what would you use?
Sertraline I can start, sir.
Sertraline is a good drug. What about clomipramine? Why not clomipramine?
I would first optimize sertraline and maybe use clomipramine as an augmenting agent if required.
Clomipramine is an augmenting agent. That is like saying Madhuri Dixit is now supporting actress. Why not clomipramine as a primary drug?
Yes, sir.
Because of side effects. Constipation,
Anticholinergics.
But clomipramine, the magic of clomipramine is that it rarely fails. It rarely fails to give side effects also. But it rarely fails to work. Clomipramine. Any danger with clomipramine? Person takes 200 tablets of fluoxetine. Person takes 200 tablets of clomipramine all at one go. Which is more dangerous? Clomipramine is more dangerous. Anyway, we'll stop. Don't get anxious. You know this or this because clomipramine can be dangerous in overdose. It's a class 2A anti-arrhythmic agent. It can cause heart block. Stop transmission. It can cause, and free the ventricle, lead to ventricular arrhythmia. Right?
Very good presentation. Only thing is, there is so much of distress, so much of worry, blasphemous thoughts are there, and commanding hallucinations are there. You did not mention about one very important thing. What is that?
Self-harm.
Self-harm and suicide. See, you should talk about having suicidal thoughts or not, because can suicide occur in OCD?
Yes, sir.
So you should
Yes.
talk about suicide here.
Yes.
Okay. In the interesting cases, again, Asha Hospital has got two very good interesting cases. That's nice that you are presenting.
Thank you, sir.
And the difficulty is the difference between an obsession and a delusion. This obsession delusion continuum, what you say. So after you have started fluoxetine and all these things, in which doses do you expect response for these patients?
60 to 80 if it is fluoxetine. Sertraline 150 to 300.
So it's a different doses from the anxiety disorders. So there you get in a lower doses, and here you get in a higher doses.
Higher doses.
Now, what is this current status of OCD in DSM-5?
It is a separate entity, sir.
Why is it separated? Can you throw a light?
Initially, it was under the all other anxiety disorders, since there is anxiety and distress along with these obsessions and compulsions. But now it is conceptualized to be a different entity because of its nature, different nature, the intrusiveness of the thoughts.
What else? What else was it?
It's a thought phenomenon. The corticostriato-thalamocortical loop was.
Is that involved in anxiety disorder?
No, sir. The amygdala circuit is involved.
Anyhow, this whole exercise is to make you understand that will be what sort of examination pattern will be experiencing with the Viva and practicals. But having said that, this we are trying to be little diplomatic here. But in a closed, you will be alone, and there will be 4 examiners, will be bombarded. So anyhow, whatever it may be, you are representing what you are taught throughout 3 years, and don't lose your confidence in that. So whatever it is, we are trying to test what knowledge you are having. That having said that, examiners' tendency is to make themselves happy that I asked a question which she hasn't answered. That that ego satisfaction the examiner wants to have. Let them have. You say no, I don't know. Once in a while, it's a good thing. Having said, I don't know, sir. So anyhow, I thank the organizers, Madam Dr. Gauridevi, Madam, for having us here, and so it's a good thing. And I thank my co-moderators, Dr. Anurag and Dr. Srinivas.
So first of all, I would like to congratulate our 3 presenters. It is an act of great bravery to come in front of so many people and face the examiners. Most of us don't even want to face examiners in our MD exam, and you are doing that before. It is extraordinary. It is very good. As Sarah said, that don't get anxious in the exam. You present what you have learned. You present what you have learned, and what you have done all these 3 years. That is all that is required. Nothing more is required. Nothing more is required in that. And what Sir said. So there is a saying for that. Any fool can ask a question which the wisest of men cannot answer. So it's easy for me to sit here and ask some damn fool question which you're thinking that, oh my God, how to answer this. Some people will want that you can't answer that question. I don't think, in psychiatry, I don't think that is there so much. Psychiatrists are generally gentle people. they're not looking to do these things. They know how difficult, how we are all in the same boat. So thank you. And this last question about whether the OCD has been moved out of anxiety disorders and given its own thing, that is actually in line with psychoanalytic thinking. Psychoanalytic thinking always saw OCD as belonging to a different category than anxiety disorders. It was lumped together in an unhappy marriage by DSM, which has now been divorced, thankfully. Madam, please. We are here because of you.
No, this exercise is not only for the examination point of view, but I mean, I think facing Anurag and you three people, especially Anurag, I'm sure all three will do very well because the anxiety is gone. It's like a flooding, I would say. The second thing which I won't blame both PGs from Asha because, the two cases which I gave is day before evening, especially when I'm in a hurry, I happen to see the child. And for the benefit of PGs, I'm just telling, this child came with the abnormal behavior and, laughing to self and all psychotic symptoms. And then suddenly mother told that she's not swallowing, she's not eating for the past 24 hours and she's not drinking. That I became panicky. Whether I'm dealing with the case of rabies with, behavioral symptoms. Immediately I call. I mean, the mother was saying that I'm worried that she may die because she's not. Then I really got frightened because I was, just to tell you, I was reminded of a case when I was in Imans as a PG student. I happened to see a man who has been alcoholic for quite some time and suddenly he stopped alcohol and he had abnormal behavior. So it's like we call walk-in workup. In 20 minutes you are supposed to do. So what I did is I wanted to see the fundus. I switched off and then there was a startled response for the patient. Then I was that something struck me. I brought some water and gave it to him. He could not, like he has been taking alcohol because the history of dog bite. When I asked, 6 weeks he was bitten by the dog. Bitten by alcohol and he started already developing rabies. IDH hospital in Bangalore, I followed him up and he died of rabies. So this child literally frightened me. And because we need to think about it, the reason why I'm saying is you need to think why somebody stopped drinking. Anyway, I called the physician in HDU. She came and said she's got huge enlarged tonsils. That's the reason she's not. Then I was literally, and then when I took the history, it is after she started having this psychotic behavior, she started playing with the dog. In the sense, she was poking the dog and things like that. She was bitten by the dog. So then I was assured that it's not rabies. This is something which I just want the PGs to learn about it, the comorbidity, because we all had comorbidity. Sometimes maybe the case I was discussing is psychosis is there, dog bite is there, and so patient developed the thing. And this child had the tonsillitis, which literally I was frightened. So, and I just gave him yesterday only, because the child was taking treatment in HDU. Maybe he didn't have enough time to talk to. It's not justification, but I just want, the idea of presenting is this. Another case she presented is, the person has, as you rightly pointed out, obsessive traits. Right from the beginning, he is, not flexible, and anarchistic traits are there. And he developed with the problem. He has got financial issues, and then he want to sell off the things, and hallucinations or delusions. You try to look at it. It's about the property, and these people are not supporting him. So it's a temporal correlation to the problem which he has. And he's an obsessive man. He doesn't want to do anything. And he developed a breakdown for a while. And after starting antipsychotics, he fairly cleared. But he started developing the, blasphemous thoughts and other things. This is something which I want to say that a comorbidity, we are talking about it. Morning also, like when he was talking about schizophrenia, he was telling people can have premorbid symptoms. You need to take that also into consideration, especially in child psychiatry. the temperamental traits, or even in adults, the childhood trauma or the personality traits are also important, which can color the psychosis or, the obsessional symptoms. Thank you for giving me opportunity to say something. Thank you, chairpersons.
Thank you for having us here.
Thank you, madam. Thank you, our moderators. It was a wonderful session. We would love to say thanks and felicitate all our moderators on the stage. I request Dr. Gauri Devi, madam, to kindly hand over the mementos and certificates to Dr. Anurag Srivastav.
I mean, the youngsters, I think many of you may not know that what a legendary figure Dr. Viviana is. Not only has she been an academician, when she was in IMET, she brought about so many changes. She strived so hard to make things different. And I remember her I know her for 22 years. And I remember her from the very beginning that she is one of the sharpest minds that you will see in psychiatry. She's become very quiet these days, madam. She was always, I remember, our great Majid Khan Sahib, he would never forget, Gauri, come here, come to the front seat. Always he would ask her to come, because her contributions were like that. The legendary figure, madam, I'm very honored you thought of me. Thank you. Thank you.
Dr. We would also like to call upon the presenters, Dr. Uma Maheshwari. Dr. Satish. Dr. Niharika. Thank you, sir. Thank you, ma'am. We'll be departing for lunch break. We are planning to join back by 2 p.m. for free paper presentations. Those who are presenting papers, please report at front desk to Dr. Amulya. Yeah. Which course?
At least tell them that to assemble 5 minutes before so that we'll tell you the hall.
We have to decide based upon the number of
No, we have 8 people. First 4 would be in hall, this main hall. Other 4 will go into the Mangira hall.
So free paper presentations are divided into 2 halls. One is this main hall and other is Manjira halls. So just report 5 minutes before so we can let you know where the presentations are going on.
Dr. Sai Krishna and Dr. Vishal, sir. Thank you, sir. We will be having validity function in next 5 minutes. We will be having valedictory function within 5 minutes. Till then, refreshment, tea and refreshment is served. So you can have it.
Hello. Request you to please have the tea and snacks at backside only. It's available on backside. Inside hall, backside.
Good evening, everyone, and welcome to the most important and concluding session of 2 days academic program, postgraduate training program. I request everyone to please occupy the front seats. All the students, please come to front. Your opinions about this 2 days program is much awaited. Please occupy the front seats, please. I would like to invite on dais Dr. Uday Kumar sir, President-elect IPS South Zone Branch. Dr. Kishan sir, Chief Guest of the today's program. Dr. Gangaram sir, Dr. Ramasubba Reddy sir, immediate past president, Telangana State Branch. Dr. Sai Krishna sir, Editor General, Telangana State Branch. Dr. Vishal Akula sir, Mental Health Awareness Committee, IPS Telangana State Branch. Dr. Gauri Devi Madam, Organizing Chairman for PGCME. Dr. Chaitanya Deepak sir, Organizing Secretary, PGCME Program. Thank you, sir and madam, for joining today. I would like to request now Dr. Uday sir to do the further proceedings of the valedictory function.
Heartfelt thanks to the ASHA team of Hyderabad, especially the organizers, Dr. Magaru, Gauri Devi Garu, and Deepak, Sweta, Saqib, and the whole team of ASHA group. And from the day one, they had taken this event. We were very happy about they being taking it, because we all know that they are really authentic people, and then they must have done n number of events like this. We were not skeptical about this being go bad or good. Really, we were very happy for giving this event to this ASHA team actually. And then especially we felt very happy about Madam has taken this event into a heart and doing this event. I was actually, South Zone Branch was little skeptical about this theme is actually meant for really practitioners who are practicing already. This theme is not suitable for students actually, because you have all just started learning psychiatry. You may not know what this kind of term at all, comorbidity is. But I think Madam has really proved that this theme is really, really useful for the students even, because you get sensitized of this theme, so that you would go and learn, read more about this, so that you will know psychiatry is not so simple, because it is always a complexity with a lot of issues in, especially when you try to understand and even try to treat the patient. I think Madam has chosen the best possible young Turks of speakers. Hope they have delivered very nicely. All of them were spellbound. I really enjoyed. I think, I believe that you have enjoyed those deliberations. Are you? Yes. I think, I don't know how Madam has chosen these speakers. Definitely they have done justice. Few of them, I think, not come. Even then they have delivered their best of their work through online. And the kind of hospitality is, and the food and everything, I think the best. The anchors Sweta and Saqib and Ajay. Ajay, I usually forget. Yes. Because he's my like a son. I thought I should not miss his name today. Ajay, I think these anchors have done really best to the event. And the day one, I have seen all the office bearers of local branch, Telangana Psychiatric Society branch office bearers. They're all with the organizers the day one. It's not the day one of this event. Since they have taken this event, they are associated with these organizers. I think Vishal and Ramsubba Reddy Garu, George Reddy, Sai Kiran, all of them are with these people to support this event. I am very lucky that our chief guest, Dr. Kishan Garu, the ex South Zone President and Professor of Pratima Medical College, Karimnagar. He is a gem of a person who wishes all these kinds of events to go in success. I think he is always with us to bless this events. I'm very happy that he is with us today as chief guest. And we have Ramsubba Reddy Garu representing TSB Society of Society as in place of George Reddy. Vishal, Sai Kiran is South Zone's CME committee, one of the members. Since Arvind, CME chairman, not come, I think he is representing CME committee of South Zone, and he is the one who has selected this theme and then the speakers also. Vishal, Akula, is the hero of Nizamabad. Not only Nizamabad, I think he is extending towards Hyderabad. National hero. He is as the Community Mental Health Awareness Committee chairman of TSB. And I think from bottom of my heart, I extend my thanks to the Sun Pharmaceutical companies. I think whole team of national team, state team, and everybody are here. I think they are the one for the last 20 years, sir, of South Zone CME. More than 20 years, I think they are the ones who have taken this task of doing South Zone PGCME is their property, like. And then ever since they have taken, I think, followed up every time they are doing it. And this being the one of them, I think whole team of Sun Pharma, I thank all of you, sir. for getting many number of students from their travel, accommodation, and everything you have taken up. I think probably you may take up this task of doing these events forever, I think. Yes, sir? Yes. I think hats off to you. Salute to you too. Sun Pharma being the best one amongst all the best ones of pharmaceutical companies. I believe so. Thank you, Sun Pharma. I would request now to say a few words by Ram Subbareddy garu.
Thank you, Uday, and good afternoon to all. And actually, this time, the South Zone gave permission to organize the CME to the Telangana State Branch. And when they asked us to organize the CME, so we gave permission to the Asa Hospital when they applied. And luckily, and here the organizing chairman is my teacher, Dr. Gauri Devi Madam. And because of that, I am here. I have to attend the valedictory function. And at the same time, you have seen all these topics. The standards of Gauri Devi Madam will be very high. And you have seen these by selecting the topics. You can understand the capacity of Gauri Devi Madam. I think all the topics for the first year students, it is very difficult to follow. I think for the final years and second years, it's okay. And all the speakers, they did very well. And Madam selected all very nice speakers and they did their job. I think most of the people, you enjoyed the topics and the interaction with the topic speakers. And here the most importantly, the Sun Pharma people were organized very well. And both here in the, by selecting this auditorium and the local, because this is the center of the city. And it is well connected to all the people of city and other states. I think I thank organizers for giving me this opportunity. Thank you, Uday.
Thank you, Ram Subbareddy garu. Gangaram garu, please. Treasurer of South Zone.
I congratulate the ASHA team for this well organizing the program, and 2 days we have enjoyed the academic feast. Thank you.
Thank you, sir. Sai Krishna.
There is a brief message from Dr. V.K. Arvind, who is the chairperson of CME committee. Respected President and office members of IPS South Zone, I am delighted to see a wonderful 2-day topics on PGCME based on the theme comorbidity and psychiatric illness, in which the PGs have learned many clinical aspects apart from their routine teaching in the classroom. I must appreciate Professor Dr. Gauri Devi Madam and Dr. Chaitanya Deepak for an excellent organization skills. I also appreciate the PGs for their active presentation. My humble thanks to my CME committee members and especially to Dr. Sai Krishna for taking the CME to the great success. I thank IPS South Zone, IPS TSB and ASHA Hospital for making me part of this South Zone program. Thank you.
Vishal?
Good evening all. First of all, I would like to congratulate South Zone President-elect Dr. Uday Kumar sir and past President Dr. Kishan sir and South Zone Treasurer Dr. Gangaram sir and IPS TSB past President Dr. Ram Subbareddy sir and Editor Sai Krishna and especially organizing team, organizing Chairman Dr. Gauri Devi Madam and organizing Secretary Chaitanya Deepak and all the team members, especially Ajay Krishna and all the team members, Dr. Amulya. So it's a nice, it was a very wonderful session. So thank you very much for giving this opportunity.
Thank you, Vishal. Madam. Okay. True, man. True. Are they ready, Deepak? Deepak, students are ready? Usually this valedictory function is nothing but to have feedback from yours, we all thought this is the way to be done, how the CME of South Zone of any of kind. We really need your feedback, how it should have been done. I request a few of you, at least 10 of you, please come on to the dais. You can, Deepak, you can. కొడుకు వచ్చినాడా? You can lean them. Yes, kept them ready. Give her a clap.
Good evening to everyone, esteemed doctors and PG students present here. I'm Dr. Navya, first year psychiatry resident from Apollo Jubilee Hills. I just wanted to start off by saying that this is my first PG training program and we had no idea what to expect from it, but the sessions were so succinct and interesting that we were able to follow them really well. The speakers, the chairpersons and the moderators were all very welcoming and we thoroughly enjoyed the interactions. And we were confident enough to voice our questions irrespective of them being stupid or not. And I can confidently say that going forward, we are much more equipped with the knowledge to deal with comorbidities in psychiatric conditions. The quiz was also thoroughly entertaining and offered us a good sampler on the various dimensions of the subject. And I also wanted to add that it was not just the sessions that we got knowledge from, but also the interactions that we got from our fellow PGs and seniors. It truly is a very inviting community and that we are glad to be a part of. So I would like to thank the organizers for providing us with that platform, and we would like to thank the esteemed speakers, chairpersons and moderators for making it such an enlightening session. And I guess I can say that though I do not have a metric for comparison, this does serve as a benchmark for future events to come. Thank you.
Hello all. I am Chandresh from Asha Hospital, final year now. So of course we have been with every step of the organizing team, so we are aware of what we have done. But that apart, coming to the program itself, like you had said, a first year PG may take a different perspective on this. They may get certain pointers on what to ask during their initial assessments that we may usually miss out. Second year, third years will get something else. And I would hope that since these are all been recorded and they're being posted online, sort of revisit this at some other point in your training, rewatch them. At different stages, you would get different perspectives, especially from, like just as an example with Dr. MS Reddy's presentation, right? So first year, you would often hear things like comorbidity of OCD, how do you differentiate OCD with OCPD? But once you start working, you would start seeing these nuances that he mentions. You would start looking at premorbid personalities in the clinic itself. You would start noting this down. And that also has a bearing on the treatment response. Some people may keep telling they're not improving at all. So you need to go back and see, is this because of the premorbid personality? Is the treatment really working? Things like that. There's a lot of nuances from what each of the presenters have shown. And it's worth revisiting, coming back. And I'm not sure if there's a library of these conferences online, at least in the Telangana web, the state branch website. Maybe that could be a library can be created so that even though these are being recorded, so even us, once we pass out, as we are practitioners, as Sir said, we may have a different perspective. We may get more out of this later than we have now. Maybe that would be useful to have a library so that we can revisit all this later.
a good suggestion. We usually keep all these academic events loaded in websites. Every state and then South Zone and then national level also we have a separate websites. All these events with photographs uploaded immediately after the event. So you can go into that and then revisit. Thank you. Anybody from? I would like to hear from voices. Please, please. I need 7 more.
Good afternoon, everyone. I am Dr. Hamza Hussain, second year PG from Institute of Mental Health, Hyderabad. So, to be very truthful, ma'am, when we first saw the topic, like when that brochure came in, we were like comorbidities, okay. So what we thought of comorbidities till now was like diabetes and hypertension. So usually we'll write schizophrenia with DM, schizophrenia with hypertension. That was comorbidity for us. Of course, like our teachers used to say us like many diseases are comorbid or many diseases evolve into many other diseases. But we usually didn't we didn't see into that aspect any time till now. In these 2 years, we didn't actually explore that, okay, people can actually have comorbidities. Actually, these 2 diseases can co-occur. We need to treat 2 diseases rather than just treating one. So that was a limited scope of, that was a limited knowledge we were having about comorbidities till now. And when that topic came in, we were like, कितना बोलेंगे इसके ऊपर, like कितना सीखेंगे और क्या होगा comorbidities के अंदर. That was the reaction we got. And after the first session yesterday, I was like, oh my God, itna sara hota hai comorbidities. And the session was going on one after another, and the models of comorbidities and all came up. My mind was like astonished, like kya chal raha hai, itna sara hota hai kya comorbidities. So that was the reaction which actually came out. So I would like to truly thank all the chairperson and all the organizing committee for like choosing up this topic and showing us how much important it was for psychiatry, and like making such a difficult topic, which was like we were not even imagining that topic aisa kuch topic hoga, and simplifying it in such a way that now we are so confident that if we go and from tomorrow when we are writing our notes, we'll always have this in mind that there can be a comorbidity, and we'll explore in that aspects. So I truly thank all the organizing committee and all the faculty here. Thank you very much.
Very well done. Yeah, I think Fani Prashant's the opening batsman of speaker, I think he made things easy to understand what the real concept of comorbidity is. No, I hope you have enjoyed Fani Prashant's. That has really mind-blowing lecture. It's very much true. I would give it to the owner of this event, Dr. Gauri Devigar. Please, ma'am.
Dr. Uday Kumar, Dr. Kishan, Dr. Gangaram, Dr. Ramasubba Reddy, and Krishna, I will call Sai Krishna, and Dr. Vishal, Dr. Deepak. So he was Saverio. Yeah, I'm very glad that I'm amidst my students and maybe my junior. He's not my student, Uday. He was my junior from Nimans. So I'm glad that most of my students are in fairly good IPS positions, and they're doing wonderful job for the society, IPS, I mean, and also for the PGs and for everybody, especially in the academic cycles. When I was given the task, honestly speaking, I was just wondering why I was given. Because my turn is over. I'm not in the, of course I'm in the academic circles, but anyhow, I said, like always fascinating about psychiatry right from my younger days before I chose psychiatry is this kind of comorbidity, whether it's physical or psychiatric. And I always had the dilemma, and I have gone through ICD 8 and then ICD 9 and then 10 DSM. With all those things, I just wondered sometimes you become lumper, you become, splitter kind of a thing. And especially when you come out of medical colleges and you start practicing, you realize how difficult it is. It's a classificatory system is fine, but when you deal, it will not really, the patients don't follow the classificatory system. They manifest with various symptoms. So that made me think that let me give something different to the PGs. It's not really clinical topic as such. Okay, it is about classificatory system and how there will be overlap and how difficult it is for a psychiatrist to understand. So with that intention, I said, okay, I told Chaitanya and other people that we'll take it up. So, and here I would say that, okay, selecting the topic and selecting the speakers and the chairpersons was my job. But most of it is, I think I need to be humble to say that all my kids from Asha family, I would say, not Asha hospital. We always call Asha family because it's like a group of members who are very close to each other. Chaitanya, Amulya, and Sweta, name anybody. All the people participated so well, Ajay. So I think it is all these people's contribution and their organization skills, which again I'll give weightage to my colleagues, my friends, right from my childhood. Prasad Rao, MS Reddy, Chandrasekhar, they were all my classmates. So I think I really feel that I'm privileged to be among these people. So they taught these people organizing skills. Prasad and then MS Reddy, they've done so many conferences. Our children, they are really good. I'm sorry, I'm calling you children because I still feel your children. But young brigade, I'm sure even if you give a major event, they're capable of doing it. I think, but for them, I don't think I would have done that. I think I did very minimal job and majority of it they have done. I'm very grateful to all of them and I congratulate them. And it's all my, best wishes to all of them who contributed to this. And even the speakers, I chose because during the, COVID, when the conferences are going on, meticulously I sat and heard many of the speakers and all the conferences. Because I make it a point to learn because it's better to listen to people and learn because they go through so much of material and they give me gist. So, that's how I learned that these are the speakers who are very good in these areas. That's how I could choose all these speakers meticulously from all the states of South India, because I don't want to miss out anybody. And similarly, I've chosen the, chairpersons who are also well versed and they're very, they can discuss the things well. So I would give credit to all these speakers and chairpersons who stuck to time and then who gave very good gist of what I really expected. And not the least, I think I would give credit to Sun Pharma, who are always there. They always show interest in, academics. And they just come forward and to do whatever we ask. So that way, I think we are fortunate enough to have the pharma backup of Sun Pharma. And I thank them and I congratulate them that they've been doing wonderful job in this academic arena. And I thank everybody for what all they, if I haven't named, it doesn't mean that I am not acknowledging. I'm very glad and I acknowledge the credit of each and every person who made this program success. Thank you.
I think it is not enough. I think big round of applause again and again. Thank you. I think she needs respect. Again, please. Really wonderful, madam. This shows how you have toiled enough to get this event gone into success. It's really wonderful. Now I request my chief guest, Dr. Kishan Garu, to say a few words.
Sir.
Respected presiding officer of today's valedictory function, Dr. Uday Kumar, President-elect, South Zone, Madam Gauri Devi, organizing chairperson, the teacher of teachers, taken responsibility of organizing committee. She is at patron level. Actually, generally, she is a patron of so many things. But really, a great madam, taking a great responsibility, and that shows your humbleness. And Dr. Gangaram, he is a secret of success of Telangana State Branch Treasury, cost 50 lakhs, and South Zone Treasury. So he has done 2 terms of service since last 4 or 5 years. And Ram Subba Reddy, he has given permission to Ash Hospital to conduct the CME during his presidentship. And here I'm think actually that the South Zone conducts 3 programs: midterm CME, PUCME, and conference as a responsibility, constitutional responsibility. These are given as a rotation, and it is responsibility of all South Zone office bearers to sit. Raghuram Reddy used to sit throughout the program, wherever there. Then I think total EC responsibility is a success, whatever the success. And Telangana State Branch has given opportunity to choose their sponsors. And Telangana State Branch EC as well as they had a responsible role. I think Ram Subba Reddy is doing that job, and I'm able to see Ram Subba Reddy and Sai Krishna and Vishal on behalf of Telangana State Branch. And as well as Sai is representing VK Aravind. Is absent because of his personal reasons, but still he is having sent one wonderful message. And Dr. Vishal, yesterday Dr. Vishal conducted a program with involving South Zone, that is a International Day of Prevention of Drug Abuse. Yeah. So this shows that Telangana State Branch, Dr. Jarji Reddy and Vishal, Dr. Minhaz, Dr. Dinesh of HPS, all came together and involved Dr. Ramana Neras as a chief guest, and a wonderful function within a short notice of time. That shows the Telangana State Branch young leaders' capabilities. I'll come back to that point. Really, it's a success, and today press coverage is wonderful about that program. So coming to a little, I want to come to the theme of today's theme. There's a lot of discussions happening about theme and topics. Always, Gauri Devi Madam is a model teacher, and I will tell my lady PGs, you should model Dr. Gauri Devi Madam. You should evolve like Gauri Devi. I think I'm able to see Dr. Sri Lakshmi, Dr. Preeti, and Dr. Shweta Reddy. These are all growing like Madam. I think they will carry your message forward. And the boldness of talk, especially in sensitive areas of teaching, their boldness and crisp, and I think I'm able to see a lot of here. Please, all female PGs, take Madam as a model. And I think in selection of theme also, Madam is a little bit special, and I think I'll come back. Why it is, my interpretation is something different about, because yesterday a lot of discussion happened in EC, in faculty meeting. Actually, what is happening in Telangana State Branch as well as South Zone in last 1 decade. So Telangana State Branch, as you know, is the youngest state branch of South Zone. Now we grown to, our treasuries crossed 50 lakhs within 8 years, 7 years, I think. We are from Telangana State Branch. We instituted Shatavana PG Poster Award in South Zone. And now the AGB of South Zone approved the Dr. P. Raghuram Reddy Research Fund, that is 10 lakhs. that is 10 lakhs research fund is approved, and next year we're going to have two events. One is the Raghuram Reddy best research published paper on the floor. First paper, second paper, three best papers they select, and remaining amount, the interest amount will go to the best research protocol. And the awards committee finalize the things what to do. And here I think all our Telugu people I'm able to see here. If you see the South Zone, Jaya Nagaraja Award, Quiz Prize, DS Raju Memorial Oration, and Vishaka Oration, lot of South Zone, whatever instituted by Telugu states, and the Telangana state branch also is doing wonderful job in that. One more point I want to add here, and that is again, I will connect to the theme. So now, actually, yesterday we discussed about the thing, we finalized almost. I think it has to be formally finalized in the EC of IMH alumni. We are also, there is already fund collection is over, instituting IMH alumni teachers fund for research. Every year we want to select a best protocol, research protocol from IMH alumni annually, and that also one thing. And one more thing in the EC, there's already discussion started. Probably by next AGB, out of 50 lakhs, 10 lakhs will be a research fund. Whatever the interest comes from 10 lakhs, we are keeping in everything in the bank at FDs, but we are not utilizing it. So 10 lakhs research fund will be there. The interest will not waste the amount of state branch, but only whatever the interest part of the 10 lakhs will go to the research Telangana State Branch Research Fund. So why I am telling all these things are, so now Gauridevi Madam, whatever the faculty used to have in IMH, at that time psychiatrists are very less. Even choosing psychiatry, DPM, everybody used to change and they disappear. 50% DPMs will disappear, even sometimes 80%, 75% DPM students in the first year itself, they go to other PGs, discontinuing. But now, 90 PGs are coming out every year in Telangana. That was and they are taking as a choice. By chance, the psychiatrists used to, that is our generation. So the present generation, why I am telling is, some of the section of postgraduates should choose the research as a career. Our time is how to make students better psychiatrists, formatting them within 3 years, ICD, DSM, how to diagnose the cases, how to treat bipolar, how to treat schizophrenia, how to treat this thing. That is over. We are all now, yesterday you have seen Asha Hospital, RTMS. You can survive, you can earn a lot of money. In psychiatry also, there are services. We are now in the work of how to improve the rehabilitation services, therapy centers, behavioral therapy centers, and even drug abuse section only. So a lot of specialty wings are coming, subspecialty wings coming, and we are planning about your future settlement. So it is going to expand. And, every psychiatrist will survive in a better way with equal to earning, especially in earning as well as the self-respect. So along with this, I'm requesting a section of postgraduates to choose who came from the well-established good families, reasonably rich families. Better to choose psychiatry as a research. And I think last 2 days, I'm observing, lot of gray areas are there. Lot of research, fill in the blanks are there. These are the points to be researched well, and that's why we are putting research funds. Lot of funding agencies should come out. Why we are lagging behind? Why still we are reading the CTP Comprehensive Textbook of Psychiatry of America, European? Why not Indian? We should have an Indian textbook of psychiatry that is under IPS. So that is the plan, and we should have our own researchers future. And a lot of research, the yoga and other things are going on. So we should come up with our own studies and our data, we should have our own data, epidemiological, so a lot of things to be done. I think IPS, Telangana State Branch, and as well as South Zone is doing wonderful job to shape your future. I think this is the Gauradevi Madam choose because now today she raised the bar of PGCMEs, and I think nobody can beat. No, not only routine topics. We are having in 3 years of post graduation, 3 PGCMEs of state, 3 PGCMEs of the South Zone. So that may not be routine monotonous. One CME, we can take a chance of stimulating something open-ended research ideas should come up, and gray areas, whatever the theme is like that. And I think I got a lot of ideas as a professor. So these areas to be explored and should be researched. So these are the things with these few comments. Congratulations, madam. You again become very active, and we want to see you very healthy and prosperous, and guide the IPS Telangana State Branch and South Zone. And I think that is why Asha Group selected Gauradevi Madam as the chairperson to make her more active. She's always active since the beginning. She was teacher, but now we are able to see sitting continuously since last 2 days. And thank you, Madam, for taking responsibility of a chairperson. And that shows your humbleness. Raghuram has taken responsibility in as a president of Telangana State Branch. He was already national figure, because he has given prana pratishtha to Telangana State Branch. Sometimes elders has to take responsibility to guide the better programs and better leadership of young generation. With this few remarks, thank you very much for giving opportunities to South Zone. Uday is a person of, is a work, he has conducted a lot of CMEs. Nellore is from Nellore. He is known about his hospitality, CMEs, conferences, and he's serving United Andhra Pradesh. He was president of United Andhra, as well as his various capacities serving IPS. I think South Zone has got now, South Zone started not only research capacity, especially even research. One point I forgotten. South Zone started from Shaji. Shaji was the president of South Zone almost 10 years back. There, the research capacity building effort started. During TP Sudhakar and Jagadish period, it was taken a momentum of the committee. And during my period, already we started funding, how to pump the funding to the journal as well as the RCBC, research capacity building. One course is already over. Second course is started only 1 week back. Try to utilize the training. We are giving training how to do research, and we are developing funding agencies. And South Zone has taken responsibility in publishing update, psychiatric update from the, like North American clinics. No, why not from India? That is, Ramakrishna has taken the task. And South Zone is having its own office now at Trichy. And IPS Telangana State Branch is having its own office in IMH Hyderabad. So these are the growth of Telangana State Branch as well as South Zone growth in organizational matters. And I think we need young leaders now. Of course, in between Gauradevi Madam and between you. And this IPS, whatever the foundation given by our elders, should be carried forward. I think Uday will take over. Last year, South Zone got the best zonal award during my tenure. After that, even Ramakrishnan, after me, Ramakrishnan also has the best zonal South Zone award. I think everything, this grade goes to the secretaries. During my Abhay was the secretary. Now Suresh has done wonderful job in recording. Whatever you do, you have to record it. Yesterday, please, Vishal, you record whatever that is submitted to the national IPS. And Telangana State Branch got best branch award in the national level. So these are the things our young leaders are taking up, and I think we are guiding them properly in a proper way. Thank you. Thank you, Uday ji. And I think we are going to see a new South Zone for next 1.5 years under your leadership. Thank you very much.
Wonderful, Kishan garu. I would like to tell you about Dr. Kishan Garu. We all believe, forever we believe, that he is a divine person, because he is the one who has, as an instrument, worked towards to establish whole Telangana Psychiatric Society, maintained and then gone into level that to get a national award very soon within 7 years. Whereas in Indian states, I think nobody had got within 7 years reached such a level is just because of Dr. Kishan. Because I've been following him, even whatever he said, so many awards instilled in South Zone, all of them, 90% of them are instituted by him. So I think nobody, you take money and then enjoy the money for yourself, but he thinks that teachers are divine persons like gods, given respect, and then on their teacher's name, he has instituted all these awards. Dr. P. Raghuram Reddy, Raghuram Reddy, Raghuram Reddy. I think he is the best student and the best model of a person towards you to interact and then get stimulated to take inputs from him. I think hats off. I think he needs great applause from you guys.
So one thing is certain, he created new trend by establishing the awards on the name of his teachers. That is the great thing by Dr. Kishan.
True, sir. I think very nice, very humble, very quiet. We have a lot of interactions, but there were only few sounds. Okay, sir. Okay, sir. That's all. He's none other than Dr. Deepak, who has really toiled enough to get this event a big success. I think Deepak, you should say, I think second owner of this event.
Thank you, sir. I would like to thank South Zone for giving us this opportunity, and also the Telangana State Branch for supporting us throughout this. All my teachers and mentors and my colleagues who have been supporting me throughout this, and all the delegates who have been patiently listening to us. Thank you.
Chaitanya Deepak has taken responsibility of conducting Telangana State Branch conference recently. You are the organizing secretary, and this is the second event at South Zone level. I think he will grow. I think very silently and well organized, and one is his humbleness. Certainly, I think he is expected. I think his leadership is necessary for future IPS. Thank you.
Thank you, everyone. Now we will be announcing the winners of Best Free Paper, Best Poster and Quiz. So the winners of Best Free Paper, first prize goes to Dr. J. Shweta. I would like our chief guest and Uday sir to please give prize to our winner.
Dr. Kishan Garu, Gauridev Madam, and Ram Subbareddy Garu, Gangaram.
Very proud. See your student.
Second prize for free paper for paper presentation is Dr. Alia Farheen.
Actually,
Winners of winners of poster presentation. First prize is for Dr. Vidyashri J. She has already left. Second prize goes to Dr. Madan Vamshi. Madhu Vamshi, sorry.
Congratulations.
Winners of quiz. First prize goes to Dr. Hari Krishan, Ativ Chandane, Mamatani. Which winners?
Satish Jana Pramod Dunda. So you will
Mamtani. First runner-up is Uma Maheshwari, Hamza Hussain, IMH Hyderabad. Second runner-up, Anantapur Medical College team, Neha and Maravika. I'm sorry if I'm taking the name wrong. Monica, Anantapur Medical College, Monica and Neha.
Congratulations.
We would like to thank whole Sun Pharma team. I would like to request Mr. Satish, Ramakrishna and whole team to please come ahead and accept our token of thanks.
Yes.
Good evening. We have come to the end of this event, and we thank IPS South Zone for giving us an opportunity to be associated this year as well. I think it's been almost like what I said told, it's more than 20 years we have been associated with this event. Before even we all started our careers, Sun Pharma has been doing this program, and always we enjoy actually doing the PGCMEs. In fact, this PGCME has set so many examples as well. If I am not wrong, sir, in 2020, Kishan sir were president, and during that time the pandemic was there, and there was no possibility for the physical meeting as well. Even during that time as well, we have not stopped. Kishan sir traveled all the way from Telangana to, Hyderabad, Karimnagar to Vijayawada, and that's the first virtual conference in psychiatry in whole India we have conducted. Correct, sir? Yeah, that's how the South Zone sets the standard for the PGCME, and we are always lucky, like among all the zonal branches of India, South Zone always stands apart actually in terms of having a distinction, being conducting beautiful academic events actually. Even the chosen topic for this time and the chosen theme for this time itself is an exemplary one, and I thank. And it won't be fair enough if I won't acknowledge for selecting this venue. We were having a little difficulties because after the pandemic, the dynamics have changed totally, and we were not getting the venues like earlier. And during that time, whatever happens, we go to the seniors, and then that time actually we touched Dr. Gauri Deva Madam and Dr. Surya Prakash Rao sir. They helped us finalize the venue with saying that nothing will happen. We do have ways and means to do it, and we worked out all the possibilities, and we landed up here. And I represent Sun CNS, all 5 CNS divisions of Sun Pharma. Even though I did not do the groundwork, my colleagues Satish, Rajesh, Surya, and others have done exemplary work, and always we work as a team to execute any of the events. Just for the sake of convenience, few of us will be in the front end, but there would be a lot of work going behind any of the events which we do academically, especially not just the team here, even because now this event is comprising of 5 states actually. All our colleagues who have been there working in the other states also have helped us do all these things, because the speakers and other logistic things. Thank you very much. Thanks a lot, sir. Uday sir, thank you very much for acknowledging us as well. And in your leadership in the upcoming South Zone event as well, definitely I'm sure we'll do much, much better, sir. Thanks a lot. Thank you very much for all for attending. Thanks.
Now we would like to appreciate the work of our organizing team. I would like to call upon members of our organizing team, starting from our junior most members, Dr. Sohini. She's our first year DNB resident. Dr. Niharika. Dr. Satish. Dr. Chandresh. All the technical responsibilities has been very well managed by Dr. Chandresh. Dr. Madiha. She's our final year DNB resident. Dr. Amulya. Dr. Siddharth. So the wonderful food we had and the menu, everything was being looked after by Dr. Siddharth and Dr. Ajay Krishna. Our quiz master, Dr. Karthik. He also gave a wonderful demo of RTMS, live demo of RTMS. Dr. Shweta. Dr. Chaitanya Deepak sir. I'll come. Dr. Chaitanya sir. And myself, Dr. Sahib. Dr. Chaitanya sir. Gauri ma'am. Some more members from our organizing committee who have contributed, they are not present today. I would like to take their name, Dr. Pratyusha, Dr. Mrudula and Dr. Surekha. Now we would like to thank our audiovisual and technical team, Purushottam and Ram Reddy ji, please come to the dais. So without your efforts and support, the conference is not possible. Yes. Now, I would request Dr. Gauri Devi to felicitate, Dr. Gauri Devi and Uday Kumar sir to felicitate our chief guest, Dr. Kishan sir. Thank you, everyone. Now I request everyone to stand for national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, everyone.